nothing can be better to talk about the molecule which has been the oldest in the management of diabetes after the insulin. Is there a current place for sulfonylureas in diabetes management? Whenever a new thing comes, we always think that probably the older is not so much required. This is a thing which always seen in this world in all kind of the situations and all kind of the fields. If we look back over the history of sulfonylurea, it has been invented in 1946. And after the invention, it has reigned over the diabetes management world at least for the 40 years. It has been discovered even before metformin. The metformin, as it is being prescribed to each and every patient of the diabetes, the same situation and same status has been enjoyed by the sulfonylurea after its discovery for 30-40 years. When the metformin has taken over in 1993 and onward, after the so many other guidelines have given the metformin this status. So let's come over to the classification of sulfonylurea, which is being provided nowadays by number of organizations, especially the Southeast Asia Federation of Diabetes and Endocrinology. What it says that conventional sulfonylureas like glipizide and glibenclamide are another class, and now modern sulfonylurea can be kept in a different class, that is the glipizide, modified release and extended release, and gliclazide. As far as the efficacy and safety of the sulfonylureas are concerned, and it compared with the other available oral anti-diabetic agents, those who are said the modern anti-diabetic agent, we always find the sulfonylurea at the highest efficacy level. It is the medicine which is having the capability of highest HbA1c reduction after the insulin. Risk of hypoglycemia is moderate with a weight gain potential, but CV safety and is neutral and with the lowest cost. Sulfonylureas are efficacious with low to moderate risk of the hypoglycemia compared to other oral anti-diabetic agents. But there are certain concerns which are raised for sulfonylurea. As you all know that many people say that it is cardiovascular neutral, so many adverse cardiovascular outcomes may come up while using the sulfonylurea. Hypoglycemia and weight gain has been implicated. It's traditional adverse outcomes which are supposed to be with their other key consideration while choosing an oral anti-diabetic always remain there, the efficacy, durability, and cost. And I think all these three considerations, sulfonylurea keeps its place on the number one. Let's start with the UKPDS, the evidence in favor of the sulfonylurea. It's very easily understandable through the UKPDS to say that intensive glucose therapy with sulfonylurea has demonstrated reduction in the risk of microvascular complications in that era. And in fact, that era was in which the sulfonylurea was being used like left and right in each and every patient of the type 2 diabetes. But very important thing, what we realized later after 10 years in the follow-up study of the UKPDS, that it was the medication behind the good results of the UKPDS, which not only worked to risk reduction of any diabetes-related endpoints, but even after 10 years of the study terminated, even after the 10 years the interventions has been stopped, it has been maintained up to the 9% of diabetes-related endpoint risk reduction. As far as the microvascular complications and macrovascular complications are concerned, especially the myocardial infarction, we could see that no change had occurred in next 10 years, even the interventions were not continued with the UKPDS. Even the interventions which has been done in the UKPDS trial were stopped then, but after 10 years of the stopping them, the benefits were continuing, and this has been called as the metabolic legacy of sulfonylurea. The advanced trial, which has been a very important trial and has been done to assess the effect of blood pressure lowering on macrovascular and microvascular outcomes in patients with type 2 diabetes. It has included 11,140 patients to see the microvascular outcome in the form of the non-fatal stroke, non-fatal MI, death from cardiovascular cause, including the sudden death, and microvascular outcome in the form of the new development of the nephropathy or worsening of the nephropathy and diabetic eye disease or retinopathy. In this trial, we could see that intensive control achieved target of the HbA1c 6.5%, resulted in 10% reduction in combined macro and microvascular complications at the 5 years follow-up. So this was again a very good result coming from the advanced trial in favor of sulfonylurea, endorsing the findings given by the Wikipedia. As far as the renal outcomes are concerned, this advanced trial has given us the idea that intensive glucose control strategically lowered HbA1c to 6.5%, resulting in 11% reduction in total renal events, which lead to 21% reduction in nephropathy. So as far as the renal outcome is concerned, we could see the reduction of the overall outcome, overall renal events with new microalbuminuria reduction, as well as few people have could change from microalbuminuria to macroalbuminuria. So the worsening of the nephropathy has also been lesser with the users of sulfonylurea who targeted HbA1c in the intensive glucose management. Reduction in end-stage renal disease and remission to normalization both have been seen to be achieved in this advanced trial through the intensive glucose control, which has been seen to be translated into 20% reversal to the normal albuminuria and 65% reduction in the risk of end-stage renal disease. Advance on, it was a follow-up study of the advanced trials. And in this follow-up study, not only we could see that reduction in overall end-stage renal disease occurrence, but also reduction in the end-stage renal disease occurrence in the patient, those who are already suffering with the chronic kidney disease. So intensive glucose control provided significant, that was a 46% reduction in the end-stage renal disease, including the patient getting the dialysis and transplantation after 10 years. But these benefits were greater for the preserved kidney function, means those who were normal kidney having, and they have been found to be much benefited with the use of this intensive glucose control using sulfonylurea. TOSCA-IT, this was another trial which has focused on the long-term CV safety of sulfonylurea. And factually, this was the trial which has given us inference that incidence of the cardiovascular events was similar in patients treated with sulfonylurea, mostly those who have been using the glimepiride and viclazide, to those who have been treated with the pioglitazone as an add-on treatment to the metformin. Let's talk about the Carolina study. And Carolina study is study of recent days, and it has really re-established the sulfonylurea. It has given the glory of the sulfonylurea back again. So this was a trial which has been done to produce the definitive evidence-based data on the cardiovascular and hypoglycemia safety, on the efficacy of linagliptin, which has been compared with the efficacy of the glimepiride, as an add-on to the metformin early type 2 diabetes at increased cardiovascular risk or established CV complication. This was a multicentric randomized double-blind active control trial in which the primary outcome was the 3P MACE and the secondary outcome was the 4P MACE, in which the occurrence of hospitalization due to unstable angina has also been included, and safety outcome in the form of the hypoglycemia has also been studied. And in this Carolina study, what we could see that linagliptin was almost similar to the glimepiride in time to first occurrence of the cardiovascular death, non-fatal MI or non-fatal stroke, 3P MACE. A reduction in risk was similar for 3P MACE and 3P MACE with hospitalization for unstable angina for linagliptin when it has been compared with the glimepiride. So we could see that both the drugs were almost at par, whether it is the complications are occurring in the form of the 3P or 4P. Carolina study in which we could see the incidence of hypoglycemia was definitely more with the glimepiride as compared to the linagliptin. Carolina trials reassures on the body weight neutrality with sulfonylurea. It has been believed since a long time that sulfonylurea means the potential to weight gain. But in this particular trial, we could see that those in the glimepiride group initially gained about 0.6 kg in weight, while the linagliptin group lost about 1 kg. By the end of the trial, both the drug groups lost weight from baseline. The glimepiride group weighed about 1.5 kg more than the linagliptin participants over 6 years. So in nutshell, at the end of the study, we found that people, those who used glimepiride, initially they gained weight, but for the long-term use, the weight gain was not remained any concern with the use of sulfonylurea, especially the glimepiride. Trial reassures on the cardiovascular safety of the modern sulfonylurea, also in the form of the glimepiride uses. There was no significant difference in occurrence of 3P MACE in patients treated with glimepiride as compared to those treated with linagliptin. Now, question arises: can these results of the Carolina be applied to other sulfonylureas or not? If we talk about the Danish registry, in which the comparing of the sulfonylurea has been done regarding the previous MI, in which the more than 1 lakh patient has been initiated with single agent treatment with sulfonylurea added up or with the metformin. In 9-year registry it was, in which gliclazide was found to be associated with significantly lower cardiovascular risk than other sulfonylurea for all kind of the comparison, may it be the all-cause mortality, CV mortality, MI, stroke, and cardiovascular mortality. If we go into the meta-analysis in which all-cause mortality and CV mortality with the sulfonylurea has been compared, we can see that all-cause mortality and cardiovascular mortality were significantly low with modern sulfonylurea like glimepiride and gliclazide as compared to the sulfonylurea, which were the conventional. If we talk about the hypoglycemia again, while comparing among the sulfonylurea which are already being used, gliclazide was associated with the lowest risk of the hypoglycemia, followed by the glimepiride, which was as compared to the other sulfonylurea. Weight gain with sulfonylurea has always been a concern, as I already said in my few of the previous slides. UKPDS has said that weight gain during first year of the therapy was stabilized by 3 to 4 years. Accord has reached to the inference that weight gain of more than 10 kg were more frequent in the intensive therapy compared to the standard therapy at 3.5 years of follow-up. VADT said that weight were significantly greater in the intensive arm as compared to the other arm, especially when the rosiglitazone and metformin has been used in the 5-year follow-up. Advanced trial has shown the overall weight gain was negligible, 0.1 kg with intensive therapy of the gliclazide modified release over 5 years of the follow-up. And instead, a small mean weight loss of the 0.5 kg was observed in obese patients in the advanced trial, those who were having the BMI 30 or more than 30. So weight neutral over the 5 years has also been found to be negated by another study which has been published in 2016 in a Journal of the Diabetes, Obesity and Metabolism. No significant difference in weight in metformin together with the glimepiride. The study said that if sulfonylurea, especially the glimepiride, is combined with the metformin, strict glycemic control can be maintained in a real life setting without relevant weight changes. So combining with the metformin always helps sulfonylurea in maintaining the weight as well as reducing the hypoglycemia. Durability with the sulfonylurea, we talk about, this is the molecule which has proved its worth in the longest time in the world. And this is the molecule where the patient has completed even their life of 40, 50 years using this molecule without getting failed. Linagliptin, which is the representative of the present day DPP-4 inhibitor, was non-inferior to the glimepiride in lowering HbA1c. However, reduction in the HbA1c was significantly greater with glimepiride comparing with the linagliptin. Again, if we talk about the durability among the sulfonylurea, we find that patients treated with the gliclazide have low rates of the secondary failure compared to sulfonylurea. So message has already been passed by the UKPDS follow-up study and later on the advanced follow-up study that patients, those who are being kept on the sulfonylurea, those who have reached to the target HbA1c while using the sulfonylurea in their early days of life, they kept on controlled glucose level, they kept on controlled glycemic status even after the intensive use of the or intensive lowering of the glucose has not been followed in the later life. You know about the cost effectiveness. I think it is needless to emphasize the Indian audience that cost effectiveness of the sulfonylurea, we understand this is the molecule which is having the least economic burden over the users. Let's talk about the benefits in a special population. Elderly population, people in the Ramadan and chronic kidney disease patient. If we talk about the sulfonylurea in the elderly, we know that these molecules have been found to be the very easy to use by the people, those who are of the elderly age. And although there is some potential of the hypoglycemia and glimepiride, but it has been seen that if we use the modified release, it is almost remain free from the hypoglycemia kind of a thing with good glycemic control achieved in the elderly age group. Flexibility with the sulfonylureas remain in the Ramadan also, which is the maximum with the gliclazide that was almost equivalent to the CPP4 inhibitor available, but with the more glycemic efficacy followed by the glimepiride. So sulfonylurea stands strong as the second line therapy after the metformin is still nowadays. And together with using metformin, it gives additional advantage that it is weight gain is negated. Hypoglycemia incidence has also been found to be lesser when it has been used with the metformin, and efficacy standard has also been improved. The second line agents for the glycemic control for type 2 diabetes is definitely the older wine is better as compared to the newer available molecules presented. So summarizing the talk, availability of the new drug classes has sparked a debate regarding utility and viability of sulfonylurea as a therapeutic option with views on cardiovascular risk and hypoglycemia. However, this may hold true for older sulfonylurea due to their non-selective mechanisms of action. The development of the modern sulfonylureas that do not block ischemic preconditioning has rendered the UGTP controversy moot and preserved a place for sulfonylurea in the treatment of type 2 diabetes. The modern sulfonylureas are proven to be effective, safe, and well tolerated in various clinical situations. And sulfonylureas are also reported as the most cost-effective therapy compared to other oral anti-diabetic agents. And renaissance of the sulfonylurea therapy might ensure that it remains the drug of choice for uncontrolled diabetes in the future with enough room for flexibility. So still we can say that use of the sulfonylurea is much more relevant in the present days as compared to the newer molecule which has been recently acquired and recently achieved by us as far as the glycemic efficacy and safety is concerned. Thank you very much for the kind listening.
Thank you so much, Dr. Mukherjee. It was an extraordinary batting from the day one and day one inaugural session. So extraordinary presentation with the nutshell of sulfonylureas, where to use, where not to. And you know that, and everybody in India is also knowing this is the garibo ka belly jo bolte hain, because it is like that. So sulfonylureas are having their efficacy, but keeping in the mind the hypoglycemic condition, weight gain, and with the combination of a few medicines with even just like insulin or something. So we are watchful about the sulfonylurea. Till date in our country or all the developing countries and underdeveloped countries, this is a definitely drug of choice. And in any international or national guidelines, you can see that what is the use of the sulfonylurea everywhere. The mentioning of the sulfonylurea there. So you have at least delivered a very good lecture, and thank you so much for this extraordinary presentation. Again.
Thank you. Thank you.
So indeed, pleasure always to listen, Anuj sir, and you always learn one or two new points in your practice. Thank you. Thank you so much, sir. With that, let's move to the another talk again by Dr. J.J. Mukherjee, sir. I would like Dr. V.N. Shah, sir, to introduce Dr. Mukherjee, sir.
Dr. Mukherjee is always known to everyone, those who are practicing diabetology and endocrinology. He is a very senior consultant in medicine department of diabetes and endocrinology, Apollo Multi-Speciality Hospital, Kolkata. Endocrine training at St. Bartholomew Hospital, London. He was a senior consultant at National University Hospital, Singapore. Recipient of the post-SEM GP Moses Oration Award, RSSDI 2020. 60 publication in high-impact peer reviews, journals like Lancet, Endo, GCEM, Clean Endo, BMJ, Radiology, Thyroid Diabetes Medicine. He is having the 20 chapters in various textbooks, including Thyroid Homeostasis in Oxford Desk References. So a lot of things about him, everybody is knowing. And I don't know to take at least more time out of your, in between the speaker and our audience. So I'm requesting Dr. J.J. Mukherjee to give his presentation on positioning of the SGLT2 plus DPP4 inhibition combination in PIL in the management of type 2 diabetes. Thank you so much.
Thank you, Dr. Shah. Good morning to you and to Vipul. I would like to, can I share my screen now? Yes, I can. I hope my slides are now visible, full screen. Can somebody please confirm that?
Yeah, they are visible, sir.
Yes, and it's moving, right?
Yes, sir.
Okay. So first of all, my thanks to Dr. Bansi Sabu and Team RSSDI for giving me this opportunity for being in the inaugural symposium. Thanks to Anuj for taking some of the moisture of the wicket, because it's always very scary to face the first 3-4 overs. So he has taken that moisture away. So I can now come in as 1 down to bat, and Professor Ramachandran can come as 2 down. The topic is very interesting. Position of an SGLT2-DP4 combination pill in the management of a person with type 2 diabetes. Very nicely designed program, I must say, Dr. Bansi Sabu, because they are inaugurating with combination therapy, and I can see today's ending is with combination therapy, and the person I'm going to quote quite often during my talk is going to give that talk. So I will be also eagerly looking forward today evening to listen to combination therapy is the way to go forward in managing type 2 diabetes. Anuj did mention a lot about sulfonylurea. Dr. Shah, you gave me credit for that. I do not deserve that credit. That Anuj gave that talk. And as you will see as I speak on, I would rather use sulfonylurea quite low down in my list of medications used for type 2 diabetes, unless and until, of course, cost is an issue, which you very rightly mentioned. If cost is an issue, then DPP4 SGLT2 inhibitors become a little bit of an issue. This is very well known fact that if you get 1%, a very dated slide, if you reduce HbA1c by 1%, this is epidemiological assessment of the UK PTS data, you reduce all sorts of complications, micro and macrovascular complications by a significant proportion. Despite that, despite having this knowledge for the last so many years, my friends who have joined me today, we are not performing well. This is the ongoing trial, if you can see, Discover Study program. What does it say? Only 17% achieve HbA1c target of less than 7%. Why is this so? UK PDS was published way back in 1997. The follow-up study was published in 2007. And even now in 2022, we can't even get our people to target. There are many reasons. I can hear you say patient not listening, patient not controlling diet, patient not exercising, drug not available. I can hear all of that. But there has to be some inherent defect in the way we treat type 2 diabetes. We don't have this problem with lipid management. Patient is not having his biryani, that is having his parathas, and still your LDL cholesterol is very nicely controlled. So there is some issue with the medication as well. Before we start waving of N+1 other factors, let's see that maybe the algorithms we are using, the medications we are using to control diabetes are not right. And this is what I firmly believe in. This is what Professor Ralph DeFranco is going to speak today evening. We are not doing it right. Even in the 2018 ADA ESD guideline, they still support stepwise therapy. I'm glad that in the 2019 update, they added you can use combination therapy if your HbA1c is more than 1.5%, and ADA standards of care has also incorporated that. I firmly believe that we should be treating diabetes based on pathophysiology. This was the pathophysiology when I was a student. There were only 3 defects: increased hepatic glucose output, decreased insulin secretion because of beta cell failure, and decreased peripheral glucose utilization because of insulin resistance. Professor D. Fronzo in his lecture gave us 8 defects. People want to add some more. I mean, those are not that strong, but these 8 are probably quite strong pathophysiological defects in type 2 diabetes. I'll be coming to it when I discuss the combination therapy. And prior to ADA ESD 2019 update and ADA standards of care accepting combination therapy, there are a few studies which have shown that if you start with combination therapy, you do better than going stepwise therapy. This is Professor Ralph DeFronzo's EDICT study. This was over 2 years. They used metformin, then stepwise sulfonylurea as advised by the guidelines, and then insulin glargine, 150 patients, a randomized controlled trial. And on the other arm was metformin, a thiazolidinedione, and a GLP-1 receptor agonist. Exenatide was easily available then. That was the one that was used. So this is the conventional therapy, and lower down is the triple therapy. You see the reduction in HbA1c, which is statistically significant over 2 years of time. And this was with lower hypoglycemia. I'm not showing those slides. And low weight gain. People said this 5 liters zone, there'll be more weight gain, but remember there's GLP-1 receptor agonist also. In the combination therapy, you see there's no sulfonylurea. This is a small study that we did. We got it published in Diabetes Medicine, where we also started people with new onset type 2 diabetes coming with an HbA1c more than 9%. We gave them a combination therapy of metformin, thiazolidinedione, and as Dr. Shah was mentioning, we are a cost-conscious country, so they could not afford GLP-1. We can't give consecutive patients GLP-1. Some people will refuse. So we chose the second best in Britain, which was a DPP-4 inhibitor. And these people, because they came with an HbA1c of more than 9% and a fasting was more than 250, they all got a 2 to 4 week duration of insulin. So this combination therapy got them into goal. Their baseline HbA1c average was 11%. They came down to 6.5% within 3 months, which was maintained over 6 months. And this, ladies and gentlemen, I'm very happy to see that in the 2019 update of the AD-ESD 2018 consensus statement, they now say that if HbA1c is more than 1.5%, start combination therapy. I, for one, still disagree with that. I would still say if HbA1c is not more than 1.5% above, but you have reasons to add an SGLT2 or a GLP-1, please go ahead and add. There you're not treating glycemia, but you're protecting the organs. We'll come to it later on. These are the various agents you have to treat type 2 diabetes. Of these, metformin, sulfonylurea, glenides, TZD, GLP-1, alpha glucosidase inhibitors, insulin, DPP-4 inhibitors are easily available to us. Amylin mimetics, bile acid sequestration, dopamine should not be used, and glenides we don't use often. So we have to play around with these 8 molecules when we are designing our combination therapy. Dr. Aruj mentioned in great detail about using metformin and sulfonylurea. Certainly, yes, if cost is an issue, but they're powerful, as you rightly mentioned. I accept that. But that's all you get with them. They do have a risk of hypoglycemia. You can't get away by saying that sulfonylurea does not cause hypoglycemia, no matter how much of advanced data you show me and how much of UKPDS data you show me. All of us who are using sulfonylurea do know that cause hypoglycemia. But yes, second generation cause much less than the first generation. Now, if you're using a combination of metformin, DPP-4, and SGLT2, sorry, I went a bit too fast. Now, if you take this ellipse, it's metformin plus DPP-4. You will get HbA1c reduction, not as powerful as sulfonylurea, but of course, risk of hypoglycemia is low. But you do not cover these 2 quadrants. So this is the holistic management of type 2 diabetes. You want glycemic control, you want low risk of hypoglycemia, you do not want weight gain, and you want to protect your organs. Now, you will hear a lot about this throughout the Diabetes India for the next 2-3 days about how diabetes treatment has changed from glycemic control to organ protection. So if you're using metformin, SGLT2, DPP-4, or metformin, SGLT2, or a GLP-1, if affordability is there, most people can't afford it, then you're covering all 4 quadrants. You could use metformin, DPP-4, pioglitazone, yes, but then there's a weight gain issue. You could use alpha glucosidase inhibitors, but then the powerful, they're not very powerful. They're weight neutral, they're cardiovascular neutral, so you do not get those advantages which you get with this combination. So if you see, the best combination to use would be metformin, SGLT2, and an incretin. Affordability is there, GLP-1, affordability is not there, SGLT2 plus. Not only affordability, there are certain things which will bring in an SGLT2 much ahead of a GLP-1, like underlying heart failure, underlying renal dysfunction. So if you now combine a DPP-4 and an SGLT2 inhibitor, you find that they are complementary. The HbA1c reduction is better. The glucagon effect, one making it go up, one making it go down, gets cancelled. And all the good things of SGLT2 inhibitor, cardiovascular protection, etc., are maintained. Weight loss is maintained. As you can see, they are taking care of 6 of the 8 pathophysiological defects now. If you're using metformin has to be on board. Metformin taking care of increased hepatic glucose output, then glucagon secretion, insulin secretion, incretin effect, glucose absorption, decreased glucose output, all of them is being taken care of. So if you use them in combination, these slides you must have seen many times on drug-naive patients or metformin background patients. Almost 60% of people achieve HbA1c of less than 7%, and in metformin background, 3 to 5 times more likely to get HbA1c under control. Body weight reduction, BP reduction, uric acid reduction, which you see with SGLT2 inhibitor, that is also maintained when you're combining it with a linagliptin in this combination, EMPA and lina. Hypoglycemia, it's not zero. As you can see, about 1 to 2% patients do get it, but it is not raised when you're combining empagliflozin with linagliptin. And this is the initial added benefit that you get. People didn't know it, but they found it that we are combining a DPP4 with an SGLT2. There is a reduction in GTI. You can share your experience. This is a randomized controlled trial data. Now, if you see, we know this is all old hat. If you use an SGLT2 inhibitor, you get all these kinds of benefit. Amongst the 4 SGLT2 inhibitors, the ER2 is not available to us. So we have EMPA, CANA, and DAPA. If you see the all green boxes are 3P MACE, CV death, HHF, all-cause mortality, renal endpoints are green with empagliflozin. Canvas program, you get 3P MACE benefit, did not get CV death benefit. HHF, yes. All-cause mortality, no. Renal endpoints, yes. Declare to me different population. You can't compare them head to head because the population was different. Only 40% had risk factors. But so they did not get the 3P MACE cardiovascular death benefit, but they got HHF benefit and renal endpoints. Ertugliflozin, I will not go because that's not what we have. With empagliflozin and with dapagliflozin, you have added benefit of heart failure benefit, either with reduced ejection fraction or with preserved ejection fraction. I'm not going to details. I'm just showing you the headlines because you will be hearing about this in great detail in the next 2-3 days. People will be talking only on Emperor Preserve for 40 minutes. So I'm not going into detail. Don't read the results here. They will be discussing great detail. All I'm saying is DPP4 inhibitor plus SGLT2 inhibitor. When you combine SGLT2 with DPP4, it not lose the benefits of SGLT2 in heart failure. Kidney, this is where SGLT2 scores over GLP-1. If you see, initially was Credence trial, which included all diabetes patients with a GFR above 30 with macroalbuminuria. Then you have DAPA-CKD, which included people with GFR 25-75 with USCR of more than 200. And now EMPA kidney, headline results are out, which also has shown statistically significantly superior benefit in clinical renal endpoints. And the benefit of EMPA kidneys, they've included people down between 20 to 45 without any albuminuria. So that's the added benefit in the added excess information that you get in the EMPA kidney. Again, this will be discussed in great detail. I'm just saying the headlines. So now if you come to the ADA-ESD 2018 and now the ADA Standards of Care 2022, what do you find? You find that you now have to see whether the patient has got atherosclerotic cardiovascular disease, heart failure, or CKD, and then you have to use an SGLT2 or DPP4. I'll just take 2 more minutes here, person sir. Now, if you come to the DPP4 inhibitor combination there, you have Saxa, Sita, Lina. And if you see here, of all the boxes that you have, linagliptin scores over the other DPP4 inhibitors. So it's a nice combination to have an empagliflozin and linagliptin. And in Carmelina trial, you found that there is an excess reduction in albuminuria. So this is the combination that you have now: EMPA, Lina, DAPA, Sexa, Remo, Vilda, and now we have DAPA, Vilda. So this is the last slide that I'll spend a little bit more time on. If you take SGLT2 inhibitors, EMPA, everything is green here. If you take DAPA combination, fair enough, 3P MACE, CV death benefit you don't get, but you get heart failure, renal, hepatic benefit you get. If you take Remo, I'm not saying you don't have benefit, I don't know. You haven't done a randomized controlled trial. Hepatic is not recommended, vildagliptin. So if you combine DAPA and Vilda also, you will not be able to make even 3 out of the 5 boxes green to get all the benefits. So if you combine SGLT2 DPP4, more so EMPA and Lina, as opposed to the other combinations, you get metabolic benefit, you get CV benefit, you get renal benefit, and you get the other metabolic benefits as well. So with that, I'm going to stop. If you use a combination of empagliflozin and linagliptin, SGLT2 DPP4, you get metabolic benefits. 1.8 is a little bit hyperbole. That is, if your HbA1c is really high, you will get at 1.8 up to 1.2. You get 3P MACE benefit, CV death benefit, all-cause mortality benefit, heart failure benefit. If you're using empagliflozin, if you're giving DAPA, then maybe 3P MACE, CV death has to go out. And renal perspective, we have data from secondary interpretation of the cardiovascular outcome trials, and we have now dedicated renal trials, which is Credence, DAPA CKD, and EMPA kidney, which will be published, presented in great detail later, and you'll be hearing great detail. So, ladies and gentlemen, I hope I've been able to convince you that from tomorrow, when you're in your clinic, please start combination therapy. If there are no contraindications, metformin plus a DPP4, whichever you want to choose. I spoke in favor of Lina today because I showed you the comparison. For want of time, I did not go into too much detail. And an SGLT2 inhibitor, if there's no contraindication, mark you. There's no contraindication. And between EMPA, DAPA, and CANA, I try to differentiate them a little bit, but it's impossible to do that in 20 minutes. So combination therapy, choose your combination well. I had a slide on what kind of combination you need to choose. We have published this. We've written this as a chapter in Satiko's textbook of Professor Satiko's textbook of diabetes. If you want, you can just have a look at it. It's chapter 52. We've given you various options of what kind of combination to use. With that, back to you, Dr. Shah.
Thank you so much, Dr. J.J. Mukherjee. It was an extraordinary presentation. And everybody, those who are practicing diabetes in the world, people are knowing what is the importance of nowadays for the practicing with the SGLT2 newer group and plus a combination of the DPP4. So you have at least nutshell mentioned about what are the benefits, and without any side effects, we can have the cardiac benefit, we are having the even CKD benefit, we are having the weight reduction and other benefits also. So it was an extraordinary presentation. After completion of this presentation, we will have the at least question and answer session. And now in the inaugural symposium, our third speaker today is Dr. Ramchandran. Dr. Ramchandran is such a figure. It is a national, it is not the national, but the internationally. Everybody is knowing whole family of the Ramchandran, and lot of our academic purpose. I am telling about the our academic purpose regarding the diabetes prevention in our country, and what are the mentioning regarding this thing, which is from the family point of view. Ramchandran family has mentioned. Dr. Ramchandran is from MD, PhD, BSc and FRCP Edinburgh, President of Indian Diabetic Research Foundation. He is a chairman, Ramchandran Diabetes Hospital, Chennai. Internationally renowned his work and epidemiology diabetes. His project, the Indian Diabetes Prevention Program, has been acclaimed internationally. His pioneering work for the use of the mobile technology in primary prevention of the diabetes is well known, and publishing more than 400 original research papers. So I'm requesting Dr. Ramchandran to give his presentation on lesson from the diabetes primary prevention trial in India, mechanism of the reversal of the dysglycemia. So Dr. Ramchandran, it's your now time. Thank you.
Good morning. Thank you for that introduction, and thank you all for inviting me for this and participating on this. So let's see whether I can share my slides and then see we can go from there. Are you able to see my slides now?
Yes, sir. It is visible.
Great. Thank you. Perfect. So what I thought I'll discuss in the next probably 20 minutes would be that we have been talking about prevention of diabetes, and we know that prevention of diabetes is possible, or postponement of diabetes possible. But from our ancillary papers in the primary prevention trials, I would like to explain how we brought about the prevention. So I thought we'll talk about the mechanisms of prevention or mechanisms of reversal of hyperglycemia. We know that there have been a number of primary prevention trials, starting with the first in China, and then in Finland, Yakutameleto, and then the DPP program in the United States. In India, we had the IDPP1, which is published in 2006. And then we had the Indian SMS study, again published late in 2013, and the DCLIP trial. And there's another latest trial called the Kerala Prevention Study. The ones which I'm going to discuss with you are actually from the IDPP and the Indian SMS study, and then discuss about the changes in the insulin kinetics and inflammatory milieu in facilitating prevention of diabetes. To recapitulate, the IDPP was a randomized control trial in which we randomized 531 people who had impaired glucose tolerance to 4 arms of the study. First is a control arm, and then you have lifestyle modification, then you have metformin, and then a 4th arm, which is a combination of lifestyle modification and metformin. And these subjects were followed up for 3 years, and the participation rate was almost 94%. And what you see in the results is that in the control group, the cumulative incidence of diabetes in 3 years was 55%. In the lifestyle group, it was 39.5%, metformin group 40.5%, and both combined almost 39.5%. In other words, the relative risk reduction of diabetes was actually 28.5, 26.4, and 28.1. And we can also see that there was almost similar number to treat to prevent diabetes, 6.4, 6.9, 6.5. So within the trial period, if you intervene for about 6 to 7 people, you will prevent 1 diabetes. So it's a very powerful strategy to prevent diabetes. There have been a number of differences, and one of the most important differences has been our people were actually much thinner, were non-obese compared to the European populations and the American population. Therefore, there were not much of confounders in looking at the insulin values and changes in the biomarkers. The SMS study was a study which was in collaboration with the Imperial College in London, because it was funded by the United Kingdom Educational India Fund. And in this particular study, we again randomized about 537 people. It was a 2-year study. And of course, this is showing the screening program and the way we actually recruited people by 2 oral glucose tolerance tests. It was actually a 1-to-1 ratio randomization. The control group had standard care, and however, the intervention group had text messages sent on the mobile phones in order to change their behavior to prevent diabetes, and the analysis was done at the end of 2 years. And surprisingly, we got a much more powerful reduction. There was a 36% relative risk reduction in the development of diabetes by changing lifestyle. Now, this showing you the absolute risk reduction was 9%, and because the control group, it was 27%, and intervention group were 18%. In other words, the number needed to treat was 11, again, is showing a very powerful strategy. Now the main question is that when you do a strategy, when I told you that we send SMS on the phone, you think that whether diabetes is prevented by chance, or was it actually strategies or the interventions worked? So the first question that you ask in any trial is, did the intervention prevent diabetes, or diabetes is prevented just by chance? And how did the components of the lifestyle modification work? It's very easy to say lifestyle modification, but it has components such as diet, physical activity, weight changes, etc. So we actually looked at this graph. This is an expected incidence. If the number of lifestyle scores, in other words, if people stick to the lifestyle modification, then you can score them. And if the score increases, then the incidence will be 0. But if the score is very little, then you can expect the incidence will be high. This is an expected incidence rate of diabetes as correlated with the lifestyle scores. Now, we tested this hypothesis to the trial that we did in the Indian SMS study. And what we found is exactly a similar pattern. As the goals improved, the incidence of diabetes decreased. In other words, it looks as if diabetes came down only because of the lifestyle modification or behavioral modification, which was brought about by the SMS program. So that is the first mechanistic explanation. The next one is, was there improvement in insulin secretion? Was there improvement in insulin sensitivity? And we have a new theory that we also improve the underlying inflammatory processes, because we feel that, we know there have been lots of studies to show that diabetes is an inflammatory disorder, but we also feel that probably even pre-diabetes is an inflammatory disorder. An improvement of the underlying inflammatory process must have been one of the associated factors which has prevented diabetes. So first, look at the beta cell function. Back in 2000, I think this is published soon after we published the IDPP. Spangler is the first author. And as you can see, what happened was those people who developed diabetes, the insulin secretion, delta Ig, significantly came down and the insulin resistance increased. So this shows the pathophysiology of diabetes. Now, you know that none of these people, there was a significant weight change. So it's absolutely no confounders. Now, the next question is, what happened in patients or in subjects who prevented diabetes? And that is shown here. What we found was that we improved insulin sensitivity to significantly every year of follow-up, first year, second year, and third year from the baseline. What you see here is the home IR. On the other hand, the insulin secretion remained the same. In other words, maintaining insulin secretion but improving insulin sensitivity was the mechanism by which we actually prevented diabetes in those with pre-diabetes. However, nowadays, we do not just go by the HOMA-IR or delta Ig. We need to have newer methods of actually measuring the beta cell function, because adaptation of insulin secretion to the prevailing insulin sensitivity is a highly regulated mechanism, and a deterioration of both the functions is associated with the development of diabetes. So therefore, Steve Kahn and his colleagues have now put in a product of insulin secretion and insulin sensitivity called the oral disposition index, DIO, is a better and more accurate measurement of beta cell secretion. So we applied this for the second prevention trial called the Indian SMS prevention program. To explain this further, I have shown you this curve called the hyperbolic curve concept. What is this concept? As there is increased insulin resistance, usually in normal people, there will be a compensatory increase in beta cell function. This is called the hyperbolic curve. Now, in patients who develop diabetes, there can be a pull of this curve to the left. When it comes down, what it means is that as insulin resistance increases, there will not be a compensatory beta cell function increase. And therefore, you will have a stage of normoglycemia going towards dysglycemia or diabetes. And that is measured by a combination, a product of these two factors, both insulin sensitivity as well as the beta cell function. So we use that concept, and what you find here is that change this on the green side, you have the insulin secretion improvement in those subjects who actually prevented diabetes from conversion from impaired glucose tolerance to normoglycemia was shown here, showing that there was a compensatory improvement in the beta cell function, or we can say by reducing insulin resistance. So that's the mechanism by which you prevent diabetes. On the other hand, those subjects who developed diabetes, there was significant decrease in the disposition index, showing that the insulin resistance was not associated with compensatory insulin secretion. Now I'm going to come a little more exciting or a little more new concept, and that is the biomarkers in diabetes. Of course, there are many definitions for biomarkers. The NIH definition is that it is a characteristic that is objectively measured and evaluated as an indicator of normal biological processes, pathogenic processes, or even pharmacological responses to therapeutic intervention. The FDA definition of a biomarker is much more simpler. Any measurable diagnostic indicator that is used to assess the risk and presence of a disease. In other words, biomarkers are not only predictive of diseases, but also involved in the pathogenesis, and therefore modifying them has a potential to change the course or onset of diseases such as diabetes and cancer. Now, as you know, the development of diabetes goes through from normoglycemia to pre-diabetes and to diabetes. Usually, it is associated with decreased beta cell function and insulin resistance. But some of them even reverse to normal. And so we do not know who are the individuals who actually become diabetic when they have pre-diabetes, because in the natural history of pre-diabetes, reversal to normality is very well known. Therefore, it's possible that the pro-inflammatory cytokines and adipokines, their presence in the stage of pre-diabetes may be another important risk factor which drive them or convert pre-diabetes to diabetes. And we're going to examine this from the prevention trials. So the concept is diabetes seems to be an inflammatory disorder. The biomarkers, which are pro-inflammatory adipokines for diabetes, should predict the onset of diabetes in non-diabetic subjects. Biomarkers may be added to conventional risk variables to improve power of association of prediction. It is possible that improvement of biomarkers in a pre-diabetic stage could influence prevention of diabetes. Now, the next question is it true? How do we abate the inflammatory process? Can lifestyle modification do it? So we examined several biomarkers, and I'm not going to give you everything. Adiponectin, retinal binding protein, the GGT and the ALT, which are the liver enzymes, interleukin-6, leptin, visfatin, and fituin. I'll just show you the results. We are one of the groups first published the paper on adiponectin back in 2003. In fact, this paper is published even before the IDPP results are published. What is adiponectin? Adiponectin is a hormone produced solely by the adipocytes and is a regulator of glucose and energy homeostasis. Low adiponectin is associated with low insulin sensitivity, and it participates in the etiopathogenesis of diabetes. And we're going to examine that in the IDPP. And here is the results. What is shown here is that the first tertile of patients with low adiponectin at baseline had an increased risk of diabetes, 56% incidence compared to 12%. In other words, a low adiponectin level in patients or in subjects with pre-diabetes had an increased risk of developing diabetes compared to those people with pre-diabetes who have higher adiponectin level. Because adiponectin levels actually reduces the insulin sensitivity. In the second study, an SMS study, we looked at interleukin-6 along with adiponectin. Interleukin-6 alters insulin signaling in hepatocytes and adipocytes, and it's impaired energy regulation. And leptin is also associated with resistance. So what did we find? We found, even by controlling for other risk factors, a lower adiponectin again increased the risk of diabetes, which is reproduced from the previous study. Interleukin-6, adjusted for other variables, gave a odds ratio of 2.27, which is 2.5-fold increased risk of diabetes. So these two adipokines were involved in the pathogenesis of type 2 diabetes in the Indian population. Retinal binding protein is a very new one, and that is it's secreted by the hepatocytes and adipocytes, 20%. In fact, it is 80% of retinal binding protein is secreted by hepatocytes, so it can be called as an hepatokine. It contributes to systemic insulin resistance and impaired glucose regulation. And we looked at the baseline values, and we found that even for controlling for the BMI, waist circumference, and the 2-hour plasma glucose, which is a very strong predictor of diabetes. Further, retinal binding protein had a O ratio of 1.73, 73% increase. And if you further adjust the model 3, can adjust even for the liver enzymes, we found 65% increase. So this is another important adipokine or hepatokine which can predict diabetes. I'm sure doctors will be interested about NAFLD and the pathogens of diabetes. There have been many papers after we published this, and this is the study of association between the liver enzymes and insulin diabetes. And you can see here that GGT in model 1 and model 2, even for controlling for other risk factors, had an HR of 2.18 and 1.78. In other words, this shows that liver plays a role in the pathophysiology of diabetes. And whether correction of this metabolic abnormality could prevent onset of diabetes is an important question. The last few slides, I'm going to give you the results of the study done by my PhD student on association of predictive value of visfatin and fertuin A with incident diabetes. Now, what is visfatin and what is fertuin? Visfatin is produced in the visceral tissue, adipose tissue, and is a perfect adipokine. It's a regulator of cytokine influencing glucose homeostasis. Fertuin A, on the other hand, is actually exclusively produced by the liver, and it's a hepatokine. And it's been shown that elevated levels can be seen in type 2 diabetes. So what I'm showing you here is that if you look at the baseline values of visfatin, it shows that it increases the incidence of diabetes. In tertile 3, there was 54.2 incidence of diabetes compared to 13.4 in tertile 1 in visfatin. If you look at fertuin A, again, tertile 3, you have 55.6% compared to 12.5. In other words, baseline fertuin A levels in pre-diabetes predicted diabetes. Interestingly, if you combine visfatin plus fertuin A in pre-diabetes, it gives an odds ratio of 12.63. In other words, if you have elevated both these together, and if you have impaired glucose tolerance, you have almost 13-fold higher risk of diabetes compared to those who do not have it in a pre-diabetic stage. Another interesting factor, it is not only diabetes, but it is also predicted metabolic syndrome in patients with pre-diabetes. It looks as if these inflammatory adipokines are related to cardiovascular risk. Well, I'm going to just give you one slide, which is unpublished data. And that is the question is, does the prevention and development of diabetes associated with change in the plasma adipokine or biomarker markers? And what you find here is that a follow-up of all these patients during outcome in all the subjects who had normal glucose tolerance at the outcome had a decreased fertuin A decrease in the chimerin, and decrease in the resistin, which are the other biomarkers. But visfatin did not show that. So in other words, it looks as if prevention of diabetes is associated with decrease in pro-inflammatory markers. And that may be an association or can be also a mechanism. So to conclude, postponement or prevention of diabetes is possible with lifestyle modification. Every component of lifestyle modification plays a role in the pathophysiology of diabetes. The improvement in insulin sensitivity and preventing insulin secretion both are responsible, preserving insulin secretion, both are responsible for prevention of diabetes. Changes in the inflammatory biomarkers like adipokines and hepatokines involved in the pathogenesis of hyperglycemia seem to play an important role in prevention of diabetes. So therefore, we are actually, when you are preventing diabetes in people with pre-diabetes, we are not only just reducing hyperglycemia, we are also reducing the process of inflammatory process in the body, which reduces cardiovascular risk. Just want to thank my team, which is a clinical team as well as a research team, and then Professor Tamilatu from Finland, Johnson from Imperial College, Nick Veram from Cambridge. Thank you. I think I may have to go because my clinic is on. Sorry for that. So I hope Dr. JJ will answer my questions.
No way. How can fertuin A and visfatin, sir, how can I answer? That is your research work. You have to stay. You can easily spare 10 minutes, I'm sure.
It was indeed
mine is the last talk, so you can have the question straight away.
Yeah. So, as there is no question in the chat box, but from my side, I would like to ask, sir, what can be the markers for a pre-diabetic, or where we should work more, or what is the future for biomarkers for preventing type 2 diabetes?
Well, the best biomarker for insulin sensitivity is actually adiponectin. Easier to measure. So if you have a very low level of adiponectin and if you have pre-diabetes, your risk is pretty high. So then you have to be more aggressive in preventing diabetes. And now you know that we have used lifestyle modification as well as metformin. And even metformin is a good drug.
What is about the acarbose?
We are not using acarbose, but the stop NIDM trial have been used. And also there is a very good study called the ABC trial by Rory Holman in China, which reduced incidence by about 16% diabetes, but it did not have any effect on cardiovascular risk. Acarbose reduced in the latest study, prevention of diabetes was about 16 to 18%. Not that powerful.
Dr. Chawda.
Okay.
Yes, thank you, sir. Thank you so much for
JJ,
time. Bye.
Bye. Nice talk. Nice listening to you. Thank you. I enjoyed the unpublished data.
I'm sorry, I'm in the clinic, so therefore some people are waiting outside and they're going to start knocking on the door.
Nice listening to you, sir.
Bye.
Nice to listen to you, sir. Bye. And my question goes to Mukherjee, sir. Sir, in a pre-diabetic or obese patient, how would you place the combination of SGLT2 and DPP4? Can we use them off-label for pre-diabetic or obese patient?
I think in pre-diabetes, we should not be thinking of SGLT2 or DPP4 inhibitor. They're absolutely not advised. For weight loss, again, SGLT2 and DPP4 inhibitors are not to be advised, but certainly GLP-1 receptor agonists, both liraglutide and semaglutide, are licensed for use in weight loss. So in pre-diabetes, as Professor Ramachandran presented, I think lifestyle modification is the key, which is the most difficult aspect of treatment. If you see all guidelines, on the top, the first bar is lifestyle modification. Professor Ramachandran left. I've asked this question before. It's very interesting as to when you combine lifestyle with metformin in the Indian patients, there wasn't a better outcome with regards to prevention of IGT going into diabetes. It's very interesting. So it would be nice to know what was the mechanistic difference between, because only lifestyle modification gave the maximum benefit in the Indian diabetes prevention program. So to answer your question, pre-diabetes, certainly please do not use SGLT2 or DPP4. Even off-label, because if you see pre-diabetes, there's so many drugs have been used, right? You know that. You know that metformin has been used. You know that pioglitazone ACT now has been used. Stop NIDM has been used. All drugs are used. But not even once is licensed by FDA except lifestyle modification. We do use metformin, which is, I won't say it's off license, with some kind of some degree of consensus that metformin can be used. The others are not used at all. And with regards to weight loss, only GLP-1 receptor agonists as of now licensed. Back to you.
One more question from my side. Because you see, due to the SGLT2, our poor hygienic condition, we are seeing the plenty of UTI patients. But those who are not having the UTI and they are having the itching problem, even in the male patient also. So what the kind of the recommendation you are going to give them?
So you're coming into the degrees of balanitis, you see,
without UTI.
So there is the UTI is no longer an issue. The UTI with SGLT2 inhibitors was an issue in the initial trials, but subsequently the large cardiovascular outcome trials have clearly showed you that there is no increased risk of lower or upper urinary tract infection. Having said that, if there is past history of upper urinary tract infection, pyelonephritis, pyonephrosis, or recurrent UTI, the definition of which I still do not know what is recurrent UTI. The only guide that I can give to my friends who are listening is the Declare to Me trial, where they said if you've had 2 UTIs in the last 1 year, avoid using an SGLT2. So having said that, now your question is what happens when they get a GTI? So if they get frank GTI, say, it's a wet balanitis. Wet balanitis is very easy because there is wetness, there is itching, there is inflammation. Then what I suggest is stop the medication for 5 days. I give them topical antifungals which works in 5 days and ask them to restart, to do hygiene. If there is recurrence, now again, no guideline tells you how many recurrences you will stop. I generally give them 6 months, 3 recurrences, I would advise them to stop. This itching problem is very difficult to deal with, Dr. Shah. So I tell my patient that, okay, you stop the medication for 5 days, use the antifungal cream, see if it gets better, and I leave it to the patient to decide whether he wants to continue. The itching part, there is nothing obvious to see. So I'll let the patient decide whether he wants to continue on. Back to you.
Thank you so much. Thank you. Dr. Chavda.
Yes, sir. Anuj sir already elaborated everything about sulfonylurea, but I would like to get a single line statement from sir that where sulfonylurea are standing for Indian diabetic patients.
Very good question. Sulfonylurea is still practically standing as a most preferred molecule to be used after the metformin, even nowadays, after knowing so many good things about the newer molecules. And in fact, if we compare it with the DPP-4 inhibitors, then somewhere and some places we find that sulfonylurea is the better efficacious and better being used even for the cardiovascular adverse outcome situation also. And even it is the first choice of the many of the cardiologists. Most of the time when we talk to the cardiologists, they say that we are quite confident and comfortable with the use of the sulfonylurea instead of using the newer drugs like SGLT2 inhibitors and DPP-4 inhibitors. And obviously the DPP-4 inhibitor has not been proven with any of the cardiovascular benefit, but no doubt about the SGLT2 inhibitor, they are having the substantial cardiovascular benefit, but still we need to have more experience of them. Even we have not had the experience as much we had with the sulfonylurea of the 10-year extended UKPDS follow-up. Even we have not total experience of the SGLT2 inhibitor as of now. So it is very much premature to say that they are better than sulfonylurea and they are at par than sulfonylurea or inferior to the sulfonylurea.
बहुत different कर
So
I think
there is no.
I am following Dr. J.J. Mukherjee. He has also defended in some meetings sulfonylurea so well.
No, but if we have another minute, I think see the only reason SUs are still on the top is because of cost. You see, I mean, if cost is an issue, then certainly use sulfonylureas. All that baggage they had, weight gain, hypoglycemia, that you very nicely said is not a baggage.
Yes, sir. One suggestion, because we are practicing with a very low dose of the sulfonylurea, which is working in our patients.
So, sir, my statement is we are not giving the benefit. I mean, see, the benefit I'm not debating between DPP-4 and SGLT2.
Yeah.
I'm saying with SGLT2 and sulfonylurea, I think nowadays SGLT2 should become the second line drug. I mean, GLP-1 if affordability is there. But if it is not possible, or if you need combination therapy, I would still add sulfonylurea quite lower down if my patient can afford. But as you rightly said, many of our patients, not only our patients, many of the patients abroad also cannot afford. So if you see still in NHS practice, I think Partho will be joining later on, he can add. Sulfonylurea still is the most common second line drug even in UK, you see.
Apart from affordability issue, I would like to say there are certain number of the patients, those who keep on doing well on the sulfonylurea even after 10 years, 20 years, even 40 years. I am having such kind of a patient, they will not require to increase the dose. So obviously the precision medicine concept seems to be much acceptable, and we need to really find which person is really a candidate for the which molecule. Especially the patient, those who are having the obesity, they can definitely be a better patient for SGLT2 inhibitors or GLP-1 receptor analog. But rest of the patient may be a better candidate for the conventional molecules like metformin and sulfonylurea. And sulfonylurea metformin combination, if we compare with the results of the vildagliptin and metformin combination, they are giving you the 6 years results that it could not require to increase the dose in the 6 years. But this sulfonylurea, when it is combined with the metformin, people are continued even for the 10-15 years. So it is again required to collect the data in the real world setting and can comment on that.
Anuj, your best Yorker is Steno-2 trial use. The Steno-2 trial, they used sulfonylurea, metformin, and human insulin. And they showed such beautiful cardiovascular and all-cause mortality benefit. And my counteraction to that Yorker, how I'll put my bat down and play, is saying that if Steno-2 is repeated with an SGLT2, then it might be a bit more different. We may have more benefit. I think Partho is there. Partho, what is the use of sulfonylurea in UK? Is it still the most common second-line drug?
Yeah, I mean, still is. I mean, we have the NICE guidelines which just come out pushing SGLT2 up. So there's a lot of work that's needed to try and push SGLT2 up in spite of all the evidence. So it's the same thing, even though, people say cost is not a matter. It is. People will gravitate towards the whole thing. And I think in primary care, that's the thing that everybody's trained with. Diabetes is simple. Diet, metformin, SU, insulin, finished. So when you throw in new things, people start getting like, oh, what is this? It doesn't matter how many years it's been. It takes a long time to change practice.
Thank you. Thank you.
So there is no more question and we are on time. So let's move on to the next session. I would like to thank you, Dr. Anuj sir, Mukherjee sir, and Ramchandran sir for a wonderful talk and wonderful discussion. Thank you, sir.
Thank you. Thank you, Chairperson.
Thank you so much.
Thank you.
Thank you, sir, for allowing me to co-chair with you, VN sir.
Thank you. Thank you.
Thank Dr. VN Shah.
Thank you.
Yeah. So for the next session, we have a chairperson, Dr. Deepak Dalal, sir. Sir is a trustee and honorary diabetes specialist, Juvenile Diabetic Foundation, consulting diabetes specialist and endocrinologist. Sir is above all a wonderful mentor and a great human being. The second chairperson is my friend Dr. SS Daria from Jaipur. He is MBBS, MD, Diploma Diabetes and consultant physician and diabetologist. So I would like to tell Dr. Deepak Dalal sir to start the new session. Deepak sir. Sir, you are on mute, sir. Deepak sir.
Good morning, everybody.
Good morning, sir.
I welcome Dr. Parthakar. I have met him personally on a number of occasions, and he is one of the great torchbearer of type 1 diabetes, not only in UK, but internationally. If I read his CV, he won't be able to give the lecture. But I will like to say that he is one of the finest human beings leading with the care of type 1 children with the diabetes, and that too in the capacity of meeting the politicians and helping. Dr. Parthakar, welcome for your presentation. Thank you.
Thank you. Thank you very much, everybody. As ever, a pleasure. So what I'll do, I'll start by sharing my screen, which is the most important thing. And then let's see. Do it. Hopefully you can see my screen.
Yes, sir.
Yes.
So I've been asked to talk about levels of care of type 1 diabetes in children and adolescents. So I'll go through some of the principles of what I think is something that's happening. As ever, thank you for the kind introduction. Thank you to Bunchy for organizing this. And hopefully in the future, we'll be able to get to less virtual, more face-to-face, which is always more desirable from that point of view. So to start off with, I've always said this: if you do type 1 diabetes or even type 2 diabetes, these are the three things that things sit on: self-management, peer support, and access to professionals. And I think the problem is that we always focus on number 3, which is trained professionals. The problem that we have is we don't have enough professionals. Whatever we do, how much can you train? How many diabetologists are coming through? How many diabetologists are aware of the new change? So that's always a challenge, trying to get there. So with that in mind, if you talk about self-management, the big things that we're looking at, what things can make your life better? That's what we're trying to do. If you're living with diabetes most of the time on your own, without access to a professional, because of present times, difficult to find doctors to talk to, then you're looking at the presence of technology. You're looking at the presence of education. You're looking at the presence of any sort of mental health support. And I'll talk about peer support a little bit separately. But in general, what you're trying to do with technology, whether it's Libra, whether it's CGM, whatever, depending on affordability. But then again, not everybody can afford it. Then the most important thing that you have got blood sugar numbers to look at. You've got things that you can do. And I think it's quite important that you have access to those if you can afford it. Because obviously the India setting, it's not as easy to say that everybody should have X and Y. But the big thing is obviously education. So what do you do with your diabetes when you're struggling with this, when you've gone out on holiday, that sort of stuff. So I think if you think about the care level, then the important thing is having technology support, having education, which is a very important thing. Now, what is peer support? Peer support is something that is actually in its infancy stage, even in the UK setting, but we're trying to get it more formalized. And this is something which we don't use enough. In India, you've got groups such as you have Blue Circle, you've got Diabetes, all these groups of people that are trying to do peer support. And it's quite important that we try and encourage them more. Because what they can do is they can fill in the gap for a lot of doctors who are struggling to sort of cope up with patients. Because there's an essence of the lived experience. The important bit is, what are the expert patients? What support can they give to parents? Parents are more switched on. What support can they give to other fellow parents? So having that is quite important in your care level. So not only is it about your own, as a doctor, your own professionalism, your own education. The other important bit is what can you do to help make our lives better as clinicians? And having support for through peer support, where you encourage them to talk to each other. They encourage them. So you can guide these peer support groups with education, give them the right tools so they can cascade your bit. They become your vehicle to pass that on, whether it's formal, whether it's informal, whichever way it is. Now, you've got two levels of care. One is the primary care level or the GP level, and the second one is what we call the specialist level. So let's talk about what is the primary care or the GP level. So what do you have? What do you need in primary care level? So first of all, you need the basics. You have got type 1 diabetes in children and adolescents. And whatever happens, you don't want them to direct them towards try this food, try that food, so that they end up trying to come off insulin and cause more harm. That's the last thing you want. You want to be aware that insulin use is the most important thing in their management. You want them to be aware that technology is there. But important thing also is about the need for referral. Where does a general practitioner or a primary care say, this is the limit of my knowledge? And I think that's the most important thing that we try and do with our local general practitioners. Basics, you should know, in the sense that they need insulin for life. You need to give them some education. You need to make them aware of technology if they can afford it. But the most important thing is knowing your limits and thereby saying, this is all I can do with type 1. I may be better trained in type 2. Type 1 is very different. And this is where we need to do the referral. So what about specialist care? In specialist care, you've got a different setting. Specialist care, obviously, specialists can afford or offer more of the technology. They can talk about closed loop. They can talk about connected pens. They can talk about faster, more modern insulin. Again, a lot of that is tied in with the affordability and what people can and cannot do. But the education they can offer is also much of a higher basis. So what you're having in this place is suddenly you're turning around and saying, these are the two levels, basic level, basic education, basic knowledge of insulin being the important thing. And after that, you know when to refer it over to specialists for higher technology, higher health, etc. So one of the things that we always talk about is in any setting, any level of care, the important thing obviously is communication. And because that's the important fundamental where you want to make sure that that sort of communication is taking place. Whether you're in primary care, whether you're in specialist care, you need to have the ability to communicate so that you can pass on the right knowledge. What you also have is these things in children and adolescents, right? You have the hormonal challenges. There's an age group where they're more rebellious by nature. You have peer pressure, other people, and then school and college life is an important part of them growing up. And how do they identify with having type 1 diabetes? Is there stigma with it? The fact that they have to inject? What about family structure? Is it supportive? Does they understand? Or do you have the same issues that, you're taking injections, so it might affect your, how you live, how you get married in life, all of that. So these are all the nuances that children and adolescents face going upwards, which is very difficult for them as well when they're growing up. So what you do have is you have this document called Language Matters, and in the Indian setting, you've got a type 1 document and a type 2 document. Both of them exist on this website, which was built by patient groups, the type 1 with diabetes, and the type 2 document being built by Dr. Tejal Lathia and our colleagues. So there's some really good pieces of work there, which is done in the Indian setting to look at what language nuances might help, what things would you would say that would come across in the right way or not. So these are all important levels of care as you go along. And I think that's important part. So if you take a step back, when we talk about levels of care, what are we trying to do? We are trying to say that whenever the person with type 1 diabetes presents, wherever they present, if it's with a general practitioner or the basic, primary care, you need to have that knowledge so you're aware when to refer on. Don't send them to do something that might cause you harm. You want to try some particular product or particular powders or whatever, or yoga or whatever. That's the important thing, safety. Once you come to the specialist team's role then is to educate the primary care colleague. And the specialist care, then what do? Is then they can offer the higher technology, higher education, higher support going forward. So that's pretty much the principle of what you want to do. So type 1 diabetes is as complicated as you want to. Obviously, the nuances are of age, because we've all been teenagers. And those of you who've got teenagers at home will understand. We've got plenty of pressures in life nowadays. Being 17 in the 1980s and 90s and being 17 in 2022 is very different. Social media puts lots of pressure. What does type 1 diabetes look like, etc. So these are all important considerations to have as we give them the treatment and the approach that we do. And finally, it's about communication. It's about knowing how to interact with them. So I think if you have those principles and the levels of care, I think type 1 diabetes care can be done much better than what we do around the globe at the moment. So I'll leave it there. And thank you. Thank you for asking, as ever.
Deepak sir. Hello.
Hello.
Deepak sir. Yes, sir.
Yes. I cannot hear anything.
Can you hear me now?
Yes, now we can hear you.
Yeah, no, it's fine. Go for it. No, so I've just finished. So you let me know. I think, as I said, quite straightforward presentation. So thank you to everybody for asking. So very early in the morning here. So about to go to work. So no, thank you. Thank you for your time. And if any questions, let me know. Otherwise, that's ever a pleasure to join in.
It was wonderful, sir, to listen to you. Sir, Deepak sir, let's move to the next talk.
Parthakar, again, it was excellent, I will say. Okay.
Thank you very much. Thank you as ever. All right. Take care, guys. Okay. All right. Bye-bye. Bye-bye.
Nice.
Okay. So, Dr. Chawda, we have another chairperson, or I go ahead?
Please, sir, you continue, sir, to introduce Dr. Thomas.
Right. Dr. Thomas Dan, very good friend of ours, not say mine, ours. And I know him as a sweet person who has introduced sweet registry, and not introduced, but executed sweet registry in India. And I request him to go ahead with the presentation, because I do not believe in reading the long series, but we come straight to the point. Sir, Thomas Dan, please go ahead with your presentation.
Team RX, do we have his presentation?
Hello. Hello, my name is Thomas Tanne. I'm the chairman of the SWEET project, and I'm a pediatric diabetologist from Hanover, Germany. The subject of my talk is to let you know about trends in pediatric diabetes, an update from the worldwide SWEET registry. Let me first say a big thank you to the corporate members of the SWEET project, which are Abbott, Boehringer, Dexcom, Insulet, Lilly, Medtronic, Sanofi, who are supporting us, and in particular also the team behind the SWEET project, which are the people doing the data analysis, Reinhard Holl, Stephanie Lanzinger, Sascha Tittel, and the people who are organizing everything, Katharina Klee, Tanja von Loo, and Michael Witsch. Now, if we take a look at the differences between international registries, you can see that a registry alone and just benchmarking does not necessarily improve the glycemic control or outcomes in children with diabetes. So you see that although the age difference in the glycemic control is pretty similar between the countries, the sheer level of A1C is quite different. Now, we started to say, okay, it might be necessary to compare not only within countries, but also between countries in terms of a benchmarking, with a vision that what we want to reach is equal high quality care for children with diabetes and to harmonize the outcomes on the basis of real data. And this was how the SWEET project was started. Now you can see that it is now really a worldwide enterprise. The blue dots are the ones that have joined us even within the COVID pandemic. And you can see there are several centers in India, and we're very proud that India is so well represented here. But the majority of the centers are indeed in Europe right now, but you can see we have a lot of centers all over the world. Now, if we look at the database, there are 120 centers with roughly 100,000 patients overall. In the COVID year of 2021, we had close to 50,000 patients entered into the data. And so this allows us really to analyze more than 1 million visits of patients over the time. If you see here, if we compare 22 centers, which were actually initially already part of our diabetes registry, in 2008 and 10, and this is the blue line, there was also this typical relationship between age and glycemic control, with the levels increasing in the adolescent age group. But you can see in the green curve how this has improved in all age groups over the past 10 years. And for reference, I'm showing you the data of the type 1 diabetes exchange, which was analyzed more or less in the same time period. And you can see that although this registry also was looking very much into looking at data over time, there is quite a big difference. So what can we know what really makes such a big difference? And here you see the temporal development of three things: the percentage of patients that are achieving an HbA1c of less than 7%, less than 53 millimoles per mole, the percentage of patients who are on insulin pump therapy, and the percentage of patients who are using a continuous glucose monitor, CGM. What is quite apparent is that already from early on, from 2008, the use of diabetes technology as insulin pump therapy is increasing. But it takes some time that you also see that the glycemic control is also improving, that the percentage reaching this target of an A1C below 7% is increasing. So there is kind of a learning curve also with new technology, and the improvement in A1C is not happening immediately. If you may, you already see another upward trend in the A1C, and this also, again, is preceded by an increase in diabetes technology, in this case with CGM. And it will be very interesting to see now that automated insulin delivery, the combination of pumps and sensors for automated insulin delivery, how this again will have a further impact. Now, how do we do all this discussion? So we are able first of all, to really compare. So here you can see spider displays of the percentage of patients which are in good control with retinopathy, with severe hypoglycemia, with acute complications or high lipids and things like that. And it shows you that there are two ways to compare. Of course, first of all, you want to compare how is your center doing where compared to others. Is it in certain areas better or worse than others? And then also to take your own center as a control. Of course, you want to improve and you want to have more patients in good control and less complications. So this gives you an oversight of how you're doing. Another way is, of course, to look at size. You want to learn from centers of similar size. So this is a bubble blot, and a bigger bubble shows you a higher number of overall patients. And then you can see on the one hand, the patients, the percentage of patients in with a high A1C, and then compared to patients with a near to target A1C. And obviously you want to be as far as possible on the low right corner. And so you can actually use such a bubble blot to look at a center which is of similar size, but is currently doing much better than you. Now, another important thing for the success of the SWEET registry is peer review. So that not only you are comparing your data, but you're also visited by your peers and discussing it. And it's really a learning process, both of your own center as well as the visited center. So because there is an exchange, and so both sides are actually learning from each other in this way. And the end point is, if you pass this test, you are a collaborative center or even a center of reference.
Unstable.
Now, obviously, as SWEET is growing, we have now created hubs to organize the international efforts a little bit more. So we have now 5 different hubs with different hub leaders who are taking care of all the local issues, and obviously translate them to a chair in healthcare delivery and healthcare policy. What we are using as well is, as this is now making it very difficult to conduct real in-person clinical visits, we are now just starting a process of using virtual peer review visits, which allows, for example, centers from Germany and Slovenia visiting a center in Canada. And no ocean is actually in between, and it works really very well because you can discuss things. You can even virtually look at certain facilities and advise. So this is something that also works very well, and a new trend. Well, talking about trends, it's also important to see what the COVID pandemic has done, and obviously the COVID pandemic has hit us in different time periods differently. And here you can see that we have distributed the different SWEET centers according to the disease burden with COVID from the first wave. So you do see India there in the beginning being in a quartile with a very low COVID mortality from the first for the first wave, while other countries like Belgium, Chile, England, France, Ireland, Italy, Netherlands, Spain, Sweden, and USA had a very high background COVID mortality. So interestingly, the average glycemic control in all centers remained pretty much the same, even during the COVID pandemic. But in those with the highest quartile of background mortality in their population, you can see an immediate increase in diabetic ketoacidosis if you compare the year before COVID and after. But interestingly, just prior to the second wave, so in August, September of 2020, the DKA rates returned back into the normal range. So really those systems were able to adjust very quickly, and it was just an immediate effect of the lockdown and the disruption of medical services, which only happened in those countries where COVID was a particularly big problem. If we look at other things like the acute complication of a hypoglycemia, there wasn't really an impact of COVID. And there was also, of course, the question whether, for example, the daily insulin dose would increase because people would be less exercising and so on. And yes, you do see a little bit of an increase in the insulin dose in those two quarters with the countries with the highest problem of COVID-19, which is quartile 3 and quartile 4. You see there's a significant increase in the insulin dose, but again, it is returned immediately to the normal pre-pandemic values after the first wave was over, prior to the second wave. Now, if we look at diabetes technology, another interesting trend is, while insulin pump use more or less stayed quite the same, so there was no influence on the insulin pump use, you can see that in virtually every country and every quartile of COVID mortality, there was a huge increase in the CGM use, because people understood that the virtual diabetes care only really works when you are using CGM and then maybe have cloud-based consultations to really exchange our information from one center to another. So clearly the trend here is that due to COVID, the CGM use really increased quite a lot. Now, if we have so much CGM and we don't have HbA1c, the blood-based A1C, as much as we had it before, how can such a registry respond to that? Well, we created a so-called combined glucose indicator, which is using for the comparison of glycemic control both the HbA1c measurements based on the standardized A1C determination, the A1C estimation from time and range based on the CGM profiles for those centers who are able to upload the complete CGM profiles, and also to use if just the parameters, for example, the percentage time and range, the percentage time below range is entered into the database, then this is also used for A1C calculation, and then this is called the continuous combined glucose indicator. And you can see here that it can be nicely used to actually compare glycemic control with this aggregated data over time. And as you see, the percentage of patients in good control is actually increasing during the pandemic years of 2020 and 2021. So there are a lot of trends which are necessary to adjust our therapy, and a lot of trends are also happening in terms of how we are actually changing the therapy. And so again, our data was analyzed in particularly on the question, are there differences in those groups who are using injection therapy only, injection plus sensors, only the pump, or the combination of pump and sensor. And you can see that the groups are pretty large. There were around 9,600 children having injection only, close to 4,000 having the combination of an injection and a sensor. Again, a little bit more than 4,000 having only a pump, and close to 8,000 combining a pump and the sensor. So the first finding here was that the A1C was lower in all categories of participants who used a pump and or a sensor compared to the injection therapy. So clearly having injections appears to be less flexible and more difficult to achieve good control than those who are using the pumps or in particular a sensor. And combining this with other studies, if the question is, what is more important? Is it the pump or is it the sensor? it looks very much that the sensor is really the important part here. You might be a little bit surprised if you look at the severe hypoglycemia rate here, which was lower in the pump no sensor group, but higher in the injection and sensor group. But the reason here we have to understand that very often having a severe hypoglycemia was the reason of putting somebody on a sensor within injection therapy. And so, as we know that the risk for severe hypoglycemia is about 4 years higher after an event of severe hypoglycemia, it is very likely that this is the cause why the severe hypoglycemia was particularly high in this group. So it was not due to the sensor, but the sensor was really the reason for putting somebody with injection therapy on a sensor. Interestingly, also the other acute complication, DKA, again, was significantly lower in the pump and sensor group. You would say that the pump in general should have a higher DKA rate, but both groups with the pump had a lower DKA rate than the injection groups. So the idea of that pumps are a particular problem with infusion set failure appears to be less of an issue compared to the more constant insulin delivery that you're having with the pump compared to an injection therapy where missed insulin doses are a frequent occurrence. Another important part here is looking at the targets, the treatment targets in different is concerned about having not enough manpower to treat children with diabetes. There is a little bit consolation here maybe that we didn't find any association between education time and A1C or the full-time equivalent of personnel and HbA1c. But what really was very outstanding here is that there was a positive association with the target value for glycemic control and A1C outcomes. So more ambitious targets were associated with better outcomes. And that really the composition of diabetes teams could and metabolic control could not be demonstrated. So even with a small team, having ambitious targets will lead to good outcomes and good results. Now, what is the next step? We will now try to get more in touch with the patients, and we have created a patient advisory board, and I'm very happy that we have also somebody from India joining this board and trying to look at patient-related outcomes to see how the feeling of the patients, how the satisfaction with diabetes treatment is, and relate this to the long-term treatment here. And also, we look on the political scale here, registries like the SWEET registry are more and more understood and hopefully in the long term supported for sustainability because people understand how important registries are, as you can see in this recent publication of the WHO from the European region. So I hope this was interesting for you to see a couple of the new trends coming from the SWEET registry. And I think one of the nicest things lately was that between 2021, the COVID general meeting of the SWEET registry, and very recently in April, the first meeting again, person to person, face to face, during the ATTD meeting in Barcelona in April of 2021. And you see a lot of smiling faces here. And along those lines, I hope very much to see all of you in person in India sometime in the future. And I wish you all the best. And thank you again for your attention.
Dr. Dan, it was a fantastic, out-of-the-box, unthought presentation. And COVID gave us a challenge. And now COVID is giving us an opportunity to do such work. Thank you so much, sir. Now we proceed to the next.
Yes, sir. Next speaker is Dr. Minal Mohit, ma'am. RX team.
Dr. Meenal Mohit, she is a consultant and head of Department of Endocrine, Manipal Hospital, Jaipur. And she is running thyroid clinic also. And she has a publication in national and international journals. Ma'am, we welcome you for your presentation. Thank you.
Thank you, Dr. Deepak. And thank you, Dr. Bansi sir, for remembering me and bringing me on this platform. I am talking from Jaipur. It's a virtual meet. I have taken the opportunity to talk to you all on a virtual platform. If you allow, let me share my screen. So the topic that has been assigned to me, talking after Dr. Dane, before I proceed. Dr. Dane, it was a pleasure hearing you all over again. I just chaired your session on almost the same topic in DTCon, if you remember. So after you, I'll be talking on adjunctive therapies in type 1 diabetes. So very good afternoon, all of you. So the very first question that comes to our mind is that when insulin is doing so good and most of the children are well controlled, or at least they are attempting to control sugars well with insulin, why do we need an adjunctive therapy? So adjunctive therapy is actually needed because there are a lot of glycemic variabilities, there are hypoglycemias, and insulin, we all know, ultimately leads to weight gain. So most of our children or the population with type 1 is put at the risk of micro and macrovascular complication. And though insulin is effective in lowering the blood glucose, we need to control something beyond blood glucose in our type 1 diabetic population. So we need something more than insulin that can adjunct insulin, that can help insulin in controlling type 1 diabetes. So the message should be very clear that we need a more stable glucose with less hypoglycemia, less weight gain, less complications. So the idea of adjunctive therapy is not to replace insulin, but to help insulin, complement insulin. The idea is not at all to decrease the dose also. The idea is absolutely that to have a better glycemic control and a better metabolic control in type 1 children. So with that concept very clear in mind, what we think about first is a pramlintide. Pramlintide is an injectable amylin analog. Amylin is another hormone which is secreted from the islet cells of pancreas. Amylin is not available in India with us. It is not available in Europe, but it is used in US. The mechanism of action is that it delays gastric emptying and creates a sense of fullness, or it improves satiety. So along with insulin, it helps in lowering of HbA1c. Because it delays gastric emptying, it also causes weight loss. But the side effects or the cons of the molecule are that it needs 3 injections per day. It might add to hypoglycemia, and it has significant GI side effects. There have been certain studies with pramlintide, and it has shown to reduce HbA1c, but associated with significant GI side effects in terms of nausea, vomiting, anorexia, and hypoglycemia. Another adjunct therapy that we all have been using in India also is metformin. There have been a lot of studies with metformin, especially in children who are feeling a lot of appetite is there and who are always hungry, or maybe who gain a lot of weight with type 1 diabetes and insulin. We do add metformin. So metformin is one of the adjunct therapies that is being prescribed in type 1 children. And there have been trials, that is one of the removal trials, where we have a data of 1 year, 2 years, and up to 3 years. And all have shown that there was a significant reduction in HbA1c, and also there was some reduction in weight. Though the progression to atherosclerosis was not significantly reduced, but we could prevent other cardiovascular risk factors, where body weight itself is one of the prime factors which is responsible for the cardiovascular risk factors. Then whereas other molecules which we are rampantly using in type 2 are now being tried and prescribed in type 1 as an adjunctive therapy, one of them being the GLP-1RAs. The GLP-1RA, that is Victoza by the brand name, or the liraglutide, which helps in weight loss. It is being prescribed along with insulin in type 1 children. It helps in the reduction of HbA1c, though not significant, but yes, it does help, but it is also at the same time associated with GI side effects. Lira is also associated with increased risk of hypoglycemia, and there have been reported cases of diabetic ketoacidosis. The idea that the molecule has never been put up for the FDA approval because of the significant GI side effects. So the research was stopped and the molecule was not put up for the FDA approval at all for type 1 children. But there is a very important one of the studies, that is Adjunct 1 study, which was carried out with one arm being on Lira plus insulin and another arm being on placebo. And it was found that as the Lira dose was increased up to 1.8 milligram, there was HbA1c reduction, which was quite commendable within a period of, say, 12 weeks and up to the 24 weeks also, that is 6-month study. It has shown that the HbA1c reduction was significant, and that gain in HbA1c reduction was well maintained over the period of 1 year. Then the newer molecules, that is the SGLT molecule, that is the sodium glucose linked transporters 1 and 2. SGLT1 are the molecules which are working at the GI level, and they help in the glucose absorption at the intestines. So if we try and inhibit the SGLT1 or we stop SGLT1, we can prevent glucose absorption right in the food itself, from the stomach, GI itself, the intestinal level itself. At the same time, SGLT2, which is responsible for the reabsorption of the filtered glucose. If we can inhibit SGLT2, we can cause glucoseuria and help reduction of HbA1c, or we can help as adjunctive therapy in type 1 diabetes management. So with this concept, we are now trying out with molecules like sotagliflozin, which is a dual SGLT1 and SGLT2 inhibitor. So with SGLT2 inhibitor here, if you see, we can block this and we can increase glucoseuria, and HbA1c or the blood glucose levels can be brought down. If we have a dual blocker which blocks both SGLT1 at the intestinal levels and SGLT2 at the kidney levels, we can cause a dual SGLT2 blockade and prevent glucose absorption on one hand and prevent glucose reabsorption on the other hand. So SGLT2 and SGLT1, both molecules, if inhibited, will also help in 100% reabsorption prevention from the renal level also. Because though 90% of the glucose is reabsorbed in the PCT by SGLT2, we also have some 10% reabsorption in the loop of Henle by SGLT1. So these dual blockers will not only prevent glucose absorption from GI, but also cause 100% prevention of reabsorption at the kidney level, causing glucoseuria. So dual blockers, SGLT2 and SGLT1, are one of the important class of adjunctive therapy, and they have been used in type 1 children. They also cause weight loss, and they do not have any GI side effects. They have insulin-independent mechanism of working. Sotagliflozin, as I was talking, is a novel dual SGLT1 and 2 inhibitor. So the studies that have been conducted with SGLT1 and 2 combined, that is a dual blockade, is the in tandem studies. In tandem is a series of studies where in tandem 1 and 2 had almost a similar pattern, where we had 3 arms, and it was 1 year study. It was one arm was treated with 200 milligrams of sotagliflozin, another arm with 400 milligrams, and the third was a placebo-controlled arm. And in similar pattern was followed in tandem 2. In tandem 3 series, we had a larger number of patients. It was a 6-month study, and there was no 200 milligram arm. It was only a placebo compared with a 400 milligram dosing. The only problem with the SGLT2 and SGLT1 and the dual blockade was that though we had as a primary endpoint a reduction in HbA1c, as a secondary endpoint, it was found that from the baseline, the HbA1c reduction was significant, but also there was increased chances of euglycemic diabetic ketoacidosis, which was reported. So it was found that we are still inhibited from using this molecule very frequently, though this molecule does give us good results in terms of adjunctive control of blood glucose along with insulin. The word along with insulin is very, very important, because we missed using insulin and we missed feeding the children with the basic minimum of carbohydrates, and that led to euglycemic ketoacidosis, which was mainly responsible for euglycemic ketoacidosis in patients who were treated with SGLT2 or SGLT1 and 2 combined, that is a dual blockade. So in Tandem 3 series, again, it was found that there was a significant weight loss, there was a drop in the systolic blood pressure, as well as there was reduction in HbA1c, but there was some chances of euglycemic diabetic ketoacidosis. In Tandem 3 series, the hypo episodes were almost comparable as compared to placebo. That we all know, even in type 2, the experience, the learning from type 2, that the incidence of hypo with the SGLT2 inhibitors are not significant. Similarly, in Tandem 3 series, hypo episodes and the DKS episodes, as you see, were not very significant or not very far from the placebo control arm if we are cautious and we are following the standard protocol. So what are the protocols? I will tell you when you are working with SGLT2 or SGLT2 and 1 dual blockade in type 1 children. Now, this is another study, that is the Depict-1 and Depict-2 studies, which were carried out with dapagliflozin. The similar pattern with after our initial run-in period, screening period, they were randomized in 1:1:1 series with dapagliflozin 5 mg to 10 mg to placebo. And in all the 3 arms, insulin was always there. So insulin was not taken off. And as compared to placebo, there was a significant reduction in HbA1c. The reduction was more, of course, as very well understood with dapagliflozin 10 mg compared to 5 mg. But even 5 mg gave us a significant HbA1c reduction as compared to the placebo arm. So Depict-2 has also shown the secondary endpoint, that is the mean change in HbA1c was also very significant. So Depict-2 has also given us the data from time in range. As we know now, the latest figures, as even Dr. Den was talking, we are also considering the combined approach of HbA1c as well as the time spent in range. So Depict-2 trial also took into consideration the time in range, and it was found that the patients who were in the dapagliflozin arm had significantly improved control and more time was spent in range as compared to the placebo arm. Then there was empagliflozin studies, that is the EASE trial, empagliflozin as adjunctive to insulin therapy in type 1 children. Again, it's a phase 3 trial. It has shown the EASE-1 series, EASE-1, EASE-2, and EASE-3, taking into consideration 5, 10, and 25. Again, the data has almost been similar, that SGLT2 inhibitors in general give us good adjunctive role in type 1 children along with insulin in controlling HbA1c, in weight reduction, and also increasing the time spent in range. So the time spent in range with 5, 10, and 25 was increased by 1 hour, 3 hours almost every day as compared to the placebo arm. Now the SGLT2 inhibitors, but they have their side effects and they come with their own set of challenges. Not only the DKA, that is the euglycemic DKA, but also the common complications that we are facing in type 2 population also, that is the increased incidence of genitourinary infections. So the increased incidence of genitourinary infection was very common in this group also. So we need to increase the fluid intake at the same time. There was some initial decrease in GFR by almost 5 ml per minute per 1.73 meters square of the body surface area. But this decreased GFR improved later on with the continuous use, showing that it was just the intraglomerular hemodynamic alteration and not actually the molecule which is affecting the renal functioning. Similarly, the Credence trial, which was done with canagliflozin, gave us that these are actually the nephroprotective molecules. So the initial fall in GFR is not because of any side effects or any worsening of the kidney functioning, but it was just because of the intraglomerular hemodynamic alterations. But the genital infections, yes, like candidiasis is very common. So we need to take care. And at the very initial first complaint, we withdraw the molecule and treat the infection rather than allowing the infection to increase. So the safety issues, again, the genital infection, euglycemic DKA, and hypoglycemias. Severe hypos with SGLT2s are SGLT2 inhibitors or SGLT1 and 2 dual inhibitors has been rarely reported. And so hypo is not a very big concern, but more important concerns are genital infections and the euglycemic diabetic ketoacidosis. So when you are suspecting a diabetic ketoacidosis, that is a patient on SGLT inhibitors, you must tell your ER staff, the emergency staff or your JRs or your nursing staff should be well informed that there is an entity when the sugars might be normal, but still the ketones are present and ketones can be large. So these are the conditions that the patient can be on SGLT inhibitors. So these are the conditions when the immediate action that needs to be taken is start the patient on insulin, start the patient on fluids, and give some 30 grams of carbohydrate. So in one of the smaller studies, it was found that type 1 diabetic patients treated actually with SGLT2Is, they need insulin always. And it is not the basal insulin which is mainly responsible, but it is the prandial insulin which was interrupted and that was responsible for decay, that is euglycemic decay with SGLT2 inhibitors. So how do we manage it? Managing, as I told you, start on insulin, start on carbs, that is glucose, and maintain the blood sugars, start the IV fluids, withdraw the SGLT. There is one standard protocol, the Stitch protocol. So that is how we manage when the patient presents to you with type 1 diabetes and diabetic ketoacidosis and so euglycemic ketoacidosis. Start carbohydrates, stay hydrated, start insulin. Though you might require very low doses of insulin, but insulin, especially the regular insulin or the prandial insulin, is something that is really required. So the Stitch protocol, as I was saying, first is Stitch, that is stop SGLT. I, that is start insulin. C, start carbohydrates. And H is for hydrate. So Stitch protocol, you must follow in all euglycemic diabetic ketoacidosis. Also, all patients with type 1 on SGLT2 should always carry a card with them that I am on SGLT2. So if I am found with ketoacidosis and normal sugars, please start me with IV fluids, insulin, and carbohydrates and stop the SGLT inhibitors. So these are the considerations when we are talking of euglycemic ketoacidosis in adjunct therapies. Other things like decay rise is seen especially in women, because maybe the women are more prone to low carb diets, though it is becoming more common in men as well. People who are fasting should withdraw SGLT2 inhibitors. So fasting, though we do not recommend fasting in type 1 children, but still if the children are following fast because of some religious reasons or because of some emergencies, medical emergencies, then SGLT2 inhibitors or SGLT1 and 2 dual inhibitors should be withdrawn. And you must always educate your staff, the diabetic patient, the ER staff, the emergency staff, your JRs, SRs, whosoever are managing your patients with diabetes, especially type 1, should be well informed about this entity. Then coming to the management of CV risk in type 1, though the CV risk does not come across, we do not encounter for the first 5 years, but after 5 years, we set that same pattern of follow-up, same pattern of screening, and the patients of type 1 are definitely at higher risk of cardiovascular mortality and morbidity. And this CV risk has been shown in tandem series as well as in E series, and we have to screen them to manage them, and management is just the same. For dyslipidemia, we add statins, a regular lifestyle, a healthy lifestyle, diet, carb intake should be restricted, and a regular exercise regime should be followed. Now, these newer molecules, the LEADER trial and the EMPA-REG trial has given us that these molecules have CV benefits. So these molecules can be used in type 1 children also. On a very sad note, we have come across this data from the Swedish study, the Swedish data registry, that children almost lose 17.7 life years and children lose almost 15 life years once they are diagnosed with type 1 diabetes. So the CV risk is very high, and these molecules, newer molecules, have shown CV benefit as well as renal benefits in various studies. So we must give that benefit, extend that benefit to our population with type 1. So what are the patient experience? The patient feedback is very positive because it's a tablet, first of all, and patients are finding it good to have something which is not injectable, a tablet which is bringing down their insulin dose, a tablet which is helping them to control their blood glucose. In spite of the urogenital mycosis, patients are willing to accept it, though we need to counsel against this concept, but the patient feedback is positive because significantly because it's a tablet and significantly because it's giving them a good glycemic control. So the patient experience is positive. And we are using these molecules off-label also because they are still not recommended to be used in type 1 as adjunctive therapy, but they are being used in type 1 and especially a little older children. The newer agents which are being used as adjunct therapies, even DPP-4 inhibitors, though they have not shown any benefit in terms of HbA1c reduction and in terms of hypoglycemia. GLP-1RA, they never filed for FDA. Maybe now with the launch of SEMA, they might try that. I'm not sure of that actually. But they have not tried for FDA so far. SGLT1 and 2, that is the dual blockade, the sotagliflozin, or the SGLT2 inhibitors, that is the DAPA, EMPA, KENA, they are being tried and they are currently being researched further for being used in type 1 children as adjunct to insulin therapies. So just to summarize my presentation, we are presently working only with insulin for the management of type 1 diabetes in children. We have various modes of insulin delivery in terms of pens or continuous subcutaneous insulin infusions. We have various scientific advancements in terms of CGMS, flash monitoring, or the Libre or the Libre Pro. But we are still facing the challenge of hypoglycemias, weight gain, and glucose variability, which is causing a high rise of cardiovascular mortality and morbidity. And we have micro and macrovascular complications in type 1 children very soon by the time they are attaining their most prime years of life, that is their adulthood. So we are looking for adjunct therapies, and these adjunct therapies is a huge pipeline. So we have the non-insulin based, we have the injectables, we have the non-injectables, we have immunomodulator based, and a lot of series, the cytokine mediator inhibitor. There are a lot of series of molecules which are all in the research phase as of now. But the idea of all adjunctive therapies is to control the QALY, that is the quality of life years, along with good glycemic control, with no weight gain, no hypoglycemia, and no side effects that is being evaluated. So the right balance that we need to find between the metabolic improvement and the quality of life without increasing the chances of diabetic ketoacidosis or weight gain or hypoglycemia or the glycemic variability. It's a dream come true or an ideal mode of management for the type 1 children probably, and we'll soon have it, I'm sure. So with that note, hoping for a better future for all our type 1 children. And with that note, closing this talk and handing it over back to the organizer. Thank you once again for inviting me here, Dr. Bansi sir and the entire Diabetes India team. Thank you so much.
Dr. Minal, thanks a lot for your presentation, and it has given a different concept. And I hope that along with this, there should have been some focus on a lifestyle, which is working quite differently. Anyway, that's a separate topic by itself. So I hand over the presentation to the organizers and thank all three presenters for one of the best presentation. Thank you.
Thank you, sir. Thank you so much.
Thank you, Meenal ma'am. Thank you, Deepak sir. Meenal ma'am, if you permit, can I ask something?
Sure, Dhruvi. It's always a pleasure to talk to you.
Pleasure, Dhruvi.
Ma'am, the honor is all mine. Ma'am, in real world, you know, I still feel skeptical as to starting OHAs or even SGLT2 for that matter. We all know we are writing insulin, but there are people who Google up things like, you know, कि हम ये दवाई ले सकते हैं, the guidelines are saying ये दवाई ले सकते हैं. So how comfortable in real world are we as doctors, or can you, you know, maybe give your opinion about how often have you prescribed all of these OHs?
Yeah, Dhruvi, thank you for this question because I can answer it very confidently. I have many of my patients, Metformin frequently we are adding to most of my type 1 because these are children and they are eating every minute.
Okay.
And they are putting on weight and they are hogging like anything. So to control appetite, Metformin has been used since many, many years. But now we are also using SGLT2 inhibitors very frequently. And many of my type 1 patients, though they are a little older ones, maybe above 18 also. So they are on SGLT2 inhibitors also very frequently with a caution that yes, increase your fluid intake, maintain your hygiene. Mm-hmm. So, and at the very first earliest sign of thrush or any itching or any redness, just do report genital infections, do report back. So these are the molecules. Even pioglitazone I have used in some of my type 1 children as insulin sensitizers, and also where I find that the sugars are really, the doses of insulin are really going very, very high. And in all of my patients, the reports have been very positive. All the parents have come back saying that after the addition of metformin, the appetite has been well controlled, the food habits have been regularized, and also the sugars have been well controlled, and the glycemic variability has really dropped. Similarly, we have added even liraglutide, though I have not added SEMA to any of my type 1 so far, but we have added liraglutide. We have added these gliflozins very frequently. So yes, I do have a data of type 1 patients, not I will say type 1 children actually, but type 1 patients, yes. I have many who are on OHA. And interestingly, you are very right. When I say I will be adding one tablet to your insulin, they also give me the same shock and expression. Tablet for type 1, yeah, they work, don't worry, and they will work well. So yes, we do have a data, and we do have patients of type 1 who are on OHS along with insulin. Nowhere we have withdrawn insulin. So the basal and prandial insulin with whatever combinations, and plus OHS for the adjunctive benefit we have been using.
Thank you so much, ma'am. Thank you. Deepak sir, would you like to add a few words about lifestyle modification in type 1 diabetes? For
I think we'll close because we'll be then running short of the time, but some other time.
Thank you, sir. Thank you.
I'll just take this opportunity to say good afternoon to Dr. Parikh sir, because I can see him here. Sir,
yes. Good morning. Good morning. कैसे हो? अभी है लेक्चर या निमट गया?
Sir, over just
over. अच्छा चलो. क्या है अब डॉक्टर जितेन बोरा वाला है?
Sir, this is Dr. J.S. Bajaj Hall, and yes. Sir, we have our scheduled session at 13:30, so we do have some time for discussion. If Parikh sir or Deepak sir or Meenal ma'am would like to add on something to the type 1 symposium.
Dr. Manoj Chawla has joined. Let us have his comments.
Good afternoon,
Manoj sir. If you have any comments, please.
And because we have time, Dhruvi, interestingly, the listing or the drug list is huge. If you talk of adjunctive therapy or the newer, actually the topic was adjunctive therapy. Yes. If we talk of the newer frontiers or the drugs on the horizon, which are still not out in the market, but there's a huge list. Right from the molecular level. Right from the molecular level, I talk, like from the cell-mediated immunity to the T-cell immunity, the immunomodulators, and there is a huge list of molecules which are still in the pipeline, which are, if really, whenever they will be with us to practice, it might change the entire scenario of type 1 diabetes management. And hopefully we see the very bright future. Maybe we can prevent all the complications and we can give the entire lifespan to our children.
Looks very, very promising, ma'am. And, we all know that all of these adjunctive therapies are along with insulin. So I think it is very important that it comes from you, that you said it very specifically, insulin band mat karo, you have to start it with insulin.
Yeah, insulin, because basically all these children are insulinopenic children. So we need insulin in any case for the basic metabolism, for the carbohydrate metabolism, and the basic metabolism to stay on carbohydrate metabolism. The minimum amount of carbs is required for the basic enzymatic activities also. Even for the thyroid functionings, we require some carbohydrate. We can't just say stop carbs totally. We can't go for very low carb diet always, especially in children. So we need some 50% of the total calorie intake in form of carbohydrates. And for that carb metabolism, we all need insulin. So insulin can never be stopped or replaced. But yes, insulin can also be assisted in terms of all these molecules till we don't have a proper transplant, maybe functional, where we can have the beta cells and we can have the endogenous insulin production.
Ma'am, the simple answer is insulin can be sensitized and empowered, but not replaced.
Yes.
Simple.
Right, sir. Very rightly said, Deepak sir.
Ma'am, we have one question in the chat box from Dr. Arun Kedia, sir. He's asking you if you have any experience with AGIs in type 1.
We have some experience with
AGI.
AGI. Yes, AGI is another molecule which is approved, sir, and which is being used. Very correct. AGI is just like Metformin. They are the molecules which, like the Voglibos or a Carbos, we are using them just to give them patient a sense of satiety, delaying gastric emptying, and stopping the food craving. So they are also being used and recommended and approved for type 1 adjunct therapy again. So there was another word in the chat box about the biological molecules. So biologicals are also on the horizon. Very soon we might have them in the market for use. They are still not approved or in the market, but as I told you, there's a huge list. I actually did not bring that list. Otherwise, there is a huge list of biologicals also which are on the horizon, which are being worked upon with.
Thank you so much, ma'am. Any comments from Deepak sir, and one last maybe closing remark from Meenal ma'am and Deepak sir, and we can close this session now.
I think no comments, we can close the session.
Thank you, Deepak sir. Meenal ma'am, any closing remarks? And we have the next two speakers.
Type 1 children, Dhruvi, the most important remark that I would request, like as a team, we should work is that we do lose them very frequently for follow-ups. We see them after they are lost for 1 year or so, and then they come suddenly with very high HbA1c. So education is most important for the patient level and at the parent level. Then the alternative therapies need to be explained that they will not work in type 1 children. Insulin is the only treatment. Everything else comes as adjunctive, regular follow-up, even making them aware for complications, because just like type 2, they will also end up with retinopathies, nephropathies, neuropathies, and all macrovascular complications. And at a younger age when not expected by the general population. So the macrovascular complications like the MI can happen at a very younger age in type 1 children, where the type 2 will not be even expecting it, or the young adults will not be expecting it. So patient education becomes the most important part of type 1 children and the management, a good glycemic control and a regular follow-up.
Thank you so much, Meenal ma'am. Thank you for taking, the leadership, and the Type 1 Symposium indeed was very, very interactive because you made it so interesting and to discuss about. Thank you so much, ma'am.
Thank you, Dhruvi. Thank you, Deepak sir. And thank you, Dr. Bansi, once again. It was really nice being here. I wish I would have been in Goa and with you all, but I'm so sorry. Thank you so much.
We'll miss you, ma'am. All right. So thank you so much again to our chairpersons and our speakers of the Type 1 Symposium.
22% of patients with diabetes have period.
Thank you. Ria, could you look into the matter, please? And Ria, could you also call up Dr. Parikh sir, because he was here.
Individuals who do not have diabetes. Just to show you that poor glycemic control leads to macro.
Thank you once again for looking into the glitch. I think Mayank or Ria, both of you, can you please look into why this is happening again? And since we have our first speaker for the next symposium, what nation wants to know, makes me sound like one of the journalists from a very, very leading news, news channel. And we are here today with three very, very eminent speakers. The chairpersons of this session are Dr. K.K. Parikh sir, who is an MD and senior consultant physician from Kota, Rajasthan. He has been a mentor to a lot of doctors and physicians. And the second chairperson is myself. I'm a consultant diabetologist for Rudraksh Institute of Medical Sciences from Ahmedabad. So I think Parikh sir hasn't connected yet. So can I have the pleasure of introducing our first speaker, Dr. Jiten Vora sir? RX team, okay, thank you. Thank you for the slide. Jiten sir is a professor at the University of Liverpool and is a consultant physician at the Royal Liverpool University Hospital, and he specializes in diabetes and endocrinology. He has gained his qualifications from the University of Cambridge, and he has a lot of qualifications and degrees to his name. He has ongoing research interests, which include development, screening, and treatment of diabetic retinopathy, renal hemodynamics, and hypertension in type 2 diabetes. the prevention of renal disease and diabetes, and the physiological aspects of treatment of type 2 and mechanisms of osteoporosis. He has published extensively in the field of diabetes and endocrinology and has served on many advisory panels, including the NICE guidelines. With that, Jiten sir, can I take a moment to welcome KK Parikh sir? He has connected with us. Parikh sir, we've just introduced our first speaker, and Namaskar sir. Sir, if we have your permission. Jiten sir, yes. Sir.
Yes, we can start. Yes.
Thank you, sir. Jiten sir, if you can share your slides now. We did see a part of your slides a minute ago.
Can you see them now?
Not yet, sir.
My screen is being shared.
So could you try once again by stop sharing once and then try and reshare the thing again? Yes, we can now see your slides, and it is in full screen.
Full screen.
Yes. Yeah.
Excellent. It's always a moment of hesitancy when you're trying to share your screen. But thank you very much. Thank you for your very kind introduction. It's always a pleasure to participate in Diabetes India, and I'm grateful for your invitation again. I'm honored, and it's a great privilege. It's a pity that we're not in Goa, but there we are. Next year, perhaps. So in the next few minutes, I want to emphasize on the organ benefits of SGLT2 inhibitors. The reason for this presentation or this title is that I am frequently asked the following question for patients with diabetes. And that is, who should have SGLT2s, when, and why? And so over the course of the next few moments, I would like to present some data and information and then try and answer the question at the end of the presentation. I realize that you will be seeing quite a lot about SGLT2s through the course of this meeting. So mine is an overview rather than a concentration on any specific databases. So in order to try and answer the question that I have posed, I'm going to cover SGLT2s in renal disease and heart failure as an example of the organs. But we're going to try and address potential primary prevention in people with type 2 diabetes. And then we're going to look at the delay of progression and or potentially the regression of renal disease and heart failure. And then finally, we will summarize with the findings and also try and address the initial question that we have posed. So firstly, it's not important to emphasize to an audience such as this that CKD is very common in people with type 2 diabetes. Regardless of how you measure it, and that by that I mean either eGFR and or albuminuria together, somewhere of the order of 40 to 50% of people with type 2 diabetes will develop a degree of renal disease. Those who develop renal disease have an increasing mortality, and the mortality increases with each stage of deteriorating renal function. So a development of an avoidance of development of renal disease as well as a possible retardation is important for these patients. Now, all of this information started off with the publication of these 4 trials, which were essentially safety trials. And you will see here the renal composite endpoints in the EMPA-REG, CANVAS, DECLARE-TIMI, and the VERTIS trials. And the remarkable thing here is the consistency in the benefit that's seen with this class of drugs. So each group, each drug in each trial demonstrated a hazard ratio of somewhere between 0.55 and 0.66. So these reduce the renal composite endpoint by somewhere of the order of 40%, absolute relative risk reduction of somewhere of the order of 40%. And it is important from this perspective that these studies, the patient population included a broad range of people with type 2 diabetes, including those who had established cardiovascular disease. The trials were enriched for cardiovascular disease. But from a renal perspective, there was a broad range of patients. So this reduction, the relative risk reduction of 40% in a broad range of patients, is very applicable to our clinical practice. So let's then move on to this potential primary prevention. Here is some data from the DECLARE-TIMI trial. And in this trial, you will remember that some 60% or so of patients did not have established cardiovascular disease and were therefore in the early spectrum of type 2 diabetes. This is exemplified by the fact that their mean eGFR was 85 and very few people had microalbuminuria. Thus, we are talking about people who did not have renal disease or were at a very early of the spectrum of renal disease. And even in this group of people, the hazard ratio was reduced to 0.53. So this to me means that there is an element of prevention, either in development of early or progression of early disease by approximately 50%. So this implies that there is a degree of prevention, a primary degree of prevention of renal disease in this patient population with SGLT2 inhibitors. Likewise, if you look a little bit more closely into the data from, say, for example, here, the EMPA-REG and CANVAS population, you find that new onset of microalbuminuria, that is early abnormalities of urinary albumin excretion, or macroalbuminuria, that's established nephropathy by our previous criteria, is reduced by some 50% relative risk. So these two together mean to me that giving people SGLT2s early in their treatment for type 2 diabetes produces a degree of prevention of development of renal disease in type 2 diabetes. So it exemplifies the early use of SGLT2s in this patient population. You will also know that the renal benefits of this class, particularly in here, EMPA-REG and CANVAS and DECLARE, was seen regardless of the baseline eGFR. So here we have eGFR starting at the top with the highest eGFR, and thereafter, as we go down, the GFR is declining, and yet you will see that there is a consistent relative risk reduction of 50 to 60% in the composite renal endpoint in all of these studies. The same is true for regardless of baseline albumin-creatinine ratio. Here, we look at urinary albumin excretion rising from, as we go down from the top, we go from normal albumin excretion, increasing to abnormal albumin excretion at the bottom. And you will see that the relative risk reduction is maintained in those who had a normal albumin excretion rate to those who had a significant albumin excretion rate. So the renal risk benefit of these compounds is present regardless of your baseline renal function, regardless of whether it's measured by eGFR or by albumin-creatinine ratio. So for a renal risk in patients who do not have established renal disease, we have so far seen some data of potential primary prevention and renal benefit in any group of patients even before they develop persistent proteinuria or nephropathy. And this is also exemplified if you look here in the renal, in the albuminuria patterns in these studies. So here we have the three studies, DECLARE-TIMI, CANVAS, and EMPA-REG. And you will see that as we go from the top, which is primary prevention. And this shows you that the level of protection that is achieved for proteinuria levels going from normal to abnormal. And you will see that there is a 1/5 reduction in patients developing abnormal proteinuria who had a normal protein excretion at the onset of the trial. So again, there is some evidence of primary prevention. If we then extend this to progression of established disease, either you have normal or microalbuminuria, which goes to macroalbuminuria or microalbuminuria, you will find somewhere of the order of 1/4 to 1/2 reduction of progression of abnormal proteinuria. And the key issue here is that there is somewhere of the order of half regression of proteinuria to the level before the level that you had at the trial's beginning. So we have evidence of delayed development of proteinuria. We have evidence of development of delaying progression of proteinuria, and we have evidence of retardation or regression of proteinuria. Now, you all know, of course, that if you want to protect the kidney, you need to either reduce or regress proteinuria levels. So again, this gives you information of potential primary prevention as well as renal benefit throughout the spectrum of renal disease in type 2 diabetes. So what we've seen so far is eGFR data, real composite endpoint data, proteinuria data that shows potential primary prevention of development of renal function in type 2 diabetes, as well as potential reduction in the progression and some regression to the level prior to the level at the start of the trial. All of this means that the kidney is protected. And you also know, of course, that if you protect the kidney, then you reduce the otherwise increasing cardiovascular mortality that is seen in patients with the development of different progressive stages of renal disease. So now let's move on very briefly to people who already have established renal disease. And here is data from the DAPA-CKD trial, showing you in patients who have a mean age of 62, a median GFR of 43, and approximately a gram a day of proteinuria. The use of dapagliflozin in this case versus placebo resulted in a hazard ratio of 0.61, meaning that there was a 40% or so relative risk reduction. And if you look at the curves, it takes approximately 8 to 12 months before these curves begin to separate, which is very different from the curves that we will see for heart failure in a moment. Now, if we specifically look at renal disease, then you will see that similar 50% or so reduction in renal risk. Now, the previous graph was a composite which included CV death. This is a figure that looks at just renal function. The differentiation between the two is important because, as you well know, majority of our patients with type 2 diabetes who develop renal disease die of cardiovascular disease even before they go on to dialysis. So the initial slide is important because it shows a reduction in cardiovascular mortality as well as renal changes. And this figure is important because it shows a 50% relative risk reduction in the progression of already established renal disease. The same was true for the Credence study using canagliflozin in people with diabetes with a mean GFR of 56, and again an albumin excretion rate of approximately a gram of proteinuria a day. And you will see again a consistent reduction of approximately 40 to 50% in the hazard ratio for the renal composite endpoint. And both the hard points of doubling of serum creatinine and end-stage renal disease demonstrated a reduction. So what does this all mean in terms of the outcome for patients with type 2 diabetes who have established renal disease? First of all, it means that we are protecting them from cardiovascular disease, so that the patients who are dying because of increased CVD, which increases as renal disease deteriorates, we are reducing their cardiovascular disease. But more importantly, we are reducing the rate of progression of renal disease. And what does that actually mean? Here you look at the modeling data of the Credence study, and what it essentially shows you is that use of Credence versus placebo in this study resulted in a 15-year delay in dialysis. So if you have a patient with type 2 diabetes with established renal disease, GFR of 55, proteinuria of a gram a day, the use of an SGLT2 will delay the use of dialysis by 15 years. That has great implications for not only patient-related outcomes, but also from the perspective of cost efficiency. So let's move on now very briefly to cardiovascular outcomes. And you are, of course, all aware of these trials. Here we are summarizing some data from the four main trials, EMPA-REG, CANVAS, DECLARE, and VERITAS. And you will see, first of all, the heart failure ratio, the hospitalization for heart failure, which shows a consistent reduction in hazard ratio to approximately 0.65 and 0.7. And we're going to be looking at this data in a little bit more detail in a moment. What about CV death? Different trials with different patient populations and different primary outcomes and different statistical analysis. But you will see that empagliflozin in a group of patients who had been enriched with cardiovascular disease for the trial revealed a reduction of approximately 40% hazard ratio in CV death. The others did not show this because the patient population was very different, the analyses were different, etc. Similarly, in 3-point MACE, it's difficult to show an analysis because of the different populations. And indeed, particularly in Canvas and Declare, this was not a primary statistical endpoint. It was used as an exploratory endpoint. So 3P MACEs were not used predominantly in these studies. So let's turn our attention to heart failure. Again, we go back to the 4 main trials, and you will see here hospitalization for heart failure in all 4 trials shows approximately the same 0.4, 0.35 reduction in hazard ratio. So there is somewhere of the order of 30 to 40% reduction in relative risk of hospitalization for heart failure. Now, this was for hospitalization for heart failure as a first episode, but also as a potential repeated episode. And what we're interested in from a potential primary prevention perspective is what does it do? What do these agents do if you did not have a history of heart failure? So here at the top of this figure, you will see that patients who had a pre-existent history of heart failure demonstrated a hazard ratio of around 0.7, suggesting that it reduces the risk of further episodes of heart failure. Whereas at the bottom half of this curve, of the graph, is people who did not have a history of heart failure. So they had no pre-existent heart failure. And in these patient groups, the first episode of hospitalization of heart failure was reduced by approximately 30%. So again, there is an element of quotes, organ benefit, primary prevention, in that you can stop the development or delay the onset of the first episode of hospitalization of heart failure. Now, people have frequently questioned what the hospitalization for heart failure means, particularly the first episode. We have to remember here that in groups of patients that we are studying who do not have pre-existent heart failure, unless we are constantly looking at BNPs and echocardiograms, the first episode of hospitalization of heart failure is used as a surrogate for the first episode of heart failure. So this time to first heart failure is important. And here we have all the big trials with SGLT2s, and we're looking at the time to the development of first episode of hospitalization for heart failure. And you will see a consistent benefit with a relative risk reduction of approximately 40% in the time to first heart failure. And again, this gives you an idea, an emphasis on potential prevention of the development of heart failure or potential delay in the development of first episode of heart failure. So far, we've seen data from the 4 main trials of prevention of hospitalization for heart failure in a broad range of population of type 2 diabetes. We've then seen some data that the time to and the occurrence of the first episode of heart failure is prevented in all of these patients. So what about people who already have pre-existent heart failure? And here I'm summarizing the data from the 2 big trials, the EMPEROR reduced with empagliflozin and DAPA heart failure with dapagliflozin. And you will see a consistency in the results. And you will see that at the top half, particularly for this presentation, in patients with diabetes, there is a 25% relative risk reduction in people who have established heart failure in the development of next episode of heart failure or the development of CV death. So here we're looking at the composite of CV death and hospitalization for heart failure. A consistent result in both those main trials showing you a reduction of approximately 25%. This information is present in patients with diabetes, and the result is consistent in people without diabetes, which gives the whole physiological basis for the treatment credibility. The benefit is seen in people with diabetes with or without EGFR reduction. The other component of these trials that's important to recognize is what happens to renal function in the heart failure trials. Now, we're all aware of the fact that in patients with heart failure, declining renal function is seen frequently, which limits therapy. The reverse is also true, which is in patients with renal disease, we see heart failure frequently. But here what we are seeing is the data in hospitalization for heart failure in patients who already had established HFrEF. And here we can see an approximately 30 to 50% relative risk reduction in the development of a renal composite endpoint in a heart failure trial, in a HFrEF trial. So the renal benefits that we saw earlier in my presentation is also maintained in patients who were in the trial, in a heart failure trial. And this would mean that you would be able to continue the therapy in more patients because you have reduced the development of a persistent decline in GFR, a sustained decline in GFR. So again, we have evidence of, in this group of patients with heart failure, and evidence of renal protection, allowing us to continue with appropriate therapies for longer. Now, in the last few slides, I just want to mention some data that's recently become available in preserved heart failure. So the data we saw recently, the last few slides were in HFrEF with an ejection fraction reduced below 40. We are here looking at patients who have HFpEF, which is an ejection fraction above 50. This is a much commoner heart failure, but is associated with many more comorbidities. In this group of patients, there is much more respiratory disease, much more atrial fibrillation, much more evidence of insulin resistance. So the comorbidities are many. Regardless, up to now in HFpEF, there has been very little data of medications to reduce hospitalization of heart failure or CV death. And here we are looking at data with empagliflozin in HFpEF for the primary endpoint of CV death or hospitalization of heart failure. And you will see that there is a relative risk reduction of 20%. This risk reduction occurs really almost immediately the therapies are commenced, just the same as they are in HFrEF. If we then look at this potential of first heart failure, as we've discussed, this may be a surrogate for primary prevention. If you look at the right-hand panel, you will see that the first episode of HFpEF in the trial with empagliflozin is reduced by approximately 30% relative risk. So this again gives you an emphasis that there is an early involvement in the pathophysiology of HFpEF, potentially preventing or delaying the time to the development of first episode of hospitalization for heart failure. Now, it's important to try and compare the effects of the SGLT2 classes in HFrEF, ejection fraction below 40, and HFpEF, emperor preserved, with an ejection fraction above 50. So here you can see the two set of results. And the striking feature here is the similarity of the results. You will see the hazard ratio reduction of composite CV death and hospitalization of heart failure by 25% in both trials, the time to first heart failure by approximately 30% in both trials, and the time to recurrent and hospitalization of first and recurrent heart failure reduction by approximately 30%. Important to note that when you look at CV death alone, you do not see a benefit in these two studies. So there is a similarity in the results, which reiterates, therefore, the potential pathophysiology of this benefit. Now, in the 20 minutes or so that I had, I could not cover the mechanisms of this benefit, and I'm sure that this will be covered through the course of the next 2 or 3 days. So what is the benefit in terms of patients? How does this translate for us in clinical practice? And here you will see that in the right-hand panel, that you have to use these therapies in very few patients for a very short duration of time to achieve the benefit that's accrued. So these are cost-effective, patient-effective, patient outcome effective, very effective drugs to use in heart failure. So how is this changing the ethos behind the management of heart failure? And the guidelines are now changing completely, whereas previously we had a stepwise approach. And now the guidelines are telling us that all 4 therapies, beta blockade, mineral receptor antagonists, RAS blockade, or ARNI, and SGLT2s should be initiated simultaneously at the diagnosis of a heart failure. And thereafter, therapies should be increased according to tolerance. Now, if you do this, what you see is this benefit. So here we have the relative risk reduction of each of the classes of the therapies: ARNI, beta blockade, MRA, and SGLT2s. But the top part of it is if you have no therapy, the 2-year mortality is 35%. If you have quadruple therapy, as we have just mentioned, the mortality is reduced to 10%. So a huge effect in this group of patients. So in my last slide, in terms of renal disease, this group of therapies seems protective at all stages of renal disease, from prevention of development as well as progression and renal death. From the heart failure perspective, it improves cardiovascular outcomes, primary cardiovascular endpoints in HFrEF, primary first admission with development of HFrEF in people with or without pre-existent HFrEF, with or without diabetes, with or without CKD, and regardless of baseline therapy. And finally, we also have positive results with HFpEF predominantly related to hospitalization for heart failure. So in response to the question I posed early, who in type 2 diabetes should have these therapies when? I would suggest that all patients with type 2 diabetes should have an SGLT2 inhibitor in their therapeutic regimen. If you're not on an SGLT2, you should be on one. Thank you very much.
Thank you, Dr. Vora. It's an excellent review of SGLT2 inhibitors. Dr. Vora, we know, is a professor of Royal College, Liverpool Hospital, and he's a very skilled and experienced clinician and teacher, and an outstanding orator. And very nicely you have dealt the renal and as well as cardiac protection with SGLT2 inhibitors. I think it's a molecule of last decade that has revolutionized the treatment of diabetes as well as the protection from the cardiorenal point of view. So progression of cardiovascular disease, renal disease is one of the very important parameter in diabetes. So thank you very much. If there are any questions, Dhruvi, can we?
Sorry, sir, there are no questions yet in the chat box, but we have a different discussion session allotted for 15 minutes at the end of the whole session after all the speakers are talking.
So thank you, Dr. Vora. If you are available for the discussion, we'll have in the last, and it's an excellent lecture, and you have talked very nicely. The CVOT brought all these two molecules, SGLT2 and GLP-1, that have been benefited in diabetes with all complications, renal and cardiovascular complications that are more important. So thank you, so nice of you. Thank you so much.
Thank you very much. Pleasure.
So our next speaker, Dr. Eberhard Stent, he'll be talking on heart failure, role of diabetologists tackling a multidisciplinary problem. This is a very important topic because diabetologists also have a responsibility of tackling the problem of cardiovascular and heart failure. So we are very eager to listen. Dr. Eberhard is a professor of medicine, endocrinologist, past president, IDF Europe German Diabetic Association, past vice president, European Association of Study for Diabetes and International Diabetic Federation. So thank you very much for sparing your valuable time. So we go on for the talk by Dr. Eberhard. Good afternoon.
Good afternoon, and thank you very much. Will do the technical things, sharing my presentation, which should be here. Okay, and this should be now on presentation mode. So you can hear me and you can see my slides, okay?
Yes.
Okay.
Yes.
Once again, thank you very much. My name is Ebert Standl, and as just mentioned, I'm an endocrinologist, but also an angiologist and fellow of the European Society of Cardiology. So I've been working in this interface between metabolism and vascular disease during a long time. And I'm very pleased to highlight heart failure with preserved ejection fraction, the role of the diabetologist tackling a multidisciplinary problem. And my task, of course, has become so much easier after the brilliant talk we just heard from Chit and Vora. So I have disclosures in trials, lecturing, but also recent publications like Heart Failure at the Crossroads, Diabetology, and of course I will come back to those publications. Now, first of all, I think it's important in this context to understand the so-called common soil concept, type 2 diabetes, at the same time with cardiorenal complication. And the concept indicates that the same cluster of risk factors, this metabolism, insulin resistance, low-grade inflammation, oxidative stress, etc., actually is driving the development of type 2 diabetes, the manifestation, but parallel to that, at the same time causing damage to the heart and the kidney, and the two organs, of course, speak to each other, so there are a lot of potential for a vicious circle. But the most important thing, all can occur simultaneously. And this is also proposed in this recent novel unifying pathophysiological concept, linking hyperglycemia, free fatty acids, other risk factors like iron metabolism, I should underline, the antioxidant system, and lipid oxidation. And this induces so-called ferroptosis. This is a programmed premature cell death occurring at the pancreatic beta cell, driving diabetes, but also harming at the same time cardiac cells, leading to cardiomyopathy, renal damage, nerval damage, retinal damage, and also bone damage. And on the right side, some pathways are indicated and opening new avenues of research, actually trying to manipulate this iron metabolism and overload and trying to really find new approaches to prevent those complications. Well, as we all know, and it has been mentioned before very often, cardiorenal complications are the first manifestation of cardiovascular complications in type 2 diabetes. And as you see across all the countries listed, the blue lines are the cardiorenal events, and they by far go beyond the red lines, myocardial infarction, peripheral artery disease, etc. But also the point is very, very early. In fact, it can be there at the diagnosis of type 2 diabetes. So it's very, very early. And if you have it, it means really very bad news. Looking here at all-cause death in conjunction with heart failure, your all-cause mortality is more than twofold increased. In cardiorenal syndrome, it's even threefold. And in terms of cardiovascular death, the figures are 3 to 4-fold increase of mortality due to cardiovascular complications. So it's early, and it means bad news in terms of premature mortality. This is a contemporary huge population from the UK. The interesting things are really the very high incident figures. They are telling us that 1 in 2 people with type 2 diabetes will be diagnosed with chronic kidney disease in the lifetime, so 1 in 2. So consider right now worldwide, the estimate for global diabetes is around 460 million. So we're talking here about 230 millions of people getting kidney disease, but in my context, also 3 out of 10. Now, this would mean the global burden, 150 million people out there which will develop, who will develop in the next years heart failure. So it's very clear that every doctor who looks after people with diabetes has to be aware and has to be part in trying to cope with this tremendous challenge. And here we see some more details. If you are starting free of that, these are the 50 and 60%, etc. I was talking about. But if you start with CKD, you see the high prevalence of heart failure in yellow, and also premature cardiovascular death. But if you start with heart failure, it's even 60% of premature cardiovascular death, and also 60% with kidney disease. So I'm not talking too much about numbers, but it's very striking in all the trials out there that prior myocardial infarction in cardiovascular outcomes trials occurring also correlate very closely with the development of heart failure. And as you just heard, it's usually defined as heart failure requiring hospitalization. So this is the ischemic contribution to heart failure in diabetes. But of course, it's also going far beyond that. There are specific factors, including also what we see in the context with kidney disease, both reduced GFR, and here we are looking at the risk of hospitalization for heart failure, which really correlates with impaired kidney function, but also with increasing albumin excretion in the urine, again, showing the close interrelationship between the kidney and the heart. And as we all know, the heart is able to speak to the kidney via the natriuretic peptide system. Now, first of all, this is something inducing natriuresis and diuresis by complex mechanisms at the kidney, but this can be measured and quantitated. And at the same time, the kidney will respond with activation of the sympathetic nervous system and also activation of the RAS system. So very early on, there is the induction of this vicious circle, but the opportunity here is that we are able to look for this increase very, very early. And it's important to understand that very often in diabetes, like here, the shortwave study indicates that the first abnormalities is so-called diastolic dysfunction. And on the left side in this pie diagram, you see some subgroups on that. So diastolic dysfunction. And this is very tricky often to really diagnose. And the recent guidelines actually tell us here on the right side, when we go for the subgroups, actually HFpEF is above 50 left ventricular ejection fraction, recently mildly reduced ejection fraction, 40 to 50, and HFrEF is below 40. And there's what's indicated here that increased increased left ventricular filling pressure correlates very closely with the rise in BNP. So we are actually able to pick up early, to sense early the development of left ventricular dysfunction. They also give you cutoffs here for NT-proBNP, which can be measured, has a longer half-life, and the active hormone BNP, so the 35 and the 125. And what's it's very important, of course, we always have to realize the differential diagnosis of heart failure, chronic coronary artery disease, hypertension, valvular disease, arrhythmia. Very often, absolute arrhythmia is a problem in that. And what's important to pick up early is the signs and symptoms of heart failure related to breathing abnormalities, of course, in the resting position, but on exercise, but also looking at an increased neck vein distension and also doing the hepatojugular reflux. So one is easy by very simple means to look into that. And what's also important that in the guidelines now, the ranking going for this natriuretic peptide measurements is very up on the list, followed by ECG and also already done with imaging. And in practical importance, the negative predictive value of those patients. If it's below that, it's very unlikely. The specificity is close to 100% that those people will have heart failure. So the new concept, the shift in paradigm, is now to narrow down the gap between current intervention, as just outlined by Professor Chitandwara, to the time point of the earliest detectable changes. And this is biomarker based, even before you definitely find major structural changes. So we have on the one side the clinical context, coronary artery disease, hypertension, which in diabetes, driven by cardiac and cardiovascular disease, lipoglucotoxicity, cardiac fuel overload, and renal glucotoxicity drive the heart across the diabetes risk continuum all the way to heart failure, hospitalization, and cardiovascular death. Here we have the specific diabetes aspect of cardiometabolic myopathy, cardiomyopathy, and the kidney leading to fluid expansion. So there is actually an expansion of intravascular circulating volume, glomerular hyperfiltration, sympathetic nervous system overdrive, and hypertension. Of course, the diabetologist is always interested, what about glycemic control? And yes, in terms of heart failure, as you can see in this red line or range, it is a predictor. But as we all know, the disappointing aspect earlier with the so-called mega trial as listed here, including UK PDS, showed that intervention, at least in this definition used there, was not successful. So this was disappointing. On the other hand, looking from today, we understand probably the wrong drugs had been used. There was a lot of insulin with the potential of fluid retention. There was a lot of actually rosiglitazone, 90% in some of the trial were on rosiglitazone, and also a lot of sulfonylureas. And as we just heard, of course, in this context, SGLT2 inhibitors, and I have listed here, the trials are now the recommended drugs. So the situation has totally changed in that. So in this context, looking or focusing on heart failure with preserved ejection fraction, you already have seen the major outcome here, heart failure, hospitalization, or cardiovascular death, very significant 21% reduction. And what is very important also, the number needed to treat for that is around 60. So in this situation, it's a reasonable margin. It's much higher when you look at the numbers needed to treat in heart failure with reduced ejection fraction, where the numbers needed to treat are down to 20 or even below 20. So patient values are very, very important when discussing the benefits of these novel drugs here. And here, again, we see that this effect happens regardless of diabetes. So diabetes as such in HFpEF has no specific other outcome in relation to SGLT2 inhibitors. And down below, you also see the spectrum of left ventricular ejection fraction. And actually, it should be pointed out in Emperor preserved, including heart failure with mildly reduced ejection fraction. So this is the most striking group. But meanwhile, it's very, very clear that probably it's regardless ejection fraction where those SGLT2 inhibitors were. Okay, so if one looks at the meta-analysis, which gives you some different ranges, but a very clear picture of 22% reduction, and as very recently, there is the DELIVER study. And this is using dapagliflozin. We yet have to see the data, but according to the recommendations, the companies have to release the reaching the major outcome results first, so we know that a second study, Emperor preserved, but also the DELIVER study show the same thing. Now, what does that mean? And recently on this background, the guidelines in cardiology, this is looking at the American guidelines. Previously, we started to discuss with stage 3, symptomatic heart failure, but now the stage A, so this is aiming at risk for heart failure. People without symptoms or signs, no visible functional things, but this is based on risk factors. Hypertension, CVD, I showed you why, diabetes, obesity, and then to be on the alert for pre-heart failure. And this is using the BMP levels and also troponin if necessary. So that means we can start therapy much more earlier. And actually, SGLT2 inhibitors in this cardiology guidelines have the first major player, even before other drugs come in. But with the development, you maintain always SGLT2 in a holistic approach together with ACE. So you're doing the same thing together with beta blockers, but also mineralocorticoids in an antagonist as mentioned. And regardless of left ventricular ejection fraction, and there is the prospect of also another change of paradigm. So if we are so sure across the whole spectrum of ejection fraction, that means we don't need right away imaging. Of course, it's very well indicated, but we can start the prevention earlier, even without the full imaging demonstration of heart failure. And so this is a summary what happens in patients with diabetes. Of course, if heart failure is known, it's a different situation. You always check for chronic kidney disease. If you start with the risk factors, then the BMP measurements together with echoes, but also ECGs are very, very important. And also silent ischemic heart disease is very important to be taken into account. And I would subscribe. Probably all of people with type 2 diabetes should be, if it comes to therapy with glucose-lowering drugs on an SGLT2 inhibitors. And in terms of the precision medicine, if you fail to reach targets, probably in combination with a GLP-1 receptor agonist. So what is the role of the diabetologist, endocrinologist in this multidisciplinary treatment paradigm? Assuring diagnosis of heart failure. And 90% or so of all people with diabetes are seen in primary care or by family physicians. So, of course, it's a huge load, but there are also very useful point-of-care measurements right now. So it is possible. Of course, it's some investment, but in the midterm range, the benefits outweigh by far the costs. Assuring compliance with the cardiologic therapy, addressing the appropriate cardiometabolic approach, including education, of course, and also helping people to do some reasonable exercise programs, which is helpful in heart failure patients, and then tailoring the appropriate glucose-lowering therapy, and cooperation with cardiologists and also nephrologists. So it's a huge challenge, a huge burden out there, 150 million people worldwide with this problem, and I hope this lecture was some kind of helpful in making progress in this area for the many people with diabetes. Thank you very much for your attention.
Thank you very much, Dr. Aberhard. A wonderful message given to the diabetologists that we must look in every patient of diabetes, possibility of heart failure, and with the appropriate cardiometabolic approach, we must know at what stage of heart failure the patient is. Also, the relationship between heart failure and kidney disease, it is also very important to know about the renal functions, and we must take in consideration the advice of a nephrologist and cardiologist to treat a patient with a appropriate drugs which reduces hyperglycemia also. So it's really a great message to the diabetologist also that we must look for the cardiovascular problem and renal problem also with the diagnosis of diabetes or hyperglycemia. So thank you very much, Dr. Stender. Excellent deliberation. We are very grateful to you for your lecture, and it's really a wonderful message and a great message to the diabetologist. Thank you very much, sir.
Okay, my privilege and pleasure. Thank you.
So next, the last lecture of this session by Dr. Sarita Bajaj, who is a wonderful orator, former director and professor, head of the medicine department, MLN Medical College, Prayagraj, president of RSSDI, past president of RSSDI, president of Indian Thyroid Society 2022, and still she's there, founder president of South Asian Federation of Endocrine Society, and Professor Sarita Bajaj Oration 2018, she started in RSSDI UP chapter. She delivered several prestigious orations, established Diabetic Education Foundation, Prayagraj. Areas of interest are thyroidology, diabetic education, and growth disorders. She is a wonderful teacher and an excellent orator. Over to Dr. Sarita Bajaj. I think she is not.
Yes, sir.
Yes, but
today I will.
Yes, the lecture is there. Pre-recorded lecture is there, so yes. We can start that lecture.
We'll be talking about the teeth reflecting our cardiometabolic status. This is a roadmap I'll be following from the oral manifestations to the correlation with hyperglycemia, the associated cardiovascular risk, association with microangiopathy, present some of our data and what should be the research agenda ahead. I have tried to list here all the oral health-related conditions associated with diabetes. The common ones I have highlighted. Remember that all, of course, you may not even see all of them in some of the patients, but the majority of patients, if you question them, they would have one or the other of these complaints. In fact, just the other day, I had a patient who was complaining of alteration in the taste, very significant alteration. In fact, that was his major complaint of presentation, despite the fact that his blood glucose was well controlled. The other reason I'm not going through this list is because what I will be doing is showing you photographs which will themselves depict all these clinical features. So what are the mechanisms and interrelationships? It could be because of immune dysfunction, side effect of drugs, peripheral neuropathy, salivary gland dysfunction, low salivary flow and or increase in the salivary glucose levels, and oral candidiasis. So this is what healthy gingiva would look like, contrasted with periodontal disease. A brief introduction. Periodontal disease is the 6th most common complication, responsible for poor glycemic control and increasing CV risk. 22% of patients with diabetes have periodontal disease, which increases with age. It is a two-way relationship, and 15% more tooth loss than in individuals who do not have diabetes. Just to show you that poor glycemic control leads to macrovascular complications as well as periodontal disease. So on one side, we have the micro, the macro, and then a list of the oral complications, the very common ones. A two-hit model for the pathogenesis is shown here. So you have periodontal microbiota, advanced glycosylation end product activation, exaggeration and sustained inflammation, impaired repair, which leads to enhanced periodontal tissue breakdown. So just to go into a little more detail how diabetes leads to periodontal disease and tooth loss, I've highlighted the immune responses, involvement of the microbiota, cytokines, glycosylation end products. Poor glucose control leads to increase in the glucose levels in the cervix fluid of the gums. Growth of micro aerophilic anaerobic gram-negative bacteria. The function of the polymorphonuclear leukocytes is impaired. The host defense mechanisms are decreased, again leading to more of bacterial proliferation. Fat metabolism in patients with diabetes leads to increase in TNF-alpha, interleukin-1 beta, and decreases PDGF, TGF, and FGF. There's more of glycosylation products, collagen cross-linking, which reduces the collagen solubility, repair, and replacement. So the end result is gingivitis, reduction in the periodontal tissue, tooth loss through increase in bone cement and ligament damage. A host of microbiota, including viruses, has been listed here. So now just to take you through some photographs, this is localized or moderate gum disease. Again, severe periodontitis in a type 2 diabetic. Severe periodontitis in a 22-year-old man with poorly controlled type 1 diabetes. Severe chronic anaerobic periodontal infection. Enlarged gingiva in a type 2 diabetic. A gingival polyp here and here as well. Severe periodontitis in a patient who has poorly controlled diabetes, who had responded initially. Extensive bone loss, which is better visible in radiographs. This is a gum boil indicating acute infection. Implant, because of the implant, there is inflammation and infection. Dental caries may also be associated. A fissured tongue caused by severe hyposalivation. This is candida, this milky curd-like appearance. This is candidiasis of the palate and candidal-related lesion, that is denture stomatitis. Again, angular cheilitis. This is candidal-related. You can have recurrent aphthostomatitis, lichen planus. Leukoplakia and oral cancer has been described. Temporomandibular joint disorders may also be a manifestation of hyperglycemia. And if you ask the patient to open the mouth, don't forget to look at the foot. If there is periodontal disease, there may also be associated foot disease. So can we say it is a foot and mouth disease? Perhaps yes. Presence of periodontitis predicted a 2 times increase in the incidence of type 2 diabetes. This was a 2-decade follow-up. 5 times increase in the progression of A1C among almost 3,000 diabetes-free participants. So this is some of the data that I'll be showing you. Clinical measures of periodontal infection are associated with increased insulin resistance. The risk of elevated HOMA-IR is increased by 30%, and the status is associated with insulin resistance if the WBC count is higher, as well as a higher CRP. So this was the first study which highlighted the relationship periodontitis to carotid intima media thickness. So the odds of an intima media thickness of 1 millimeter were higher for severe periodontitis and moderate compared with no periodontitis. Again, the results here may indicates that periodontitis may play a role in the pathogenesis of atheroma formation as well as in CV events. Small study, 50 carotid atheromas, 72% of the surgical specimens indicated a bacterial content, and 44% of the atheromas contained at least one of the periodontal microorganisms, which I had highlighted earlier. What about mortality? Death rates from ischemic heart disease and nephropathy were higher with severe PD than in those with no or mild PD or moderate PD. It has been implicated as a risk factor for stroke and carotid atherosclerosis as well, because of the associated endothelial dysfunction in patients with coronary artery disease. Again, the two-way relationship that I was addressing earlier, microalbuminuria is increased 2 times, end-stage renal disease 3 times in diabetic individuals who have severe periodontitis, cardiorenal mortality 3 times higher. But note the silver lining that effective periodontal therapy would reduce your A1C by 0.4%. A small number of type 1 diabetics to evaluate the relationship between the severity of PD and control of diabetes, divided into 3 groups, good, fair, and poor, depending on the A1C. And the result was severity of periodontal disease increased with poor glycemic control. What about the effect of therapy? 30 diabetic patients received appropriate full mouth scaling and root planning with systemic doxycycline. Group B received no treatment. All the periodontal parameters, including serum TNF-alpha and A1C, were significantly decreased 3 months after the non-surgical periodontal therapy. A lot of studies are out there which are showing the effect of periodontitis on diabetic complications and incident diabetes. I'm not going into the details, just to highlight that yes, they're associated with proteinuria, the severity. So this is the study that I was referring to, which has been published in the Indian Journal of Endocrinology and Metabolism. We took 50 cases, they were selected, they had oral complications, and we looked at the oral manifestations and the associated micro and macrovascular complications. These were the oral manifestations, from periodontal disease to oral candidiasis, tooth loss, oral mucosal ulcers, taste impairment, halitosis, xerostomia and salivary gland hypofunction, dental caries, and burning mouth syndrome. So if we look at the blood glucose status, the fasting blood glucose was significantly higher in cases as compared to controls, as was the postprandial. The complications, microvascular complications, were significantly more. Cardiovascular disease was more, in cases compared to controls. However, there was a significant association for neuropathy, retinopathy, and dyslipidemia. And I have listed the p-values here for neuropathy, retinopathy, nephropathy, cardiovascular disease, and dyslipidemia. So several oral complications are seen. Periodontitis, commonest association of oral markers in diabetes and microvascular complications suggests that there is a significant association between the two. Subsequently, we published a chapter. Dr. Sridhar invited us in this textbook, Advances in Diabetes, Diabetes and Periodontal Disease, making the connection. Yes, there is a strong association with smoking and periodontal disease. It's a major risk factor. What about treatment? I have, yes, pointed out that significant improvement in periodontal clinical parameters, which correlated with reduction in the A1C levels as well. Again, very recent data from Japan that glycemic control is strongly associated with the number of natural teeth, and this is in the real world setting. They've shown a continuous relationship between A1C and the fasting plasma glucose with the number of natural teeth. Their data emphasizes the importance of glycemic control and appropriate oral care for the protection against tooth loss. Individuals with impaired fasting glucose are at risk of tooth loss in middle age. So this is showing you across the ages the number of natural teeth loss, which are higher in individuals with higher A1C. This is the number of natural teeth age-wise compared when we look at the fasting blood glucose. The association between smokers and non-smokers in relation to blood glucose, fasting plasma glucose levels as well. So what they've tried to do is emphasize the importance of glycemic control, stopping smoking, and appropriate oral care for the protection of individuals with impaired fasting diabetes against tooth loss from a young age. This is just April 2022, not even a month-old article, which is showing the association between type 2 diabetes and tooth loss. This is a systematic review and meta-analysis. There was a positive association between type 2 diabetes and tooth loss in the cross-sectional studies. Type 2 diabetes increases risk of tooth loss by 1.87 times in unadjusted data and 1.2 times in the adjusted data. Pre-diabetes, I've been talking about diabetes. I did mention tooth loss in pre-diabetes as well. So even individuals with impaired glucose tolerance demonstrate severe periodontal inflammatory parameters. Severe periodontitis was associated with a 93% increase in the odds of impaired glucose tolerance after multivariable adjustment. Pre-diabetics with fasting more than 100 milligram and gingival bleeding are more susceptible to periodontal breakdown compared to those who have lower glucose levels. So the need to refer to an oral healthcare provider. I'm not going into details of the management. It is very well highlighted. And there are also some newer options for treatment as well. I would like to summarize by saying that the association between periodontitis and type 2 diabetes is bidirectional. 1/3 of patients with diabetes have severe PD. American Dental Association says that 1 in 5 cases of tooth loss is related to diabetes, macroalbuminuria 2 times, end-stage renal disease 3 times, cardiorenal mortality 3 times in those with severe periodontitis. Yes, you get a good A1C reduction with treatment of periodontal disease. Very few patients with diabetes visit their dentist regularly. They are unaware of the impact of diabetes on oral health and that diabetes can cause tooth loss. That implies for the healthcare providers as well. And diabetologists should refer their patients for a thorough periodontal exam and dental professionals should keep a check on glycemic status. Oral health should be promoted as an integral component of overall diabetes management. So when we see the A, the B, and the C, the D is the dental checkup, which should be every 6 months. So there are future directions because yes, there's always need to do more. I would end by saying that I have tried to show you that your teeth reflect your cardiometabolic status, and this is what healthy gingiva look like. Pink, firm, should not bleed with brushing or flossing. Thank you. Thank you very much.
Yes, Dr. Dhruvi. Last lecture by
Yes,
Dr. Sarita Bajaj. So she is not present. So wonderful. It's a very clinical lecture and a very important from hygiene point of view. So can we have discussions now? Do we have questions?
None as of now, not in the chat box. I'll just communicate with the RX team in the meantime, sir, if you can take up some.
Yes. Dr. Bora?
Yes, sir.
Can I ask? Yes. Sir, do you think that the clinical inertia of starting early start of SGLT2 is very, very important to decrease this inertia? Because still the clinicians and diabetologists are not aware about the benefit, cardiorenal benefit of SGLT2. So is it because of clinical inertia? Because now there is no cost factor. The cost has come down in India to almost nearly around sulfonylurea. So what do you think, sir?
I think there are a number of reasons. One is that the data hasn't got through as clearly as it is beginning to now and is beginning to gather momentum. Two, there has always been this issue about safety, particularly when the type 1 information started coming out and people said, oh, well, there's this issue about ketoacidosis, and in the past there has been issue about bladder cancers, fractures, etc., which of course we now know are not an issue. And the third thing is that we have spent a lot of time, and a lot of us lecturing today are guilty of this, trying to say, is it GLP-1 receptor agonists or is it SGLT2s? In my opinion, majority of the patients are going to need at least 3 drugs, if not more. And so it's not a question of which you should be using. It's a question of adding in SGLT2s to everyone. Now, so those are the 3 big things in my opinion. The other part of this is there has been an emphasis on the MACE reduction of between 14 and 18% with the GLP-1 receptor agonists in a cardiovascular established enriched population. But what we have not emphasized at all is that with heart failure, increasing heart failure, you're increasing your cardiovascular mortality. With increasing renal impairment, you're increasing your cardiovascular mortality. We know from the UK PDS that if you go from normal albuminuria to microalbuminuria, your cardiovascular mortality doubles. And then if you go from micro to macroalbuminuria, your cardiovascular mortality doubles again. So if you are able to reduce that development and reduce the progression, you are giving a cardiovascular benefit. So whilst we talk about organ benefit, the emphasis of the organ benefit in reducing the cardiovascular mortality has not been emphasized. So I think those are the major reasons that I feel the SGLT2s and GLP-1 receptor agonists have not been taken on. Of course, the issues about inertia with GLP-1 receptor agonists are slightly different and may be changing as oral presentations become more available. But I do think that those are the 3 things. 1, the data hasn't got out. 2, people have been worried about side effects. And 3, we have spent a lot of time arguing about SGLT2s versus GLP-1 receptor agonists, which come first, which comes after metformin, et cetera, et cetera. These are, in my opinion, passé arguments.
How common about urinary infection or fungal infection, which is said to be quite common in those who are using SGLT2 inhibitors? How commonly do you see?
So the meta-analysis all shows that there is a 0.4% increase in genital infections. Now, when I speak to my general practitioner colleagues, they tell me this is not a difficult problem for us to resolve. One, it's talking about public hygiene. It never happens in people who are generally very, very clean or take their public hygiene safely. Two, that even treating this is not a particular issue for us. So there is undoubtedly a small rise. It's an early rise because it's when the glucose level, the hyperglycemia levels are high, but the level of mycotic or genital infections or perineal infections declines with time as glucose levels become controlled. And my GP colleagues tell me it's relatively easy to control. So in my experience, telling the patients, you are likely to lose 3 kilograms in weight, this is going to give you good glucose control versus the possibility, small possibility of an increase of a perineal genital infection. I've never had a patient who says, doctor, I don't want those medications.
Right. So
I would like to make a brief comment.
Yes.
Sorry. Well, specifically when it comes to heart failure and cardiovascular death, we have looked into that, for instance, in the TACOS trial. And most of the time, it's acute sudden death. So it's a very specific complex you are talking about. It's not the typical cardiovascular myocardial infarction or this type of thing. So it's acute sudden death which you are preventing, and of course this impacts largely also on the mortality. And for that, the numbers needed to treat are very, very useful. They are down to around 20 patients you need to treat at those with heart failure, with coexisting heart failure, to prevent one acute cardiac death. And so in my mind, this is a very significant progress for that. But it's also true if people have a prior myocardial infarction. For instance, people in DECLARE TIMI have looked into that. So if you have a prior myocardial infarction, especially within the last year, you have a very significant reduction of MACE. So it's always the context, the comorbidity, when those drugs are working. But again, if you have a patient, and very often the distinction is made, go for a GLP-1 receptor agonist for arteriosclerotic cardiovascular disease. So the combination, when you really combine that, is really also aiding in the benefit after or secondary after first myocardial infarction.
Thank you, Dr. Eberhard. I think Parik sir just got busy somewhere. Thank you very much to both of our speakers. And any closing remarks before we close the session? We are very much on time, and we are in the last almost 1 minute for the session. Any closing remarks from Jiten sir and Dr. Eberhard?
The SGLT2s are becoming the statins of this year. Use them and use them early.
Thank you, sir. Thank you.
Well, I would echo this. SGLT2s are a great gift of diabetology to cardiology. So this drug really has go far beyond diabetology. And for instance, it's now the #1 and first drug in those people at pre-stage heart failure. So it's really a changing paradigm in that.
Thank you.
Very correct, sir. Actually, in CVOT trials, we were looking for a cardiovascular safety, but these two molecules were really revolutionized the treatment. We got these two molecules, which have been hijacked, I can say, by nephrologists and cardiologists for their benefit. Now, it is being more used for in cardiology practice and nephrology practice. Thank you so much, sir.
But that is why we need to talk about early use.
Yes, early.
we as the endocrinologist, diabetologists need to be talking about early use before they become heart failure or have established renal disease.
Try to emphasize
but then we have to increase the awareness among and reduce the clinical inertia for more use of SGLT2 inhibitors. I think still the use of SGLT2 inhibitor is much less what we expect. So the most important thing is to, as Dr. Everald said, that a diabetologist should also think about the cardiovascular and renovascular problems. They must evaluate initially when a patient comes to you for the treatment of diabetes. Initially, I think at that time we must evaluate for his cardiovascular and renal problems.
Yeah.
Baseline, so that we can in future we can look after for those things. Thank you very much, sir.
From an SGLT2 perspective, you should be on one if you're not on one. And for the practicing clinician, the question should be, why not?
Why not? That's right. Why not? Correct. Why not to use? That's very right. Very right. Thank you so much, sir. Thank you. Nice.
Wish you a good conference.
Thank you.
Thank you so
much.
Thank you.
So we
Bye
close
bye.
this section now?
Yes, sir. Yes, sir. We are just, yes, we have the next chairpersons also. So thank you so much, Parik sir, for chairing this wonderful session. Thank you to our speakers and thank you, sir. With that, can I request our next chairpersons, Dr. Akansha Patria and Dr. K. Vijayakumar sir, to take up the reins, please. Dr. Akansha Patria is from Surat. She's a practicing endocrinologist. And Dr. Vijay Kumar K is a physician and diabetologist and a PG diploma diabetes from Bengaluru.
Thank you. Thank you for this giving the opportunity to chair this wonderful session from the East Symposium. Well, diabetes, I should first... Very good evening. At the outset, I want to congratulate Diabetes India for an excellent lineup of topics and bringing in the East and the West and making it a wonderful, interesting session all through the 3 days, wonderful agenda. And today, because I am chairing this session, the East Symposium, focusing mainly on the cardiovascular health. In the first talk, I would introduce Dr. Siddharthavan Sangadu. I'm sorry if I'm spelling it wrong, Doctor. Doctor is from Indonesia. His PhD, DTM and H, and he was born in Amsterdam, graduated medical doctor in 1971. And was a specialist in internal medicine and also consultant endocrinologist with a PhD from the University of Indonesia in Jakarta. Currently, he is the professor medicine and endocrinology in the University of Indonesia. He is the president of the Indonesian Diabetes Association for 2 terms and chairman Indonesian Endocrine Society for 2 terms. He also initiated diabetes education programs and organizations in Indonesia. He served 2 terms as executive committee member of the IDF Western Pacific region and presently leading the Indonesian Diabetes Institute and practicing endocrinology at SS Diabetes Care, Pusada Hospital, Silawam Simpatpung Hospital in Jakarta. Well, the topic today would be by Dr. Segundo, the optimizing LDL cholesterol for the cardiovascular risk reduction. As we all know, LDL, low density cholesterol, has been established as a marker for cardiovascular risk. So what is beyond this LDL cholesterol is what, with the real world evidence, Dr. Segundo would be enlightening us in the next 25 minutes. Doctor, please take over.
First of all, thank you very much for the opportunity to talk in this beautiful and important session of Diabetes India. My talk will be, as mentioned, optimizing cardiovascular risk reduction beyond LDL cholesterol. Why should we talk about it? You know that dyslipidemia therapeutics have primarily focused on lowering levels of LDL cholesterol. Lowering LDL cholesterol for reducing CV risk has been a key therapeutic strategy for more than 30 years. And statin therapy, adopted globally, is recommended primarily to lower LDL cholesterol. However, many patients continue to experience CV events despite effective lowering of LDL cholesterol. There are prominent efforts to target additional risk factors to achieve more effective prevention of cardiovascular disease. TG risk lipoproteins play a causal role in atherosclerosis, highlighting the potential for specific therapeutic lowering. Growing evidence that TGs are not just a marker of increased CV risk, but rather a causal factor that rivals LDL cholesterol. The ASG, they mentioned the unmet need for primary prevention in individuals with hyper-TG not eligible for statins. Targeting patients with hyper-TG with statins or other TG-lowering therapies may be significantly reduce CV events in patients without pre-existing CVD and therefore represents a population that deserves special attention for the primary prevention of coronary heart disease. Statin non-eligible individuals with TGs around 264 milligram per deciliters had risk of ASCVD similar to statin-eligible individuals defined according to the 2016 AS guidelines. This illustrates an unmet need for primary prevention, calling for an expansion of guidelines on statin eligibility and the potential for placebo-controlled randomized clinical trials in individuals with hyper-TG. And even the ESG guidelines for 2019, they had a secondary goal. The secondary goal is non-HDL cholesterol. Non-HDL cholesterol evaluation recommended for risk assessment, particularly in people with high TG levels, diabetes mellitus, obesity, and very low LDL cholesterol. Non-HDL cholesterol secondary goals are very high, moderate, and also ApoB secondary goals were mentioned. And after that, there was a study about real world. The real world risk of cardiovascular outcomes associated with TG. It is said that among patients with cardiovascular disease, hyper-TG is common and is associated higher ASCVD risk across a range of triglycerides. It is possible that as many as 1 in 4 patients with ASCVD may be candidates for emerging therapies. And the large contemporary population-based cohort observed that among individuals with established ASCVD, hyper-TG is associated with ASCVD events across a spectrum of TG levels. Determined that a sizable proportion of patients with ASCVD in the real-world clinical settings have hyper-TG and controlled LDL cholesterol and may potentially be candidates for interventions for further reducing residual cardiovascular risk. The TG reduction in secondary ASCVD prevention, the concept as you see here that TG-related ASCVD risk is a marker of cardiometabolic risk and insulin resistance associated with obesity, reduced HDL, hypertension, hyper-TG, and diabetes. And this implicates that it is a marker of insulin resistance and cardiometabolic risk. And reduction in TG may indicate reductions in cardiometabolic risk. But it has also direct atherogenic effects of the VLDL, remnant cholesterol, and small dense LDL. The implication of this is that lowering triglycerides may clinically reduce risk of atherosclerosis, and there is a potential therapeutic options with PPAR modulators and omega-3 preparations. The consensus of the ESG about triglyceride lipoproteins and their remnants, the metabolic insights, the role in atherosclerotic cardiovascular disease, and emerging therapeutic strategies. The key point is that changes in LDL metabolism impact on structure, composition, metabolism, and function of LDL and HDL particles. And HEPA-TG favors formation of small dense LDL with potential increased heterogeneity and smaller dense HDL particles that perturb lipidome and proteome and effective vasculoprotective function. Although the degree to which these alterations contribute to severe risk is unclear. Formation of TG-rich lipoprotein remnants and their role in atherogenesis. In hyper-TG, the overproduction of and inefficient lipolysis of both VLDL overproduction and chylomicron overproduction leads to increased remnant formation. TG-rich lipoprotein remnants contribute to the initiation and progression of atherosclerotic lesions. The particles retention in subendothelial space and followed by inflammation and so on, and it's a plaque progression. As you see here that the VLDL overproduction and chylomicron overproduction will affect on the atherogenesis. Based on evidence from several sources, particularly preclinical studies, the conclusions were the following. Arterial retention of triglyceride-rich lipoproteins and their remnants is linked to maladaptive responses central to plaque initiation and progression. The ApoE and ApoC3 content of VLDL and chylomicron remnant particles is critical to mechanisms of arterial retention. LPL expressed by arterial wall macrophages and smooth muscle cells may directly promote atherosclerosis, and cholesterol-rich remnant particles induce macrophage foam cell formation more potently than LDL. Macrophage uptake of remnant particles and native and modified forms elicits an inflammatory response and thereby promoting atherosclerosis. Emerging pathophysiological and metabolic evidence supports the putative heterogeneity of ApoB48 and ApoB100 containing remnants during the postprandial period with ApoB100 containing particles predominating. And later the same year, the American College of Cardiology has a consensus recommending for providing for clinicians and patients regarding unique aspects of lifestyle interventions for the management of hyper-TG and the use of statins and TG risk based on statin therapies for HDL risk reduction. And the following 4 groups: patients with ASCVD, patients with severe hyper-TG, patients with diabetes, and high-risk primary prevention. Okay. There are 4 groups. The patient population is you see here the patient with ASCVD, adults with ASCVD, and patient with fasting TG more than 150 or non-fasting more than 175, and TG less than 500, and the diabetes also more than 40 years, no ASCVD, and fasting TG more than 150 and non-fasting more than 175. Less than 500, and this is the diabetes group, and then this is the other group, the high risk, and this is the patient with severe high TG. All the groups, you see, has the same consideration. You have to evaluate and manage secondary causes, optimize diet and lifestyle intervention for hyper-TG, implement guideline-directed statin therapy and optimize statin adherence with, and also optimize glycemic control, monitor response to therapy and adherence, and conduct clinical patient discussion for potential benefits, potential harms, and patient preference. If all this is done and it is still fasting hyper-TG, then optional interventions should be considered and risk-based pharmacologic agents could be added. The What does the AAC say? The management of AACVD risk reduction in patients with persistent hyper-TG. The recommendation is that if persistent hyper-TG is defined as a fasting TG level more than 150 after starting use and lifestyle intervention, hyper-TG is responsive to lifestyle modification. Optimizing diet along with regular aerobic exercise can lead to a 20 to 50% reduction in TG levels. So this should always be the first approach. Pharmacology treatment for patients who had established ICVD and for patients with diabetes, whether or not they have ICVD, particularly if they are over age of 50 and have persistent fasting TG, 150 and 500, provide LDL lowering therapy first, primarily with statins, and add other LDL lowering medications as indicated. Once maximally tolerated LDL lowering therapy is achieved, or patients' LDL level is at the goal level, if triglycerides are still elevated, then the guidelines of the ACC said it may be reasonable to add icosapent-ethyl to lifestyle modification. One other study in the US of the Kaiser Permanente Reach study, they said that triglyceride levels and residual risk of ICVD among patients with type 2 diabetes and coronary disease, elevated TG were independently associated with adverse CV outcomes, even after adjustment for clinical and simple biochemical covariates. According to this, after that, there are studies how to mark biomarkers for lipid association associated risk with atherosclerotic disease, the remnants, the LDL, the quantification of lipoprotein-associated risk in ICVD. There is no clear distinction at present between newly secreted VLDL or chylomicrons and their partially lipolyzed products, remnants. These particles are then defined together as triglyceride-rich lipoproteins or remnants. Non-HDL cholesterol is the measured content of all ApoB-containing lipoproteins, that's total cholesterol minus HDL cholesterol. ApoB is the measured concentration of this apolipoprotein in plasma. It includes ApoB100 in all particles and ApoB48 in chylomicrons remnants if they are present. The LDL cholesterol can be measured directly by homogeneous assay, measured after centrifugation, precipitation by the Francis method, or calculated as total cholesterol minus HDL cholesterol minus LDL cholesterol. But the latest effort is that the latest development is to examine or to check the direct remnant assay to measure cholesterol in TRR and IVL particles, and also LPA cholesterol assay. The newest approach of the American Heart Association, they have made comprehensive management of cardiovascular risk factors for adult with type 2 diabetes. AHA, American Heart Association 222. There's one section about lipid abnormalities and lipid lowering therapies in type 2 diabetes. The management of this lipidemia is central to comprehensive cardiovascular risk factor control and CV risk reduction for adults with type 2 diabetes. The most commonly encountered lipid abnormalities in type 2 diabetes are related to the clustering of risk factors associated with the metabolic syndrome, including increased serum TGs, triglyceride-rich VLDL, triglyceride-rich lipoproteins, small dense LDL cholesterol, ApoB, LDL particle numbers, non-HDL cholesterol, and decreased HDL. And LDL cholesterol is often mild to moderately increased. This atherogenic dyslipidemia is associated with both chronic low-level vascular inflammation and a prothrombotic state. This accumulating clinical evidence suggests that serum TG is a predictor of atherosclerotic cardiovascular disease comparable to LDL cholesterol in populations with type 2 diabetes, which both exceed the predictive power of A1C. In patients with diabetes and ICVD or patients with diabetes at high risk for ICVD, with serum triglycerides of 135 to 500 milligrams per deciliter despite maximally tolerated statin, and addressing contributory factors including lifestyle modification, prescription isocopan ethyl at a dose of 4 grams per day as well should be considered given the 30% additional severe risk reduction in the reduced-age trial. Of note, this trial, the median baseline is LDL cholesterol in this trial was 75 milligram per deciliter, and 29% of the study population had diabetes. Several RCTs have assessed the additional impact on CV events of fibrates when used in combination with statins. Thus far, the data are inconclusive, although post-hoc analysis have suggested potential benefit in those with residual modest hyper-TG. All we know that the non-atherosclerotic cardiomyopathies need high-density statin therapy. There are several residual risks. The residual risk, cholesterol risk, residual inflammatory risk, residual thrombotic risk, and residual triglyceride risk, and residual LPL risk. But optimal control, to have effective risk management, you have to control both LDL cholesterol and TG-rich lipoprotein as a key step. At the end, we know that hyper-TG associated with residual cardiovascular risk. Genetic and preclinical studies directly implicate triglyceride-rich lipoprotein in the causality of atherosclerotic disease. The presence of hyper-TG identifies patients who require more intensive lipid lowering. Existing agents with potential to lower cardiovascular risk, fibrates, omega-3 fatty acids, are likely to be protective in high TG patients, but does not associate with TG lowering. Novel agents developed to lower TGs need further evaluation in clinical trials, but in the meantime, use triglyceride-rich lipoproteins and remnant cholesterol to serve as a surrogate biomarker. The ASC guidelines said that the prudent approach now is to employ LDL cholesterol as the primary goal and non-HDL cholesterol or ApoB as an ancillary target. As the recent discordancy analysis suggests, once the LDL goal has been achieved, careful attention should be paid to the risk linked to the elevated levels of other ApoB-containing lipoproteins as reflected in non-HDL or ApoB. This ends my presentation. I hope it will make us discuss later on. Thank you very much for your attention. Thank you.
I think Dr. Siddharthavan very beautifully highlighted the importance of not only managing the LDL cholesterol, but also the triglycerides. And very much in Indian population, specifically Asians, we have this aspect where the LDL cholesterol is very well maintained, but the triglycerides is left untamed. So thank you, Dr. Siddharthavan, for this beautiful highlights. We'll be taking your all the questions at the end of the panel discussion. Thank you.
There's a page announcement.
Well, that was a wonderful session, Dr. So we'll move on to the next session. That will be we'll move on to the next session. We should go the latest guidelines for the management of diabetic dyslipidemia by Dr. Liang Ji from China. Dr. Liang Ji is a professor, director of Department of Endocrinology and Metabolism, Peking University People's Hospital, and is the immediate past president of the Chinese Diabetes Society, vice president of Chinese Endocrinologist Association, also the vice president of the International Diabetes Federation, and he has a strong background in diabetes, focusing mainly on the epidemiological and the genetic research. Dr. Liang Ji, please take your session forward. You are on mute, Dr. Liang Ji. You need to unmute.
Thank you very much, Dr. Kumar, for a nice introduction and the chairing. I'd like to thank the Committee of Diabetes India, and also Professor Sabu for inviting me to attend this huge Congress. Now I'd like to share my screen. So the assignment to me for this session is to give an introduction on the latest guidelines for management of diabetes dyslipidemia. So I'm going to focus my talk on two parts. One is focus on LDL cholesterol, the current guidelines evidence on the cholesterol management. And then I will focus on other lipoprotein fractions of dyslipidemia. Talking about dyslipidemia in type 2 diabetes, it's really three parts. One is this elevation of VLDL and triglyceride, and elevation of small and dense LDL, and then the reduction or decreased level of HDL. All of them were shown to be risk factors for cardiovascular disease in type 2 diabetes population in the epidemiology studies. And also there's evidence from basic research that dyslipidemia, hypoglycemia, and insulin resistance, which is the characteristic of type 2 diabetes, altogether resulting a spectrum of physiological changes, which have an impact on the physiological, on the pathophysiological changes of arterial wall, resulting in atherosclerotic lesion development. And those are including the formation of atherosclerogenic low density lipoproteins, advanced glycation end products, and also the activation of pro-inflammatory signaling pathways. And so far, the lipid management is an integral part of diabetes management, together with glucose management, blood pressure management, weight control, and then also in addition to the lifestyle modifications. So far, the strongest evidence are coming from the starting therapies in reducing the low density cholesterol. As has been shown from this meta-analysis, the reduction of LDL cholesterol result in improvement of major cardiovascular outcomes, as well as all-cause mortality. This is also true in primary prevention and also in the secondary prevention of cardiovascular disease and deaths in type 2 diabetes population. In addition, aiding this cholesterol absorbing inhibitors, ezetimibe, to the starting therapy, also showing benefit in further reducing the cardiovascular outcomes in type 2 diabetes population. Recently, the PCSK9, which is more potent LDL cholesterol decreasing agents, were also shown in the general population with a cardiovascular high risk, can improve the cardiovascular outcomes on top of starting therapies. In this trial with another PCSK9 inhibitors, the researchers had did a subgroup analysis or sensitivity analysis by stratifying the study subject into those with type 2 diabetes and those without. You can perceive from this first plot that the effect size on patients with diabetes in terms of cardiovascular disease risk reduction is the same as in other subgroups. So indicating that on top of statin therapies, aiding PCSK9 in type 2 diabetes population also can further reduce cardiovascular risk. So based on those clinical evidence, the ADA has recommended the statin therapies for the primary prevention of cardiovascular disease and death in patients with type 2 diabetes, and also on the secondary prevention of cardiovascular disease in type 2 diabetes. It's also stated that based on those evidence, if statin therapy cannot achieve optimal cholesterol control, you can aid either ezetimibe or, in the case of a secondary prevention, PCSK9 to further reducing the LDL cholesterol levels in order to increase, improved the prevention of cardiovascular disease in those with higher risk of developing those conditions. This was also reflected in the guideline of Chinese Diabetes Society. It's recommended starting as a first-line therapy for managing higher cholesterol levels, and if needed, other medications such as ezetimibe or PCSK9 inhibitor can be aided to further improve the level of cholesterol control. So how about other lipoprotein fractions or targets outside the LDL cholesterol? From the clinical trials aiming at reducing the LDL cholesterol levels, there's still a residual risk that cannot be addressed by simply reducing the LDL cholesterol levels, such as in IMPROVE-IT study, which is a combination of simvastatin and ezetimibe, and the FOURNIER study is a combination of LDL statins with evocumab, which is a PCSK9 inhibitor. And also there are many epidemiology studies showing that the elevation level of triglyceride is associated with ASCVD. And also there are many mechanistic studies or basic research indicating that triglyceride might play a role in the atherosclerotic process that leading to the cardiovascular disease. But unfortunately, using the niacin either in combination with statins or uses alone didn't show a clear benefit in further improving the cardiovascular outcomes. The same is true for those agents that can increase the level of HDL cholesterol, because in the epidemiology studies, the elevation of HDL cholesterol is a protecting factor for the cardiovascular disease in both general population and also in type 2 diabetes. From the previous clinical studies, it didn't show that statin plus fenofibrate or fibrate study can further improve the cardiovascular outcomes, questioning the role of triglyceride lower therapy in the role of preventing cardiovascular disease on top of statin therapies. And there are dedicated trials to try to address the role of fibrates in reducing triglyceride levels on top of statin therapies, such as in the Accord study, the researchers didn't show that on top of a statin standard care, aiding the fenofibrate have further improved the cardiovascular outcomes. But in the subgroup analysis, the researchers have identified there's a trend in the subgroup with they called diabetic dyslipidemia, which characterized by increased level of triglyceride and decreased level of HDL. But unfortunately, a dedicated trial tried to prove this hypothesis that this diabetic dyslipidemia is a cause for cardiovascular disease in type 2 diabetes population. And this COVA trial has recently been adjourned because of a lack of efficacy. In this trial, they use pemafibrates, another agents that can reduce the level of triglyceride. And this study didn't show that aiding these agents to reducing the level of triglyceride on top of statin therapy can further reduce the outcomes of cardiovascular disease. Therefore, the ADA didn't recommend either improve the endothelin function and also have anti-inflammatory actions and also have an anti-thrombotic effect. There's also study indicating that omega-3 fatty acid can have anti-arrhythmic actions. In the reduced trials, researchers randomized patients receiving statin therapies to the placebo and then this omega-3. And the study did show that a combination of omega-3 fatty acid with statin have a beneficial effect in reducing the cardiovascular disease in the population with higher triglyceride levels. But another trial using the same strategy, the STRENGTH trial, didn't show that among statin-treated patients, the aiding of these omega-3 agents could further reduce risk of major cardiovascular events. And if we look at the difference between these two trials, and there's the effect size of omega-3 in the two trials are very similar. But what make the difference in these two trials is that they use the different comparator. In one trial, which showing the benefit effect of a combination therapy, they use minimal oil as a comparator. Actually, the minimal oil have a detrimental effect in terms of cardiovascular outcomes.
Hello? Can I hear you?
Hello.
Oh, I can hear you now.
Yeah, Dr. Moon, it looks like there is a issue with the some issue. You're here. Can you hear me clear?
Yeah, now it's all right.
All right. Yeah. So that's good. Thank you, Mr. Linong ji, for maybe we lost in the last slides, lost some words. We'll move on with the next topic. Now I invite Dr. Moon Kyo Lee. I think I spelled it correctly, Mr. Doctor, from Korea. Dr. Lee is a professor, Division of Endocrinology and Metabolism from Korea, and is currently the chair of IDF Western Pacific region and is the former chairman of the board of directors of Korean Diabetes Association and Korean Society of Lipidology and Atherosclerosis. He graduated from Seoul National University and was trained in internal medicine in endocrinology at the Seoul National University. Took his postdoctoral fellowship training at the University of California, San Diego. His current research interests include insulin resistance, metabolic syndrome, in obesity and diabetes, and insulin resistance and beta cell biology. He has published over 130 scientific papers in peer-reviewed journals, periodicals, and book chapters. Yes, Dr. Lee would be taking us through the barriers and chances of diabetes management in the Western Pacific region. So he has got a systemic review to discuss with us. Thank you, Dr. Lee.
Thank you so much, Dr. Kumar, for your kind introduction. Well, I'm going to share my slide today. I'm very pleased, and it's a great honor to join again the World Congress of Diabetes India. Thank you for the invitation, especially to Banshi Sabu. And it's very nice to see Drs. Sigando and Linongji, old friends. And this time, unlike in contrast to the previous speakers, I was asked to present my original data, still unpublished. And as I belong to Western Pacific region, a neighborhood of Southeast Asia, I was interested, and I'm still interested in those situations like challenges or opportunities for diabetes management in our region. And I found we did a systematic review and got an interesting data so that I can have a chance to present and share with you today. This is my disclosure, and I'm going to talk in these sequences. As you are well aware of, the number of people with diabetes has been and still increasing worldwide, and especially you can see those three areas, the South Africa and Southeast Asia and Western Pacific region are the regions with biggest number of people with diabetes, and are still showing the still increasing number of people with diabetes, which means a seriousness in our region, so that the investigators should be very eager to solve the pathophysiology or management in our area. And as you know, IDF launched several activities such as IDF School of Diabetes, kids program, for example. But however, for effective diabetes education and management, it is absolutely necessary to recognize the challenges of patients and healthcare professionals, including physicians. And some years ago, I still remember a very impressive talk presented by Dr. Narayan at his Kelly West Award lecture. The brief summary is is in the center panel. So he stressed a huge mismatch between where the diabetes burdens reside globally and where the research is concentrated. So that his conclusion was the importance of investment in global collaboration in research and policy to win the war against diabetes. I think sometime will this kind of time will come to us. But in that occasion, we have to prepare such that we have to study hard as to the specific pathophysiology or patient characteristics or social conditions, etc., etc. Well, now this is a brief summary of Western Pacific region. We are also part of IDF, and WPL has the biggest area number of people with diabetes currently and in near future, and we have very diverse languages, which can be a barrier and lifestyles and healthcare systems. So that so far there has been almost no efforts to arrive at a consensus guidelines for diabetes or any kind of lifestyle-related diseases so far. This is a brief summary of the characteristics of diabetes in Asians, but it's that can be summarized like a marked increase in prevalence, especially in young age groups, and the decreased insulin secretory capacity, which is similar to the southeastern populations as well, which is similar to the expression like small pancreatic beta cell mass or function, something like that. So in summary, the Asian people are prone to have increase in visceral fat mass within the same BMI, and the relatively decreased pancreatic beta cell function, which can be a dual risk factors for the diabetes. As you know. And this is our data. Some years ago, we've also published that kind of similar data that insulin secretory defects can be identified at a very initial stage of glucose intolerance, such as IFJ and GT, compared to the Western people. This is the insulinogenic index. The decrease in beta cell function can be identified at the stage of IFJ and GT. And this is this was also confirmed in both non-obese and obese people. So at that time, we were very interested in the beta cell function at that time in our population, which can be found in several other areas like China, Japan, and Vietnam, Cambodia, etc. And WPL region has been running a diabetic foot care project for several years, led by Professor Yutaka Seno. And they've also done many workshops and studies, something like that. And this is a very interesting summary showing that regional differences in characteristics of diabetic foot lesions compared to the Caucasians. WPL patients are inclined to show the younger age and male dominant, the no gender differences. And the interesting thing is the amputation is more common in Western Pacific populations, and compared to the Caucasians, the healthcare systems for diabetic foot care are very inferior compared to the Western populations, so that we have to be more careful about the foot care in this area. I think it seems to be similar in Southeast Asia as well. And this is data from Japan, showing that the most prevalent cause of death in people with diabetes are usually cited as cardiovascular disease. It is similar in Asian populations to some certain degree, but as time goes on, as you see, the vascular lesions are decreasing, but the cancer, the mortality due to cancer ranks first in Japanese people, compared to, which is quite different from that of Caucasians. And this is a data from Korea, which is similar. I mean, the most prevalent cause of death should be regarded as cancer in Korean populations with diabetes as well. And in the meantime, we've done a literature review to see the other regions' data, especially in terms of the systematic review. This is the data from South Asians. They also, your region also is stressed the important examples of barriers such as lack of knowledge, misconceptions, lack of cultural adaptation to diabetes management, which can be a sort of specific to the region. But at the same time, they also extracted facilitators for diabetes care, such as programs focusing on improving communication, misconceptions, and culture-specific strategies, which can be very plausible and reasonable. This is a data of systematic review from Latin America and Caribbean. They did very diverse analysis using the many published papers, but as a whole, the most of them are related to lifestyles and culture-specific characteristics in terms of both barriers and facilitators as well. Therefore, but we found none. Actually, no one such studies of systematic review, or if possible, meta-analysis in Western Pacific region. But as we didn't find any important studies so far, we've decided, and we've recently done a systematic review using this kind of databases such as PubMed, Web of Science, and Cochrane Library. And these are the keywords we've used for that analysis. This is the selection criteria, such as written English, type 2 diabetes adult patients from Western Pacific region, should be original data, not the review one or citing data, etc., etc. And after extracting the unrelated manuscripts, we collected 63 papers, and we asked two independent epidemiologists to qualify the data of those papers we selected according to the mixed methods appraisal tools and NIH study quality assessment tools. This is a scale that using 5 different each criteria for qualification of the data. Our epidemiologists finally they arrived at a qualification, and they approved us to analyze the 63 abstracts and papers. Yeah, this is the flow diagram among more than 80 abstracts. We finally extracted 63 studies which met inclusion criteria. And it's interesting to see that more than half of the studies were conducted in Japan, Malaysia, and China. Yeah, this is the summary slide showing challenges to diabetes management in WPL. There are we've also done extensive analysis, but the red ones can be regarded as a relatively specific, which did not show up in other regions, such as poor sleep quality and quantity, sleep duration, etc., or long working hours from Japan, and quality of healthcare. What type D personality? I'm going to mention again briefly at a later time. And beta cell dysfunction. It's very interesting to see that kind of the terms in region specific papers. And this is the chances to diabetes management. We found such diverse class of chances for diabetes management, but I think I can say that at this moment that these are the similar. These kind of factors could be identified in other regions as well. So as a discussion point, I'd like to stress the importance of psychological factors, because there are many papers on the association between major depression and diabetes. I think you can agree with that. So as time goes on, the stresses of people are increasing, I guess. And this is the more detailed, analysis on sleep quantity and weighted mean difference in A1C, which shows a significant association. And this is the meta-analysis of type D personality. Well, I think you are well aware of type A personality, and type D personality is explained by mixture of high level of negative affectivity, and social inhibition, leading to negative emotions. And this is associated with threefold increased risk of poor prognosis. And it's also associated with significant risk of diabetes. And it is still important to clinically detect the effects of type D personality trait on DM prognosis, including mortality in our region, as well as other regions as well. And this is also the multivariate logistic regression analysis data showing the importance of the beta cell function, as shown in this slide. Postprandial C-peptide reactivity index, which denotes a beta cell function, was significant still after the diverse, the statistical adjustment. It still shows the very significant correlation with hyperglycemia after 2 years. So I think the beta cell function could be a very important factor we have to consider in care of patients with diabetes, especially type 2 diabetes in our region as well. So as time is limited, I'm going to summary. I don't need to summarize in detail because there are very explicit, but a small number of data in my presentation today. There are, as you know, there are very remarkable barriers, such as the natural disasters or a lack of insulin supply, etc. But at the same time, it seems absolutely necessary to control lifestyle and mental health problems, especially in Western Pacific region, in patients with diabetes. And at the same time, I'd like to say the quality of healthcare and policy should be supplemented, the management as well, according to individual characteristics such as type D personality or beta cell function, especially in people living in Western Pacific region. But lastly, I'd like to summarize the necessity of investment in global collaboration in research and policy is warranted, especially in Western Pacific region and Southeast Asia as a whole, Asian countries as a whole, which have the biggest number of people with diabetes, and will have the biggest number of people with diabetes in the future. These are the acknowledgements. I'd like to acknowledge the previous, the past, chairs of the IDFWPR. Thank you so much.
Thank you, Dr. Lee. That was a wonderful research indeed. It basically touched the core reason why there is a vast difference in diabetes incidence and control in the different regions of the world. And the mismatch, like you pointed out rightly, the mismatch between where the actual area of incidence of diabetes is there and where the research is conducted. This mismatch has led to maybe there is a little bit of information we are losing as to approach the right way. For example, like you said, in the Western Pacific region also, there is a podiatrist. Sorry for that. So the Western Pacific region, the foot care, the slide which you had presented, they say the physicians and the surgeons are the major people who are looking at the foot care, whereas in the Western area, Western countries, it is mostly the podiatrists and the specialists that take care of the foot care. And probably this is the reason why there is a decreasing incidence of amputations. So that is one point you highlighted very well. And maybe this is where we need to project to the world, where there is an increasing incidence of diabetes and the complications. If we do a lot more research and understand the actual ground situation in these areas, we could be doing more probably better control in the global perspective. I think you agree with that. Yeah. So coming to the chances of diabetes better management, and it is rightly put forward by your study, the stress levels and the sleep quality, that has been the major considerations in the current situations. And the newer generations are going through a lot of these problems, and definitely this can percolate into a more incidence of diabetes in the future if it is so. So lifestyle management is what is again reascertained here in your studies, and that's thank you for that. And we have a question in the chat box. This question probably I think Dr. Linong Ji would be a better person to answer this. It says regarding the incidence of adverse event for the use of high intensity statin, which is myopathy, is an adding PCSK9 to the statin therapy could increase this episode?
Yes, I think this is a very good question. Actually, the myopathy observed in a statin treatment coming from statin itself. It is not from LDL lowering. So by further reduction of LDL from PCSK9 inhibitors actually didn't increase the incidence of the side effect associated with the statin therapies. Yeah.
Okay. I don't see any further questions here.
Yeah, actually, I have a question to, I'd like to have a comments from both Professor Menghui Li and Professor Sequando. It's about this early onset or young onset diabetes in this region. In recent years, we have observed in our clinical practice, also from epidemiology studies, that in this region, particularly in East Asian population, and probably in also in India, the incidence of diabetes from young population are now increasing dramatically, and also in the epidemiology study showing that actually they carry a more risk of developing diabetes complications, especially the cardiovascular conditions. So I'd like to first have your impression on these issues in your specific regions.
Absolutely. Thanks for the very important comments. I totally agree with you. We also have some similar data in Korea as well, showing the doubling, almost the doubling, or the doubling of the incidence in younger generation, like in 20 and 30, compared to the years of 1980 or 1990, something like that. These days, their incidence level doubled in over 30 to 35 year periods in Korea, which is very impressive and very serious, because, as you mentioned, they will live longer than the old generations, and they are more likely to have complications. And it's interesting to see that although their beta cell function is declined, most of them are type 2 diabetes, which is almost equal to the metabolic syndrome, which encompasses diabetic dyslipidemia and hypertension as well, so that their risk should be the controlled more comprehensively. But it's more complicated to administer or prescribe some complex medications to them. So the pediatricians are very agonizing to comprehensive control the younger generations of people with diabetes, I think.
Yeah. I think I agree because let's say in Indonesia, I think it's correlating with the increase of obesity. Mm-hmm. You see more and more obese children, more and more young adults, and this just because of the lifestyle. And I think this affects the increase of the incidence of diabetes.
Yeah. How about in India, Chairman?
India is again like there's no much different. We are also witnessing an increasing incidence of all these higher LDL, higher incidence of diabetes. Definitely, it's increasing. I would go with Dr. Moon Q. Lee's research. Definitely, the lifestyle has been playing a larger role in increasing the incidence. I agree with Dr. Sangdu as well.
But I'd like to make a short comments on this. Recently, we found a very serious situation in case of childhood type 1 diabetes. The National Health Law of Korea says that those patients, including type 1 diabetes, who should take care of multiple insulin injections and some other sick illness as well, should be appropriately taken care of at school as well. It's a very, very literally very important and explicit dictation. But in reality, the newspaper said, and the major television news reported that many of the type 1 diabetic patients, children, inject their insulin during school, at school in the behind the curtain in the washroom, because school nurses are reluctant to help them inject at the school nurse's office, because they are concerned about the potential inadvertent accidents without doctor's prescription at school. So we have been agonizing to solve that problem. So we invited the members of parliament and the patient association, school nurses association, and Korean Diabetes Association, and it was solved, after 3 years of discussion, and at last it was solved by the parliament. They passed, they revised the law that school nurses, most of the schools should hire at least 2 school nurses, and they are exempt from the inadvertent accidents during those kind of health activities at school. So I think there are very, very, if we will try, we can find easily those kind of pitfalls and barriers in everyday life around us, especially in patients with diabetes, at the job or at home or in the neighborhood.
That's true. Even in India, we have such kind of agonizing situations. But the problem here in India is each patient is taken care by themselves. No law would be helping them in such situations, actually. Like we need to take case by case to understand their barriers and then discuss and try to solve these issues case by case, because each case has got a different barrier and it can be multiple as well. So that is one of the challenges we face in our country, in India, when it comes to the type 1 diabetes. Coming to type 2 diabetes, motivation has still been the biggest challenge in even explaining them the need to better control and the benefits of better control, even after explaining and teaching them, showing them the evidence. The motivation still remains at the lower levels. I don't know where we need to go how far we need to go to strictly make them understand. Maybe this kind of approach has to be developed right from the early ages in life, so that they know the importance of lifestyle and prevention of this kind of chronic diseases. So that's the point we see in India. Any comments? I have a question for Dr. Linong Ji. As you had gone through the guidelines of managing diabetic dyslipidemia, wonderfully beautiful guidelines has been approached. What, in your view, do you see any further more strict recommendations coming in the future to control better for the better control of LDL cholesterol? Because even after using high statin, there are quite a few, even much more incidences of uncontrolled dyslipidemia in diabetes. Do you see any further progression in the recommendations? Dr. Linong?
No.
Sorry. Anybody else?
Internet problem.
Internet problem. Can I ask Professor Segundo to
Can I comment? Because we should follow the guidelines. You have the American guidelines, you have the European guidelines. These guidelines are not the same, but I see that even on TGs, the Americans are the targets also. The American guidelines are less than 70, but the Europeans are less than 55. And even the goals and targets are different. Yeah, and if you but about TG, both countries or both continents are having now getting more interested in TGs. Yeah, and because the residual risk with statins you get only 40%, 60% are still not achieved, and even with PCSK9 inhibitors. Because if you use because the target with statins, if with the highest tolerable dose, that means there are many patients who are cannot tolerate statins, and for these patients, you have to use either PCSK9 inhibitors or other drugs. But for patients with LDL not a target, but with higher TG, you still have another target. But now you have the problem of the reduced trial and the strength trial with the different Professor G said, because the target will be different, and then TG is going to be more and more what do you call it? They are going to resolve the residual risk. Because statins is very much used even in Indonesia. The highest top medicine in the insurance is statins, but still they are not used. I mean, not at the accurate dose. Some are used at moderate dose, but never used or not very seldom to higher dose because these side effects. And for this risk, we have to take care. And I'm sure that in the future there will be guidelines because the pathophysiology of atherosclerosis, that remnants now is going to be different, not only LDL cholesterol. The remnants are also now studied. Yeah, and then I'm sure they're going further and further. So many drugs is coming in our part. In the US, there are so many drugs. But I don't know whether it is in Korea and in China, but the PCSK9 inhibitors, the inclisiran and so on, they are very, very expensive. But can we afford it? That's the problem. Thank you.
Yeah, Dr. Linong, you have a comment here.
Yeah, I think in the future with increase of affordability and accessibility, those new agents such as PCSK9 and other injectables that can have a half-year efficacy will play a more important role because still pills burden one of the barriers for the compliance in lipid-lowering therapies. But as Professor Segundo has nicely pointed out, the affordability and accessibility of these new agents, especially in our region, are still an issue.
Yeah. Well, I have a short question to both of you. Both Drs. Segundo and Linongji showed us the importance of diabetic dyslipidemia, especially importance of triglyceride. So, but it's it's not that easy to routinely measure Lp(a) or LDL particle number or even the size, etc., or even ApoB. So in that case, what if you are seeing patients with diabetes and diabetic dyslipidemia who with TG level of around 400 or 210 or so? Is it what you mean? Do you strongly recommend the physicians to prescribe either fibrate or pure form of omega-3 fatty acids in addition to statins to them?
Okay.
Go ahead, please.
Go ahead. In the guidelines, there's such a recommendation as to aiding the fibrates or other agents to lower triglyceride in those individuals with higher, much higher triglyceride levels, in order to prevent pancreatitis. But if you look at the literature, there's no very convincing studies showing that, of course, there are epidemiology study, a case report showing the correlation between high triglyceride and risk of pancreatitis. But there's no good studies showing that if you prevent, you lower the triglyceride, you can actually prevent the pancreatitis. I think people are still using the clinical observations and epidemiology data to guide their the recommendations. So I think in the future, maybe we can do studies on this issue to see whether lowering the triglyceride can actually prevent the risk, reduce risk of pancreatitis.
Yeah, thank you. I think we are out of time now. Thank you, professors, and we all had a very great discussion of the cholesterol, and thank you for attending this session. Thank you so much.
Thank you.
Thank you.
Thank you.
Bye.
Bye, Lino.
Bye.
Thank you, Segundo.
Okay, thank you.
Yeah.
Great. Take care.
Thank you.
Yeah.
Nice meeting
See
you.
you. Yeah. See you. Bye. Segundo, Dr. Segundo.
Nice meeting you. Thank you very much.
Thank you.
Bye, Dr. Kumar.
Thank you. Bye-bye.
Thank you, everybody.
Bye.
Thank you very much. Nice meeting you all. I'm going to be.
Okay. Am I audible? Yes, sir. Am I audible?
Yeah.
Okay. So wonderful sessions are going on in the Diabetes India 2022. I think we all of us are very much enjoying the treat. I'm really thankful to Bansi sir and the organizing committee of Diabetes India for giving me the opportunity for chairing this session. I'm practicing in Gandhinagar as a diabetologist, and we have a co-chairperson with us, Dr. Girish Mathur sir. He is a senior consultant, physician and diabetologist practicing in Kota, Rajasthan. So our symposium is CODY Symposium, CODHY Symposium. Now what it stands for is basically controversies in diabetes, obesity and hypertension. The first CODY conference or congress, it was started in Berlin in 2006. At that time, the name was given was controversies, but over the period of time, as we get the newer and newer knowledge, we always create the consensus. So controversies is now outdated and it has been now shifted to consensus. So today, CODY stands for Consensus in the Management of Diabetes, Obesity and Hypertension. For this topic, we have a very eminent speakers with us. The first one is Dr. Rajiv Chawla, sir. He has been a DNB teacher and guide for 20 years, senior consultant in North Delhi Diabetes Center, more than 95 papers on micro and macrovascular complications, authored 10 books on diabetes, 10 oration awards. He has been the past chairman, RSSDI Delhi chapter, past secretary, RSSDI national body, organizing secretary of many annual conferences, scientific chair of RSSDI 2018. He has been the executive editor of International Journal of Diabetes, president DIPSI 2019, and immediate past president of RSSDI as well. I welcome you, sir, for the first session. And the topic is perspective on cardiovascular outcome trials in diabetes. Thank you.
Good afternoon, everyone. Thanks, Dr. Meet, for all those kind words. At the offset, I am extremely thankful to entire organizing team of Diabetes India 2020, in particular, Dr. Bansi, Dr. Jyoti, Dr. Manoj, Dr. Arvind, and Professor Mishra for this opportunity. And tasks assigned to me is to discuss about whether we have CV outcomes today in 2020 and whether these are relevant to us in practice of diabetes management. Thankfully, it is not a debate, so I'll be able to give you a very, very balanced opinion on that. And over next 20 minutes, I'll try to do justice to the session which has been allocated to me. Yeah, we all know that approximately 50% of people with type 2 diabetes still die from cardiovascular disease. Having said that, type 2 diabetes is a severe risk factor that determines the need for cardioprotection. So very rightly, European Society of Cardiology, minded it is Society of Cardiology talking about anti-diabetic drugs for the first time, said that individuals with type 2 diabetes and CVD or diabetes with target organ damage or 3 or more major risk factors are at a much greater risk. So AD and ESD also since 2019, 2021 in joint consensus said that all those patients with established atherosclerotic cardiovascular disease or indicators of atherosclerotic cardiovascular risk, heart failure, CKD, should ideally be on SGLT2 inhibitor, GLP-1 receptors with demonstrated CV benefits as part of glucose lowering regimen. So let me give you the background why these CV outcomes have become important. The effect of tight glycemic control on CV complication range from neutral to perhaps harmful, as was seen in ACCORD study, which ended up with higher cardiovascular mortality, and it was stopped before the completion of the study. Since then, we know many studies, where earlier studies also like UKPDS, where it has shown that individual medication on diabetes complications, they had a mixed response. So those patients who were on metformin, there it was seen that there was not only reduction in MI, diabetes-related deaths and all-cause mortality by almost 39 to 40%. Even 10 years follow-up of UKPDS has shown that metformin-treated obese patients with type 2 diabetes continue to have a reduction in MI and death from any cause by almost 33%, although numbers were very small. Well, TZs, specifically talking about pioglitazone in proactive study, which enrolled 5,000 patients, it was shown that it improved CV risk factors and significantly reduced the second principal MACE endpoint by 16%. However, the composite primary endpoint didn't reach a p-value-wise significance. So when we talk about CV outcome trials, we know in 2007, a meta-analysis of 42 studies has shown that rosiglitazone ended with increased risk of MI, and that hinted for the first time that there could be a CV-related death as a result of the drug. That prompted FDA announcement in 2008 that a meta-analysis of CV events during phase 2 and phase 3 studies must be included in applications submissions for glucose-lowering therapies. So fortunately, now large phase 4 trials have become almost culturally mandatory because no company wants to have a disadvantage of not having a post-marketing safety, even in spite of getting a US FDA approval. So 2008, for the first time, US FDA released guidance for the industry. It said that sponsors should demonstrate the therapy will not result in an unacceptable increase in CV risk, even if pre-marketing analysis has shown that hazard ratio could be less than 1.8, so drug could be launched, but subsequently the post-marketing analysis has to establish that hazard ratio for any cardiac event has to be less than 1.3. So it also mandated that meta-analysis strategies using phase 2 and phase 3 data should be included. It also mandated that blinded central adjudication of all CV events should be there. It also said that there should be an inclusion of high-risk subjects like advanced CKD, CVD, and elderly patient, and there should be a minimum exposure of 2 years in large CV outcome trials with a 15,000 patient years data. There are 3 common ways of representing cardiovascular outcomes, either by assessing time to occurrence of cardiovascular outcomes or by performing a survival analysis, or by summarizing treatment effects through various statistical methods. But minded, there could be a misinterpretation of statistics that can affect clinical practice because of differences in baseline cardiovascular risk levels of population between different studies. And it is crucial to take into account differences in study design, length of follow-up. There could be too much heterogeneity in enrollment of those patients. We know over last century, there has been an evolution of diabetes therapies from early days in 20th century, where we were talking of primarily of drugs simply to reduce carbohydrate load in form of some Ayurvedic drugs and lifestyle modification. But in 1959, for the first time, we saw launch of Biognide, Metformin, and 1956, Sulfonylurea, primarily tolbutamide. But since then, there has been a large armamentarium of drug which has been added over last 75 years. Since the FDA alert in 2008, 13 years have seen 15 CV outcome trials. And by end of 2018, we had launch of almost near DPP-4s, SGLT2 and GLP-1 like analogs. And there has been one comparative insulin trial trying to compare to insulin. But good thing is none of these trials, they have reported an increase in risk for any major cardiovascular event or MACE. And actually 6 agents have demonstrated CV benefits. So it all depends at what stage and what type of population you are enrolling. If you are enrolling a population with end stage, with end organ damage, like what was done in EMPEREG, you might see much better results. But if you are just considering vascular risk factors, what was done in EXCEL, TICOS, and FREEDOMS, then obviously results may not be very, very impressive. But if you are primarily enrolling a primary cohort, what was done in DECLARE-TIMI, obviously 3-point MACE didn't come out to be very, very significant. Here is a snapshot of all non-insulin CV outcomes till date. Mind it, the bubble size represents the total population. And you could see that DECLARE-TIMI had primary cohort with only multiple risk factors and established disease only in 40% of patients, while the upper box, you may see these are primarily those trials there they have enrolled established atherosclerotic cardiovascular disease or event patients. And in the credence, you had primarily those patients who had EGFR less than 60, while the upper right box shows you patients, those who have both established atherosclerotic cardiovascular disease along with reduced ejection, with reduced EGFR. So evidence from CV outcome has shown that there could be some glucose lowering therapy which will have beneficial effects on CV outcomes, but it all depends what type of drug you are enrolling. And you could see that when we are talking about SGLT2 inhibitors like EMPA or Canibus, we not only had 3-point MACE reduction, but we also had significant reduction in hospitalization with heart failure by almost 35%. When it comes to GLP-1 like analog, there you could see that benefits on heart failure are neutral, but there were benefits in terms of 3-point MACE reduction. But with the DECLARE-TIMI, because it was primarily a cohort with lesser atherosclerotic cardiovascular disease or risk, so benefits in terms of 3-point MACE was neutral. And so was with DPP-4, because those drugs are classically CV neutral. But in the severe TIMI, actually it was seen that there could be increase in hospitalization with heart failure. So all primary endpoint in CV outcomes of type 2 diabetes since 2016 have established that individual drugs may mechanistically differ in their impact on CV outcomes. No particular endpoint could be seen as a gold standard for all CV outcomes for glucose lowering drugs. So 3-point MACE primarily is likely that this could be the best option for looking into the endpoints. So navigating the MACE in cardiovascular endpoints, most important lesson learned from CV outcome is that classic MACE endpoint may not accurately capture the magnitude of CV morbidity as well as mortality. CV benefits of GLP-1 receptor agonists we have already seen are primarily on those patients, those who have established atherosclerotic cardiovascular disease, and they might have benefits in some of non-fatal MI, non-fatal stroke and CV death, while with SGLT2, primarily benefits are in terms of hospitalization with heart failure. CV outcome results have also highlighted the major role of heart failure per se as an independent of atherosclerotic cardiovascular disease. So further studies possibly will focus on potential synergistic benefits and the cost effectiveness of both the drugs like SGLT2 inhibitor as well as GLP-1 in management of type 2 diabetes. And CV outcomes have definitely helped us navigate the maze of other complex nature of CVD, not only in terms of atherosclerotic cardiovascular disease, but also heart failure benefits in our patient with type 2 diabetes. When it comes to heart failure outcomes and CV outcomes with SGLT2, of course, there has been a significant reduction in hospitalization with heart failure and composite CV death and heart failure by almost 20 to 25%. Trials included almost 38,000 patients. And again, the magnitude of benefit from SGLT2 therapy on MACE was primarily modest on overall 3-point MACE, but it was primarily driven through hospitalization and heart failure and composite heart failure and CV death. While the effects of SGLT2 inhibitor on MACE are confined primarily with history of atherosclerotic cardiovascular disease, in heart failure, benefits are universal, irrespective presence of atherosclerotic cardiovascular disease. Despite the size of randomized sample and consistent benefits on hospitalization heart failure events, still unfortunately none of the tested SGLT2 inhibitors still has a label to be used for prevention of heart failure hospitalization in type 2 diabetes. And this possibly could be explained because of the fact that heart failure label indication is largely due to heart failure not being as a primary endpoint in all these CV outcome trials. So the future direction for heart failure and non-primary endpoints as far as CV outcome trials are concerned ideally should be that heart failure is present at baseline. So we must standardize a comprehensive characterization of heart failure. We must ensure the proportion of patients with baseline heart failure, which is actually reflective of presence of that comorbidity in routine clinical practice, not in higher risk group. When we have significant effects of agent on heart failure, which are likely or anticipated, then we should try to enroll patients with high risk for heart failure, and heart failure even should be included as a primary endpoint, not as an additional 3+1. Should unstable angina be included in primary endpoints? Well, there has been evolution of prospectively planned primary endpoints in completed CV outcome over last 20 to 25 years. Earlier days, we were talking of only hyperglycemia, risk of hyperglycemia, mortality, renal failure, and retinopathy and other things. But of late, we have been talking of unstable angina, heart failure, CV death, or composite of that. But when it comes to hospitalization with recurrent angina or unstable angina, we know the inclusion of angina increases the number of events for analysis. But then, minded, there could be disadvantages because of too much subjectivity in hospitalization with unstable angina. Moreover, CV outcomes indicate glucose-lowering agents seem to have minimal effect on unstable angina. So if it is included as a fourth MACE, then obviously there could be shift towards the null, because then benefits could be nullified by presence of unstable angina, where the benefits of SGLT2 may not be very, very reflective. The primary outcome of 3-point MACE may offer possibly a better balance between or better balance than 4-point MACE because of statistical efficiency and operational complexity, which is in favor of 3-point MACE versus 4-point MACE. And we know all these CV outcome trials, they try to enroll a much higher risk population so as to deliver the results in as early as possible within 2 to 3 years. That is why data from CV outcomes may not be applicable to vast majority of patients in clinical practice, what we see in everyday practice. So if you talk about the EMPEREG, less than 18% patient will match what has been enrolled in EMPEREG trial. Even UK Royal College of General Physicians research base has also shown that not more than 15% patient will resemble what has been seen in EMPEREG trial. So to answer that, here is a real world use and model impact of glucose lowering therapy, which have been evaluated in recent cardiovascular trials. So aim of this was to evaluate the current use and potential real-world impact of these drugs like AMPA and liraglutide among patients with diabetes collaborative registry, which comprise almost 242,000 patients. But minded, among patients with overt type 2 diabetes in this DCR registry, less than 26% patient would have been eligible for EMPEREG and less than 48% would have been eligible for LEADER. That means most of these CV outcomes may not be reflective of what is a real world practice. Then there are challenges when we talk about CVD and CKD patient in CV outcome trial. Normally it is thought that there is an intersection of risk factors amongst CKD as well as cardiovascular disease. Then there could be patient-related factors like volume overload, anemia, infectious, dyslipidemia. There could be practice and therapeutic-related factors which could again nullify the benefits because of bioincompatible dialysis condition. And there could be uremia-related factors and certain biomarkers which could change the overall logistics. So an ideal approach to precision medicine for cardiovascular outcome trials with CKD will be to identify target pathophysiology leading to cardiovascular events. Treatment should be then selected based on the mechanism of action known to modulate that pathophysiological target of interest. Biological markers should be identified, and then we should identify those patients with those markers of interest and conduct randomized controlled trials of specific therapy in patient with those particular pathophysiology. Another lacuna of CV outcome trial is that minority have been underrepresented. So if you talk about USA, where 13% of population is Black or African American, those who have almost 13 to 15% prevalence, versus the Caucasian, which have only 7% prevalence of type 2 diabetes. But even in these trials like EMPA, Examine, Savior-TIMI or Alexa, TICO's leader or Sustain 6, less than 5% of this population, they were represented in these trials. This could be because of the fact that there could be a socioeconomic status in these minorities, so they are in an underprivileged state. So it could be also because of insufficient reliable transportation, poor health literacy among these patients, inadequate knowledge and overall nature of the medical research and disease, that they are still not able to use these facilities. So coming to whether CV outcomes are equal and whether we can directly compare these outcomes, CV outcomes definitely aim to demonstrate the addition of a novel agent as safe as is usual care. That means it is non-inferior primarily. But unfortunately, most of these trials have been versus placebo. Trials have aimed for a glycemic equipoise. And we know that in current era of primary multiple risk factor management, like stenotype 2 management approach, CV events are already very, very low. So CV outcomes are primarily safety trials. And it is reassuring that outcomes to date, they support CV safety primarily. Patient at much high CV risk may be much lower in overall general diabetes population as compared to these CV outcome trials. So trials ideally should include lower population of patient at high CV risk, and that may be considered more representative of real world practice, what was done in primary cohort and declared TIMI. Then I told you there are limitations of CV outcome, lack of generalizability because of the fact that all population are not equally represented. These are too short lasting trials. 2 years may not get you benefits in terms of atherosclerotic cardiovascular disease. Then even time for getting harmful effects is too short. 2 to 3 years may not get you the true picture of harms which might come out of these drugs. And most of these trials are, I told you, placebo designed. These are not versus active comparator. So opportunities for improvement in CV outcome trials could be that we must include lower risk, more diverse population. These primarily should be primary intervention trial in lower risk population with a longer term follow-up of at least 3 to 5 years, and we should have an active comparator. But again, mind it, if we are using an active comparator, we should be sure of sufficient knowledge of that drug versus any CV impact, and we should have a standard definition of important safety as well as microvascular outcome. So if you ask me, is it time that we should abandon CV outcome trials? Possibly no. There has been a recent crescendo in enthusiasm for real world evidence, but we know that all real world evidences are non-randomized observation analysis, and they have inherent limitations for only circumscribed deduction of treatment effects. Real world approaches are usually confounded by indication, information, and ascertainment biases. So there is true requirement to assess each anti-hyperglycemic medication at least once in a large scale standardized CV outcome trial, and that should be then subsequently give the confidence to clinician in terms of both safety as well as efficacy of the drug. Thankfully, US FDA 2011 revised its guidelines for all these drugs. It today says that there should be at least 4,000 patient years of exposure of new drug in phase 3 trial. It should have 1,500 patients exposed to new drug for 1 year and more than 500 patients for 2 years. At least 500 patients with stage 3 or 4 kidney disease should have exposure of that drug, and at least there should be 600 patients with established atherosclerotic cardiovascular disease and more than 600 patients of older age, more than 65 years, to establish the safety of the drug. So CV outcomes are very, very important. It should be noted that when we are referring to CVD, we should not only include macro, but also microvascular complication and morbidity, because both are equally important. And new and existing glucose-lowering therapy should be evaluated not only for their overall effect on vascular health, including heart failure, as well as risk like amputation and others. CV outcomes have definitely sensitized diabetes care providers to the opportunities for multifactorial and comprehensive diabetes overall risk reduction. And we know CV outcomes have demonstrated cardiovascular benefits in further reducing CV morbidity and mortality. And these CV outcomes have definitely embraced these days more cardiorenal primary endpoints, and the trial design of CV outcome is robust enough to have allowed their results to inform current recommendation. Actually, it has made a basis for current recommendation and guidelines across the globe, but still it has to go a long way. We should include other microvascular complications like cardiac autonomic neuropathy, which has not been represented and it has not been explored in contemporary CAB outcomes. So to conclude, CV outcomes are important, but there is a huge scope for improvement into CV outcomes. We should try to enroll more like primary cohorts. We should also try to include plus 3-point MACE plus comorbidities like heart failure and other risks. And we should include CV outcomes with patient with CKD, elderly, and other comorbidities. Thank you very much for your patience listening, and stop sharing here and stand by for any questions and answers.
Wonderful session, sir. You have almost covered everything. It's very important that clinical trials give us both the kinds of ideas. It gives us the idea regarding advantages and also tells us regarding disadvantages. But by and far, as you have conveyed, CVOTs are very important, definitely in future. And you have also suggested what are the pitfalls in CVOTs, which we need to improve it. Thanks again, sir. So right now there are no question in the chat box. So I will go to our second speaker. Our second speaker we have is our renowned speaker, that is Dr. Itamar Ras. Dr. Itamar Ras has received his medical degree from Hadisha Hebrew University Medical School in Jerusalem in 1980. He is board certified in internal medicine, and he is a full professor of internal medicine and was the head of diabetes unit at Hadisha University Hospital from 2000 to 2015. Professor Raz is currently serving as head of Israel National Council of Diabetes, and he is the initiator and the leader of the National Diabetes Prevention and Care Plan in Israel. In addition, Professor Raz is president of DCure, a non-profit organization that promotes and funds scientific research in Israel for finding a cure and better treatment for diabetes. In the past, he has served as a president of Israel Diabetes Association from 1992 to 2004. Professor Raz holds various editorial board positions in 8 diabetes-related international journals. He has over more than 320 publications in different peer-reviewed journals, and he has been the co-editor of publication of Diabetes Care Supplement. Professor Raz has chaired and has been a featured speaker at multiple lectures and presentations, both nationally and internationally. We welcome you, sir. Please.
Thank you very much, Dr. Meet. I want to also thank the organizing committee and Professor Banshi also for inviting me. It's a great pleasure always to take part in a meeting in India with your groups. So I'm going to discuss today controversies in the diabetes management. And many times when we talk about controversies, we actually talk about what we call today precision medicine. One moment, it doesn't pass. Okay, somehow I cannot take forward my presentation. So, Ilana, can you do it? 1 minute, please, 1 minute. Somebody's stuck in my presentation. No better presentation. Oh, okay, now it's okay. Now it's okay. Okay, right. So we talk a lot about precision medicine, and I want to talk about precision medicine in relation to controversies in diabetes. And when patients are sitting in front of me on a daily basis, many times I'm not sure whether what I suggest to them or offer to them, the drug that I offer, is really the best thing for them. Will it really be with high efficacy and high safety, or is it a problem? And it's not only my problem, it's also the patient problem, because the patient many times is not sure about the drug that we suggest to him. He heard about it, he heard about side effects. For example, I have several patients who tell me with a very high cholesterol, they tell me that high cholesterol is good because this is what the body needs. And if you reduce it, you can do harm. Not to mention the fact that many people would resist statins because of the side effect. So when we sit in front of the patient, we really want to know, are we doing good to the patient? And we just heard a very nice lecture discussing randomized controlled trial. And we do believe that randomized controlled trials do give us an idea about most of the patient. And as we heard, many of those studies are not generalized. But even if they are, the question is still there, whether we can be sure enough. And it's not only randomized controlled trials. Many times we don't have that. So we look at post hoc analysis. We look at meta-analysis with all the limitation. We look at observational studies, or we look at real-world data. So when we sit in front of a patient, what we know many times is all the data that are really there. And even though many times we are not sure about it, and many times we have to explain to the patient what are we based on when we suggest to him to do something, to take drug, to look at different targets. So let's take, for example, controversies in the management of the elderly. BMI is a big problem. If a patient has BMI of 33, or if he is from India, if he has a BMI of 29, should we treat him? Are we doing good to him? Isn't it better that his BMI will be where he is? A1C, do we really want to reduce our patient to A1C less than 7? Is it really of great importance? Mainly if it means to treat him with drugs that he's not very happy with or that could do some side effect. What about hypertension? Do we want to reduce an elderly patient to blood pressure of less than 120 or 140? Or sometimes when we see patients who have 145, 150, do we really think we should give them drugs or add drugs, remembering that there is side effect? What about LDL? LDL is a big issue by itself. Should we reduce an old patient to LDL less than 70 or sometimes less than 50? In my country, many patients who had LDL of less than 50, what happened is that they stopped treating him with statin, or they reduced the amount of statin. And what it means is that this patient will increase his LDL to 70. Is that right? What does it mean to have LDL of 30 or 20? Is it good? Is it bad? Professor Brownwald, who is a world leader in the field of cardiology, says the lower the better, but not many people agrees with him. So let's look just at the issue of BMI in the elderly. BMI in the elderly is a great issue because we know that as we get older, we have an increase in visceral fat, we have a decrease in muscle mass, and many times we are not able or we are not doing the exercise or the lifestyle that we need in order to increase our muscle mass, and we don't eat properly, we don't eat enough protein. We know that older people, 50% of them do not eat enough protein in order to keep their muscle mass where it should be. So if we take this patient and we reduce their weight, will we do good to them or bad to them? And there is what we call the obesity paradox. The obesity paradox shows and have shown in several studies that if your BMI is 33 or 34, you're in a much better stage than if your BMI is 27. And the question is whether overweight or class 1 obesity is good for the old, or should we aim to reduce it, remembering that we don't only reduce fat, we also reduce muscle mass, lean mass. So this question stands. Do we have answer to that? So mainly meta-analysis, observational studies, and so on have looked at it. And there are many studies, 16 in this case, that have looked at the relationship between mortality and between BMI of a patient. And what they have, and sometimes it was also including chronic renal failure or waist circumference and so on. And they suggested that if your BMI is above 30 to 35, your outcome or your risk for mortality is lower than that if your BMI is 25 to 30. And this is mainly in Caucasian. And the question is that true? If that's true, why should we reduce the weight in patients with BMI of 34, even if we have abdominal obesity? Now, many other studies, many other meta-analyses have showed exactly the opposite, looking again at BMI and more at waist circumference, and what they have demonstrated that there was a decrease in mortality in patients in whom a BMI was below 30 and versus those with BMI above 30. So the big question is, let's assume this is true. If we have a patient who has BMI of 34 and we will now reduce him to 29 or to 31, will we improve his health or not? Now, how can we explain the issue of what we call paradoxical obesity? So it might be that first we don't know whether in most of those of obesity, researchers looked at the BMI. They didn't look at waist circumference. So it might be that patient had high BMI, but they were relatively lean when it came to the abdomen. Another thing is that patients with BMI less than 30, most of the time, are more heavy smoker than those above 30 in those studies. Another thing that it can be that obesity by itself make a physician more aware to the patient. So if a patient has abdominal obesity or he is obese, he will be better treated than a lean patient. And this can explain why BMI above 30 might be in a way better than BMI less than 30. And as we all know, sometimes when you have BMI less than 30, it might be, for many in the old age, that you have an extra disease which causes you to have a low weight. So we don't have an explanation about this better effect of high BMI, as we've shown in the first 16 studies. But most probably, part of what I just said is the explanation, and most probably reducing weight, even in the old people with abdominal obesity, is of importance. Now, in a very nice study that done in the Lancet that looked at 239 different observational studies, it was demonstrated that at the end of the day, obesity is a bad thing at all ages, whether you are 35 to 50, 50 to 70, and even if you are 70 and above, abdominal obesity or general obesity is worse for your health, although it's true that in the age above 70, it's not as it looks for the younger age, but it is still there. Now, I want to go back to randomized control trials, because one of the problems when we want to reduce weight is that we, in the old population, is that we don't have a good randomized control trials that go over years to show us what is the meaning in reducing weight. And I decided to take the Declare that you heard a lot of just before. And the Declare was, I was the PI of Declare, together the Registry Vivio from Harvard. And what I want to show you is what happened in Declare to the old population. So let's look first at different ages, below 65, above 65, up to 75, and above 75. And what you can see is that, in general, patients above 75 were leaner than patients below 75. You can also see that patients above the age of 75 had higher risk of heart failure. They have higher heart failure. And you can also see that patients with above the age of 75 had a lower eGFR, meaning that they were, from the beginning, more sick. The young one had 94, below 65, above 84, and above 70, and above 75, they had the lowest eGFR. So let's look what happened when we want to reduce weight in these people that actually had BMI which was nearly below 30. So this looks at the weight, and you can see that the effect of dapagliflozin on weight was similar. The youngest were heavier, as we saw before, and the old above 75 had low BMI. Altogether, the effect of BMI was similar in all the three ages, below 65, 65 to 75, above 75. And let's see what was the outcome within 4.2 years of this study. So you can see,
depois o doutor partilhar a sua apresentação.
Sim.
Não está com
so you can see that unrelated to the age, there was a similar effect on cardiorenal composite endpoint and on renal specific endpoint. So the efficacy was the same at all ages. If we look at safety, we can see that fractures were the same in all ages, no difference. Malignancies were the same in all ages. Major hypoglycemia, if anything, was lower in the old than it was with placebo. So this was a safe drug in spite of the fact that it reduced A1C and weight. And we can also see that related to diabetic ketoacidosis, there was a higher ketoacidosis as it was in all the ages. So in summary, the relationship between body weight and health in advanced ages is complex. Health risk in the elderly depend on other factors that must be considered, and we didn't discuss it here further. The discussion on weight loss should be made under the supervision of medical staff, individually tailored according to each patient characteristic, with proper nutrition and exercise. But the conclusion is that also the elderly, even above even above 75 years, with high BMI, mainly if they have high waist circumference, should be advised to lose weight under supervision, making sure that they will have enough protein and enough exercise to keep their muscle where they should be. Thank you very much.
Thank you, Dr. Raz, sir, for interesting session. I think very few times we discuss about controversies, and you really elaborated regarding the controversies in BMI in our diabetic patients. So I'm really thankful, sir. I think there are no questions at present. So we can move with our third speaker. Our third speaker is Dr. Luis Gadet. He is the president of Ernesto Roma Foundation Lisbon since 2017. He has been the coordinator of 2009 first Portuguese diabetes prevalence study, PrevaDiab. Sir has been the chairman of the local organizing committee of EASD annual meetings in 2011 and 2017 in Lisbon. And Sir is chair of the National Advisory Committee of 2022 IDF International Diabetes Congress in Lisbon. So I welcome you, sir, for this talk. Sir, you are muted. You are muted, sir. Sir, please unmute yourself. Sir, you are muted. Please unmute yourself. Sir. Sir, we can see your slides, but we are, yeah. Yes.
Okay?
Yes, sir, audible.
Can I start?
Yes, definitely.
Well, thank you very much for the invitation to be in this prestigious meeting. And thank you to be in India, unfortunately, virtually. Well, I got to speak a little about nocturnal hypoglycemia. Is it different? Well, as you know, hypoglycemia is limiting factor in the glycemia management of patients with diabetes, in whom the risk of severe hypoglycemia increase as A1C levels are reduced with intensive therapy. Less commonly, hypoglycemia affects people with type 2 diabetes. More people who are with sulfonylureas and insulin. And about definition, there are several definitions. There are several definitions. An episode of abnormal low blood glucose less than 63 occurring in night time during sleep is a usual working definition. Nocturnal hypoglycemia is common, especially in patients with type 1 diabetes. During DCCT, as you know, 43 patients of all hypoglycemia episodes and 55 of several episodes reported occurred during sleep. The variation is between 12 and 56. Patients with type 2 diabetes treated with long-acting sulfonylureas, insulin or insulin combined with oral antidiabetic oral are also very susceptible. Well, there are several definitions. Well, we can have a definition based in numbers with the alert value with less than 70 milligrams deciliter. We have clinical significant hypoglycemia less than 54 or less values. We have a very severe hypoglycemia. We can we go to situations very complicated. The physiologic response to hypoglycemia is naturally different. With low values with 83, we have inhibition of endogenous insulin secretion, or values more or less 68, we have the presence of counter-regulatory hormones released like GABA or adrenaline values lower. We have symptoms from the autonomic system, glucopenic system, and cognitive dysfunction, and values less than 27. We have extremely problems with severe hypoglycemia who can go quickly to the death situation. Severe hypoglycemia is life-threatening and has negative acute and long-term consequences. Situation acute or long-term. Situation acute, we have acute symptoms, glycopenic, autonomic, from the autonomic system, cognitive impairment, impaired work performance and social activities, and acute morbidity. Long-term fear of hypoglycemia, reduced QOL, driving and employment restrictions, cognitive decline, and naturally mortality. Consequences. Recurrent hypoglycemia causes cognitive impairment. In old adults, severe hypoglycemia is associated with increased risk of dementia. Severe hypoglycemia is also be associated with increased risk of cardiovascular disease in patients with type 2 diabetes. In frail old adults, episodes of hypoglycemia may lead to episodes of dizziness or weakness, increase the risk of fall or fracture. Fear of hypoglycemia and its consequences can result in poor glycemic control. Causes of severe hypoglycemia events. We have insufficient food intake or irregular intake food, physical exercise, insulin dose miscalculation, stressful situation, oscillating BG levels, impaired hypoglycemic awareness. In this slide, we can see or we can show that two patients, we have the first one patient and the second patient, they are the identical A1C, but the first case we have several hypoglycemias, and the second case we don't have hypoglycemias. So the pattern of hemoglobin A1C could be a good signal. Severe hypoglycemia events occur in all A1C. We have in the 9, 7, 6, or less than 6, we have the situations of hypoglycemia. Hypoglycemia causes neurogenic from autonomic system. Neurogenic symptoms include tremor, palpitation, anxiety, arousal, sweating, anger, and paresthesias. And neuroglycopenic symptoms. The neuroglycopenic symptoms include dizziness, weakness, dizziness, delirium, confusion, and at lower plasma glucose concentration, seizure, and coma. Old adults and patients with long-term diabetes may have more neuroglycopenic than neurogenic manifestation from hypoglycemia. Risk factors for hypoglycemia. Hypoglycemia is associated with autonomic failure, long duration of diabetes, older age, lower levels of glycemia when achieved with medications, erratic time of meals, including missed meals and low carbohydrate contents meals, history of recent hypoglycemia, exercise, alcohol ingestion, chronic disease, kidney disease, and malnutrition and glycogen depletion. Reducing the risk of hypoglycemia while maintaining improving glycemia control involves patient education. That's essential point. Reducing the risk of hypoglycemia while maintaining improving glycemia control involves application of the following principles: patient education and empowerment, frequent SMBG, individualized glycemic goals, flexible and rational insulin or other drugs regimes, ongoing professional guidance and support. Nocturnal hypoglycemia may be the most common type of hypoglycemia in the individuals with diabetes using insulin and is particularly worrisome because it is often goes undetected and may lead to inconscience and even death in severe cases. Nocturnal hypoglycemia occurs during sleep, and it's particularly dangerous because patients are unlikely to recognize symptoms and awaken during an episode. Nocturnal hypoglycemia is more worrisome than daytime hypoglycemia because sympathetic adrenal response to hypoglycemia subject symptoms, they provide warning, and cognitive function are suppressed during sleep. Undetected nocturnal hypoglycemia may often contribute to hypoglycemic awareness, anxiety, loss of vitality, physical injury, poor quality of life, and possible neurocognitive defects. There are three groups of risk factors for nocturnal hypoglycemia: pharmacologic, behavior, and physiologic. The pharmacologic, severe slow clearance of prandial insulin or antidiabetic oral antidiabetics, peak insulin effects of basal insulin at night, variability of insulin time action profile, time of peak and duration. About behavior, missed meal, type of meal, missed SMBG, unplanned exercise, alcohol, poor judgment. Physiologic, pancreatic counterregulation involving insulin, glucagon, pancreatic polypeptide, sympathetic counterregulation, epinephrine and norepinephrine, it's lower. Adrenal counterregulation, lower. Cortisol, lower. Age, infection, other morbidity. These two behavior and physiologic risk factors that can be both behavior and physiologic hypoglycemia, awareness, stress. Monitoring nocturnal hypoglycemia. Bedtime blood glucose levels may predict nocturnal hypoglycemia. Thus, bedtime the self-monitoring blood glucose is a simple way for patients to predict and take measures to prevent nocturnal hypoglycemia. Non-invasive monitoring devices equipped with auditable alarms that detect blood glucose are available, and with fantastic results. Awareness, continuous glucose monitoring systems that transmit real-time blood glucose information directly from the patients are very useful. CGMES device designed for use in closed-loop system with CGSII pumps and insulin adjustment algorithms are now available and possible to use. Treatment of nocturnal hypoglycemia. The key to treat is early recognizing. In awake individuals, mild to moderate nocturnal hypoglycemia is easily connected by ingesting a snack containing fast-acting carbohydrates, cookies, sandwich, glucose tablets. Glucagon is as you know, counterregulatory hormone that stimulates hepatic gluconeogenesis and glycogenolysis, which rise blood glucose levels rapidly if glycogen stores have not been depleted. If response to glucose is not rapid, emergency service should be called to administer insulin intravenous glucose. Prevention of nocturnal hypoglycemia, providing education about risks and risk reduction strategies in critical and prevent nocturnal hypoglycemia, perform SMBG and use CGM are be made aware that change in the routine. When insulin is used as basal insulin, a bedtime snack may be necessary, a snack that is slowly absorbed and provides steady supply of nighttime glycemia support may be more appropriate than fast-acting carbohydrates whose glycemic effects tend to wane too easy. Intensive therapy should achieve glycemic control while avoiding severe nocturnal hypoglycemia as much as possible. Physiologic, behavior, and pharmacologic factors contribute to nocturnal hypoglycemia by the later up to factors are first factor are modified. Frequent episodes of hypoglycemia can exacerbate hypoglycemia awareness and lead to a dangerous cycle in which symptoms may be apparent until BG, blood glucose levels are dangerously low. Judicious choice of pharmacologic with insulin regimes then offer more physiologic or predictive time action profiles can lower C-passage. And thank you very much.
Thank you very much, Dr. Luis, sir, for interesting session. I think sir has covered almost everything, starting from etiology to risk factors, clinical presentation, and tackle the nocturnal hypoglycemia as well as how to prevent the nocturnal hypoglycemia as well. Sir, I have one question is, what are the common drugs which we should keep in mind that can lead to hypoglycemia apart from anti-diabetic drugs? Like which antibiotics or any NSAIDs or any other drug which can lead to hypoglycemia in a diabetic patient?
Sorry, I didn't understood.
My question is, what are the other drugs apart from anti-diabetic drugs which can lead to hypoglycemia?
About drugs?
About drugs apart from anti-diabetic. Other than anti-diabetes.
Well, as you know, the sulfonylurea is the drug who give more hypoglycemia. The old drugs are more potent to do that. New drugs, the sulfonylurea or other drugs, we are not able to.
But sir, any antibiotics which can lead to hypoglycemia?
Well, the new drugs, new oral drugs, usually don't give hypoglycemias. If you put out the old drugs, sulfonylureas, if you go to the DPP inhibitors or the other drugs you have new, you don't have any kind of if you join insulin, well, there are a small risk or hard risk that depends the management of insulin. But
quinolones are classically known to give hypoglycemia. Getty is a typical example, actually. Then there are certain anticonvulsants. We reported 2 cases of getting severe hypoglycemia with, of course, quinolones, Gettyflox and levetiracetam, which are known to give hypoglycemia.
Yes, sir.
The other thing which can cause hypoglycemia classically is the pentamidine, Kala-Azar drug, and this is one of the models which was studied earlier, whether it can destroy beta cells and so on. And as far as the fluoroquinolone, which Rajiv has referred to, in fact, the article came in New England Journal of Medicine when several cases of moxifloxacin-induced hypoglycemia were reported. So one has to be careful in, as far as these drugs are concerned. Some increase in the sensitivity can also occur, insulin sensitivity can also occur with the ACE inhibitors and ARB, where they may decrease blood sugar. So your question is very good, and these are the things that we have to take care of.
Right, sir.
Thank you.
So, are there any closing remarks from our speakers? Dr. Chawla, sir, Dr. Luis, Dr. Itamar.
Thank you. Thank you very much. Sorry.
I think closing remarks have to come from chairperson, but as far as my session is concerned, I have given the plus and minus, pros and cons and caveats related to CV outcome trials and the future direction which can improve CV outcome results and yield coming out of CV outcome trials. And I categorically said that CV outcomes are still mandatory. Of course, we need to have 3-point MACE with maybe addition of heart failure and other vascular complication like amputation also being equally adjudged during the assessment, which should be a blinded process so as to have more confidence into CV outcomes. And we should also try to have more primary cohort which are close to real world practice and garden variety of patient also addressed to, especially minorities must be addressed to. Like, unfortunately, most of our Indian patients, they have never been represented in major CV outcome trials. So data coming from Caucasian may not actually reflect our issues. So CV outcomes have to be more comprehensive, but these have to continue.
Thank you. Thank you.
Thank you.
So right now we are concluding the session of 4D Symposium, and it was really an interesting session, and I'm thankful to all the speakers for giving interesting talk. Thank you. Thank you.
Thank you very
Once
much.
again, and by the way, thanks Bansi, entire team, and Professor Mishra, Arvind, Manoj, Jyoti, and everyone. Thank you. Thank you, sir.
Thank you.
I expect to see all of you in Lisbon in December.
Good afternoon.
Yes.
Thank you.
Thank you so much, sir. I would like to thank our chairpersons also for their contribution. And we are moving forward to our next session. We have a wonderful academic session that is going on next. That is one of the editor's choice, the best articles from the Diabetes and Metabolic Syndrome Journal, Clinical Research and Reviews. So to chair this session and to head this session, I would like to invite none other than Dr. Anup Mishra, sir. No one need introduction for sir. And I would like to also invite Dr. Ritesh Gupta, sir, from New Delhi. And Dr. Anup Mishra, sir, is there. I would like him to tell a little bit more about this whole symposium and to proceed forward. Over to you, sir.
Thank you. Thank you for inviting me and Ritesh for this, I'm sure will be a wonderful session. I am Dr. Anup Mishra. I am Editor-Chief of Diabetes and Metabolic Syndrome and Clinical Research and Reviews. And Dr. Ritesh Gupta is accompanying me. He's Associate Editor. And he has been handling a lot of traffic of articles related to COVID-19 during the last 2 years. So we have been busy the last 2 years, and we handled close to 6,000 to 7,000 articles in last 2 years, and the traffic continues. And the journal has retained a very high position. As far as citations is concerned, we have attracted a whole lot of citations, some of the articles attracting close to 400 and 500 citations till now. And in terms of a position, I'm sure Raju will tell us more. But in terms of position, as far as citations are concerned, we are one of the topmost journals in last 2 years. And as far as COVID-19 and diabetes, those articles are concerned, also we are in the first 10. And sometimes, to my delight, we have left behind some of the top journals like Annals of Internal Medicine and even BMJ. So that kind of progress we have made in last 2 years. So while the world was isolated, we progressed in that sense academically, and partly because all of us had more time to write more articles, and I had, and Ritesh had more time to edit those articles. And that's why our quality of articles has improved tremendously. Now, our job was very difficult when we were asked by Dr. Banshi Shabu to pick up a couple of articles which were not only attracted high citations, but quality-wise, they were very good. So we attracted 7 or 8 articles and for this symposium, and 5 of the authors are here to present. And I'm very glad that these people have taken out time to present their articles. They are the best in the business. They have written wonderful articles, and we will see the quality as we go along. So there are 5 people presenting their articles today. Each one will be given around 10 to 15 minutes, and we will incorporate some discussion about the article after that. First two, one by Professor Prakash Chand Negi and Dr. Raju Vaishya, will be chaired by me, and then subsequently Ritesh will take over and will chair the rest of the 3 articles, and we'll combine together after each article for question and answer session. So is Professor Negi here?
Yes, Professor sir, I'm here. Good evening.
Professor Negi and I had long association. He was there in All India Institute of Medical Sciences along with me, and I remember those days. Very hardworking, very bright guy, and now, of course, he's commanding, research in cardiology like very few people in India. And I so much liked his article about omega-3 and omega-6 because those are this subject is close to my heart. And the moment I saw the article, I said, this has to be good. And it proved to be good. Of course, later on, I saw the name. I said, oh, written by Negi's team, then it must be good. So please go ahead and present.
Thank you, sir. Thank you so much. Can I share my slides? Is it visible?
Not yet. Not yet.
Is it visible now?
Yeah, now it is visible. Yes. You make it full screen, please.
Is it okay now?
Full screen. Still, it is half screen.
I have made it full screen. I don't know.
So you can unshare it and then share again, sir.
Okay.
Can you move the slide? Just see whether this is moving, this arrangement is working.
Has it changed?
No, second slide has not come.
Has it come?
No.
There's a problem. Is slide moving? No.
No, not moving.
I'll reshare again.
Yeah, you can do that. Click on the second slide to see whether it's moving. Yeah, it is moving now. So you can use this arrangement. You can start with the first slide.
Is it moving now?
Click on the first slide.
Yeah, this is first.
No, it is second slide that we are seeing.
Is it moving now? No.
Please share your slides first. So you can start with the slide if you want. Yeah, it is moving now. Yeah.
So I think I'll start it.
Yeah. Yeah, it is moving.
Yeah, thank you so much for giving me this opportunity, and thank you for selecting my article for this presentation. So I'm going to present our work that we have done on the role of omega-3 and omega-6 polyunsaturated fatty acids and vitamin D deficiency as a risk determinant of metabolic syndrome in obese worksite population. It was a case control study. So these are basically the work I am going to share with you is the basically contributed by my colleagues from the Department of Cardiology, the research scientists from the MRU, which is basically a Ministry of Health Government of India scheme, multidisciplinary research unit, active in various medical colleges. So we use these infrastructures to do the lab investigations. And I would like to specifically acknowledge Dr. Kapil Sharma, who is basically senior research scientist working in a forensic lab, Junga, nearby Shimla, who assisted us in estimating the polyunsaturated fatty acid omega-3 and omega-6. So as we know that overweight and obesity is an emerging public health problem globally, and if we see the incidence of obesity and overweight, it is increasing at a faster rate in the low-income countries compared to the high-income countries. And also we know that obesity increases the risk of metabolic syndrome, cardiovascular diseases, and diabetes, reported from various observational studies. But however, we have also know that we have seen patients who are obese many times may not be having diabetes, hypertension, dyslipidemia, and they do not have any cardiometabolic abnormalities. So what is protecting them from developing cardiometabolic abnormality? This is intriguing. So this was basically the trigger for conceptualizing the study design and find out as to what could be the possible mediators which predispose to metabolic syndrome and those who protects the obese individuals developing the metabolic syndrome. So we know that the omega-3 polyunsaturated fatty acids and has an important anti-inflammatory properties, and again reported in number of observational studies. And so therefore we try to evaluate the role of levels of omega-3, omega-6, their ratios, and vitamin D deficiencies. Could these be important mediators of metabolic abnormalities in the obese, normal healthy subjects? So the aims and objective of our study was to estimate the levels of EPA as a representative of omega-3 polyunsaturated fatty acids, arachidonic acid, omega-6 polyunsaturated fatty acids, their ratios and vitamin D levels, which were measured in these obese worksite workers with and without metabolic syndrome in a cross-sectional study. And these workers were working in a different organized sectors and non-organized sectors, having different job profile, like from the health department, police department, state and central public sector units, and the business houses, their owners and their the helpers. So we also try to identify the possible links between these biomarkers and the metabolic syndrome. With the various cytokines, inflammatory markers, adipokines, and insulin and resistance insulin indicator of insulin resistance. So we basically included the worksite workers with BMI of more than 30 and those who were not on supplementation of omega-3 and vitamin D in the preceding 3 months. And we had those who volunteered to participate in the study. And our research protocol was approved by Institutional Ethical Committee. So as I said, this was a cross-sectional study of worksite workers working in a different organized or unorganized sectors selected by purposive sampling method. It was not a random sampling method. And those who were not on these supplementations were the subject population who were screened for obesity. We took only the employees or worksite workers having BMI of more than 30. And so we collected the data related to socio-demographic characteristics, behavioral characteristics in terms of physical activity, consumption of vegetable and fruits, their frequencies, and consumption of sugar-sweetened drinks, use of extra salt at the table. These were some of the extended dietary the factors which were collected using the WHO STEPS survey instruments. So we recorded their weight and height using the standard tools and following standard guidelines, calculated the BMI. And we then estimated the lipid profiles, blood sugar levels at the overnight fasting, after overnight fasting. And based on the ATP3 criteria, the subjects who had metabolic syndrome and those who did not have metabolic syndrome constituted the cases and controls. We estimated these biomarkers, inflammatory cytokines like interleukin-6, TNF-alpha, and inflammatory markers, high sensitivity C-reactive proteins, adipokines like adiponectin and leptin, insulin levels, and we derived the HOMA insulin resistance based on the insulin levels and sugar levels using the standard formula. By using the Biorad multiplex system, and we estimated the levels of eicosapentaenoic acid as omega-3 polyunsaturated fatty acids, arachidonic acid as the omega-6 polyunsaturated fatty acids using the liquid chromatography MS. We estimated the vitamin D level using the ELISA system, ELISA method, and this was basically the distribution of the socio-demographic characteristics, work profile, and health behavior amongst the subject who had metabolic syndrome and those who did not have any metabolic syndrome. So out of these 145 obese subjects, which we basically volunteered to participate in this study, 105 had a metabolic syndrome. So forming about 72.5% of these obese people had metabolic syndrome, while 27% did not have any metabolic syndrome. So there was no significant difference in the distribution of these various baseline clinical characteristics which we had collected. So except for the male gender, the association with these factors with metabolic syndrome was not observed. So we also estimated we also did the analysis of the levels of vitamin D, this omega-3, omega-6, and their ratios by converting these levels into tertiles. So taking the first tertile as the lowest tertile as the reference value, whether the increasing tertile levels of the polyunsaturated fatty acids, which we estimated omega-3 and omega-6 had any association with metabolic syndrome, we found that vitamin D and omega-6 had no significant association with the metabolic syndrome. However, there was a significant association between the levels of omega-3, which is EPA polyunsaturated fatty acid, which we estimated had a very strong association with metabolic syndrome. So order of metabolic syndrome was significantly lower, almost 76% lower in obese people who had the highest the level of EPA levels. So indicating that increasing level of omega-3 EPA level, polyunsaturated fatty acid is a protector of metabolic syndrome in obese population. So we also try to analyze the levels of these various biomarkers to find out any possible link with the different tertiles. As I said, there was a significant relationship with the levels of adiponectins, leptins.
Dr. Negi, your link.
This was basically trying to find out the mechanistic link between how the omega-3 is protecting against developing insulin resistance. So we measured the levels of these adipokines, cytokines, insulin, and HOMA resistance index levels across the tertiles of the EPA levels. So we find that the adiponectin levels were significantly lower in those who had the highest tertiles of the EPA levels, while the leptin was lowest in those who had the lowest level of the EPA levels. So this is something paradoxical. Normally, adiponectin is a anti-inflammatory. It improves the insulin sensitivity. We expected the level should be high in patients with high levels of higher tertiles of EPA levels. But somehow we found this paradoxical. We have no explanation for this. So the levels of TNF-alpha were significantly high, and there was a trend of increase in the level of interleukin-6 as well as the hsCRP in patients with the lowest level of EPA levels, suggesting that low EPA levels are associated with increased markers of inflammation, cytokines, inflammatory cytokines, and indicators of the insulin resistance. We also try to compare the levels of these markers, which we did, the inflammatory markers and the insulin resistance marker, as well as the adipokine levels in the group with the high ratio of elevated ratio of omega-6 and omega-3. We took more than 4:1 as the cutoff value for the classifying individuals to have a high levels of omega-6 and omega-3. We did not find any significant difference in the levels of these various biomarkers. So just to the interpretation of based on the findings, what we have found is that almost 70% of the obese population has metabolic syndrome, And low EPA level is associated with risk of metabolic syndrome in obese population. And indices of insulin resistance and inflammatory markers had a significant association with the low levels of EPA. So significance of elevated levels of adiponectin and low levels of leptin in low level people with subjects with low levels of EPA, polyunsaturated fatty acid is not clear. So arachidonic acid and polyunsaturated fatty acid and vitamin D levels had no association with the metabolic syndrome in obese populations. So there are some limitations of this study. The number of controls were smaller compared to the number of the obese patient subjects with the metabolic syndrome. So therefore, some of the association might have been missed because of the high type 2 errors. And a significant proportion of patients refused to participate. We had identified 418 obese subjects, out of which only 145 participated. So almost more than 50% of the obese eligible, the worksite workers refused, and so that therefore there could be element of selection bias. We did not estimate the DHA as a long-chain polyunsaturated fatty acids, omega-3 polyunsaturated fatty acids, whether DHA will have improved the further, or whether it has any relationship with whether it has any association with the risk of metabolic syndrome in obese population is not known. We did not measure the composition of BMI, whether it was increased BMI was basically because of increased fat mass, whether it was contributed by the body mass, the muscle mass, because there are a number of studies that muscle mass is very, very important in determining the cardiometabolic health. So people with high muscle mass are supposed to have insulin sensitivity. The risk of cardiometabolic risk factor is lower. So these are some of the limitations which could have also influenced our results. But I think this is the only study which we have come across in obese population trying to find out whether omega-3 EP level has anything, whether it protects against the development of the metabolic syndrome in the obese population. So we can conclude by saying that low EPA polyunsaturated fatty acid is a risk factor for metabolic syndrome in obese subjects. And risk of metabolic syndrome is mediated by increased inflammatory state, leading to insulin, probably leading to insulin resistance. And efficacy of supplementation of EPA polyunsaturated fatty acid on the risk of metabolic syndrome in obese metabolic syndrome population is required to be carried out in future studies. So the omega-3, the EPA level, whether it has a causal relationship with the metabolic syndrome in obese population can be understood if we do controlled clinical trials and supplement with this EPA omega-3 polyunsaturated fatty acids and see whether it reduces the components of metabolic syndrome or improves the insulin resistance or decreases the inflammatory component needs to be studied in the future. However, we did not find any significant association of omega-6 polyunsaturated fatty acids and vitamin D levels with the metabolic syndrome in obese population. Thank you very much for your kind attention.
Thank you, Dr. Negi. Wonderful presentation. My congratulations for being selected for the best paper amongst the 5 best papers. My question to you is that you deal with the population who's living in the hills. And so how do we increase omega-3 fatty acid in the food of people who are living in the hills?
Basically, there are many the food sources which basically have the omega-3. Like if you talk about the vegetable-based sources, these are the linseed oils, and the linseed oil is the richest source of omega-3. These only contains alpha-linolenic acid. We are talking about the long-chain omega-3 polyunsaturated fatty acids. There may be people who may have a deficiency of the enzymes which are involved in conversion of these, the dietary-based omega-3 polyunsaturated fatty acids like alpha-linolenic acids to the long-chain EPA and DHA. The best source is the marine source. Of course, in Himachal, we have few areas where we have the fish. So the fish is the basically main source of omega-3. I definitely do agree that the dietary items which are rich in long-chain fatty acids are limited, especially the vegetable-based.
Thank you. Thank you for that answer. Any other question, Dr. Vaishya, Dr. Ritesh, Anuradha, other people who are attending? Ritesh, any questions? You're muted.
Yeah, I think it's being covered very well. It's very clear. It's a very good study highlighting the effect of basically the difference between various types of obesity. So one pathway or one marker could be the level of omega-3 and omega-6 fatty acids and their ratios when it comes to different metabolic patterns in obese patients. I think it is quite clear now.
Yeah, I think such studies should be done at other places also in India to see whether coastal areas they have. There was some study previously where it was seen that Konkan areas, the triglyceride of these people is lesser than the people who are staying away from the coastal areas. So they are eating more fish and possibly their long chain polyunsaturated fatty acid levels are high. Vegetarians can only have a shorter chain, not long chain. So alpha-linolic acid and so on. And flaxseed and chia seeds, etc., are some of the sources, but they are not good enough. I don't think they are good enough in any way. Not as good as the long chain PUFAs and fish oil capsules which are available now. So thank you again, Dr. Negi, for that wonderful presentation. And we move on to the next one. And we have a very distinguished doctor with us, Dr. Raju Vaishya, who's a people will say, what is a surgeon doing in a medical conference? But he's a surgeon, a researcher, writes about some topical issues of medicine also. And he's a wonderful got a lot of knowledge of statistics, which I don't have at all. So I admire him. I have seen his, papers, many papers in our journal and others. And he is himself is a editor of a very renowned journal in orthopedic. So welcome, Dr. Raju Vaishya. And I believe you already have a presentation ready. So please go ahead and play that presentation.
Thank you, Dr. Anu.
Good afternoon, friends. I would like to share my research on the topic of research and publication done from India in the last decade, especially in the field of diabetes. As you can see that research and publication are crucially important for the human well-being, especially in the field of medicine, to provide new therapies to enable doctors to help in the early diagnosis of the disease and so on. Until recently, most of the research and publications were done by developed countries like Europe, USA, etc. But recently, Asiatic countries have shown a paradigm shift in this field, and a lot of research is being published in various journals from the Asian countries. In fact, China has taken over USA as the top ranking country in this year in all subject areas and categories, which is a significant landmark because USA has always been in the front field of research and publication. And among the top 10 countries worldwide, 3 are from Asiatic nations, namely China, India, and Japan. As you can see here, the blue columns show the figures of 1996 to 2020, where USA was number 1, followed by China and UK, but now China this year has taken over USA and has become the topmost country. India also has done fairly well, and India's ranking has moved up from 7 to 4 in the last 10 years in all subject areas across the globe, and from 11 to 8 in medical publications. So Indian researchers and are doing well and are publishing in various journals which are impactful. There is almost doubling of publication numbers, as you can see, from 2011 to 2020, and from India now almost more than 200,000 papers are being published every year compared to less than 100,000 in 2011. The percentage contribution of Indian journal, however, amongst global publication has risen from 3.09 to 4.11% only. Currently, Indian publications contribute to about 13.22% amongst all Asiatic journals, and India has a lot of catching up to do to compete with the top two countries, that is USA and China, which have almost 800,000 publications from their countries every year. However, in the field of endocrinology, diabetes, and metabolism, there has been a positive trend in the research outputs and metrics. There, we found 16 Asiatic journals in these fields in this Kimago site, and these are from Japan, South Korea, and India, with Japan having the maximum 5 journals in this field, and India has 4 journals. The Diabetes and Metabolic Journal from South Korea were ranked as the #1 journal from Asiatic countries, considering all the metrics. However, the 5th ranked journal, that is Diabetes, Metabolic Syndrome, Clinical Research and Review from India, has the fastest growing site score, which was currently the highest amongst all Asiatic journals. So it's a proud for Indian journals and Indian researchers. The Diabetes, Metabolic Syndrome, Current Research and Review had also the distinction of being the highest ranked journal amongst all the journals from India in all specialty in these fields. As you can see in this bar diagram, the site score of DNSCRR is highest at 9.5, and it is much ahead of many other Asiatic journals, which is a very good thing. Again, if you consider all the important metrics related to these journals, these 60 journals are from Asia. You can see that the 5th ranked Diabetes, Metabolic Syndrome, Clinical Research and Review has the highest number of highest site score and significant number of citations per year from its publication. The current status of Indian Medical Journal is, however, a bit grim. There are relatively low number of journals being published from India, and only 180 journals are listed from India out of total of 6,882, making it only 2.6%. So there is a need for huge improvement in this field in future, and I believe that government and academic institution can play a crucial role in raising the interest and helping the research, especially from India, by providing them substantial grants, library facilities, free access to online literature search, and recognizing their research on a larger scale. Thank you very much for your attention.
Thank you, Dr. Basha. I think this was wonderful. This is something which we always wanted to know where we stand as far as the Asia is concerned, as far as world is concerned. Sure, you agree, and you have already put it in the last slide. We have a long way to go. We have a long way to go. But we are trying. We are trying, and we have a great ally in you who analyzes our data, our ranking, and have published so, and that is now a published document which is now being seen by many people and being appreciated. Thank you, Dr. Basha. If there's any questions from anybody, Ritesh, any questions? Ritesh? Anuradha, any questions on this? Ritesh?
Yeah, I think Dr. Raju Vaishya has been, we have so many articles from his pen in our journal, and it's always a pleasure to read those articles because they are so, as you said, that there's so much of statistics involved in that. So you tend to learn a lot, and many topics he has analyzed, especially during this COVID times. And this particular article about the ranking of various journals from India is very promising, and I think it gives us impetus to do more and to exactly know where we stand. We have made some progress, but yes, we need to do much more. Thank you, Dr. Vaishya.
So thank you, Dr. Vaishya, for presenting your wonderful data here. I hope
I have a comment.
Yeah, please.
Dr. Mishra, I must compliment you for running such a high impact journal, which is very good and very positive in taking non-diabetes authors also in your portfolio. And in fact, one of the 3 of the 5 topmost articles that I have ever published out of 700 articles that I have published are in your journal. So compliments to you. And it is wonderful that, in short span of time, your journal has achieved skyrocket image and reputation. And that is not only the best in the country amongst all medical journals and specialty, but also in the Asia. So hats off to you and keep growing. Thank you.
Thank you, Dr. Vaishya. And your article is highly cited. You know that, we know that. I was looking at the journal's performance of last 1 year. The Elsevier has released that, and your article is highly cited all over. Your articles, not article. So thank you. Thanks a lot for contributing, and I hope you will continue to contribute. And you always sound me off whether I am going wrong or I am going right in the way. So thank you for being there as a friend as well. Thank you, Dr. Vaishya.
Thank you. Thank you.
So at this point, I'll hand over the mic to Dr. Ritesh to carry on with the proceedings.
Thank you, sir. We have a very eminent speaker now. We have this article, a very interesting article. We talk about type 1 diabetes, we talk about type 2 diabetes. Whenever we talk about metabolic risk, we talk about type 2 diabetes. But here is something very interesting which has been done to study the association of parental metabolic syndrome with metabolic risk in children with type 1, children adolescents with type 1. So, so I'll invite Dr. Anuradha Khadikar from Pune to present the paper. Over to Dr.
Everybody. Good evening, everybody, and thank you, Dr. Ritesh, for the kind introduction. And I will just share my screen.
Yeah, the slides are visible. Please make it in the presentation mode.
Yes. Yeah. So thank you once again both for giving us the opportunity to publish this paper in the prestigious journal, and also for inviting us today to present this. The paper is entitled "A Pilot Study to Determine Association of Parental Metabolic Syndrome with Development of Metabolic Risk in Children and Youth with Type 1 Diabetes." We have published recently in this journal. Just to introduce the topic, we look after children with diabetes, and we have a fairly large cohort of around 500 to 600 children who come to our clinics regularly. We function out of the Jahangir Hospital in Pune Research Center here. So we know that the prevalence of metabolic syndrome in Indian adults is estimated to be about 25%. Development of insulin resistance is due to the fatty acid flux that is the most widely accepted role. I'm just going to put this down. So the coexistence of metabolic syndrome in type 1 diabetes, it is coined now as double diabetes. So metabolic syndrome type 1 diabetes. So problem statement was, in a previous study, we found that around 4% prevalence of metabolic syndrome in children and youth with type 1 diabetes. In fact, an additional 37.5% had some other metabolic risk parameter, of course, other than high blood glucose, which is there in most of our children. We recently also published this in Endocrine in this same year. So genetics, family history of type 2 diabetes and metabolic syndrome are possible mechanisms of reduced insulin sensitivity in children and youth with type 1 diabetes. As per the International Diabetes Federation, the Atlas 2019, we mentioned that here because that is what we have put in our paper. India has the largest number of children and adolescents with type 1 diabetes, around 1.7 lakh cases. In fact, according to the 2021 Atlas, now we have the dubious distinction of having the largest number of prevalent cases of type 1 diabetes in India. So given the prevalence of metabolic syndrome in Indian adults, which we saw was around 25%, also the number of children, very high number of children with type 1 diabetes, we conducted this pilot study to assess the role of family history and environmental factors in development of insulin resistance and thereby double diabetes in children with T1D or type 1 diabetes. So our primary objectives were to study metabolic profile of children with type 1 diabetes and their parents, and to study the association of parental metabolic syndrome with development of metabolic risk in patients with type 1 diabetes. So I'll put all of this up. So we did the study, we did it on 30 children from our cohort of over 500 children who attend our clinics regularly. The age range was 6 to 21 years. We randomly approached children for participation in the study. Children with comorbidities like celiac disease, untreated hypothyroidism, eating disorders, and polyendocrinopathy were not included because these are confounders. While performing investigation, one child was detected to have celiac disease with an anti-TTG-IgA positive, and thus we had to exclude the child from analysis. So the final analysis was done on 29 triads, 29 children with type 1 diabetes and both their parents, the mother and the father. So this is how the data collection was done. Anthropometry was done using standard protocols, height, weight, BMI. We converted all of them to Z scores using Indian references. Biochemical investigations included HbA1c and the lipid profile. We did, in the anthropometry, of course, we also measured the waist circumference and classified it according to Indian criteria. We measured body composition using a bioelectrical impedance. And then, of course, there was the clinical examination and questionnaires. We defined the metabolic syndrome as per the IDF definition. So for a person to be defined as having metabolic syndrome, on the left side, you see the grayscale is the adults and the one on the right is the children. So central obesity is you require a high waist circumference to actually classify a person as having metabolic syndrome, plus two of the following: either raised triglycerides over 150, in a reduced HDL of 40 in men and 50 in women, raised blood pressure over 130 systolic or 85 diastolic, and a raised fasting plasma glucose of 100. Now, as far as metabolic syndrome in children is concerned, it's like everything else that we do in children, it's a little tricky. Under 6 years of age, if a child has a waist circumference of more than the 90th percentile, then then you actually need to look at family history of metabolic syndrome, type 2 diabetes, dyslipidemia, cardiovascular disease, hypertension, and or obesity. So we don't usually diagnose a metabolic syndrome in children under 5 years of age, under 10 years of age. Then between 10 to 16 years, you with a waist circumference of more than 90th percentile, or the adult cutoff or above the adult cutoff, with a triglyceride of more than 150, again HDL of less than 40, and systolic BP more than 130, equal to or more than 130, and diastolic equal to or more than 85, and with a fasting plasma glucose of more than 100. So over 16 years, it's again the same definition: central obesity plus hypertriglyceridemia, low HDL, raised blood pressure, and or raised fasting plasma glucose. So going to our primary results, 44.8% of patients with diabetes had metabolic risk, with low HDL being the most common component of the metabolic syndrome. Amongst the parents of children screened, so we screened 60 parents, 25.3, that is 15, had metabolic syndrome. Low HDL and of course high waist circumference, which is necessary to classify a patient as having metabolic syndrome, was the most common components of the MS seen in 55% of individuals. 64.3% of patients with diabetes who had parents with MS, which we saw is 15 of the 60, that is 25%, had metabolic risk. Metabolic risk in patients with type 1 diabetes had strong relation with parental MS. However, similar correlation for overweight obesity was not observed. So this is what we found was terribly interesting, that the correlation was very strong with parental metabolic syndrome. So the same thing is presented here. You can see that the light blues are the children, the purples are the adults. So the waist circumference was high in 6.9% of the children, 13.8% children were hypertensive, 34.5% had low HDL, 55% of adults had either a high waist circumference or a low HDL, around 40% were hypertensive, and 20% had hypertriglyceridemia. So as we discussed, a total of 15 individuals among parents of patients with type 1 diabetes, 9 males and 6 females, had metabolic syndrome. Almost 2/3 of these parents had children with metabolic risk, that is around 64%, which is the bar over here. Maternal hypertension was associated with hypertension in participants with type 1 diabetes, while low paternal HDL, low father's HDL, was associated with low HDL in children with type 1 diabetes. Odds ratio for development of metabolic risk in patients with type 1 diabetes with parents affected by MS was 4.9%, while relative risk of development of metabolic disturbances in participants with T1D born to parents with MS was 2.4%. So ours is, I think, to the best of our knowledge, ours is the first study describing the association of the development of metabolic risk in patients with type 1 diabetes with the presence of metabolic syndrome in parents. We couldn't find another study which was done like this. As the presence of insulin resistance and thereby metabolic syndrome in patients with type 1 diabetes is known to be associated with an elevated risk of microvascular complications, early identification of such patients is very important. The limitation of our study, of course, is the small number. It's a pilot study. And of course, single center data. It was done at our center in Pune. And lack of longitudinal data on development of microvascular as well as macrovascular complications in the participants that we enrolled. So to conclude, individuals with type 1 diabetes microvascular complications of developing metabolic syndrome and thereby double diabetes if their parents had metabolic syndrome. A positive family history may serve as a useful indicator for targeted screening to detect occurrence of MS in children with type 1 diabetes. So as I said, we have a large group of children who come to us regularly. These are children having some fun. Without all these children taking part in our studies, we would not be able to conduct such studies. I'd also like to take this opportunity to thank all my team members, and especially Dr. Chiranta Poza, who is also here with me, who is the first author on the study and who really helped with this work. Thank you so much. Thank you.
Thank you, Dr. Raghunathan.
Thank you.
So that was a very well presented study. We had already read it, of course. So it's a very important study, as you said, the first of its kind, to highlight the association between parental metabolic syndrome and metabolic risk in children with type 1 diabetes. We often tend to ignore metabolic risk in type 1 diabetes, especially in children. Once they are adults, we might look at their other parameters, but people tend to ignore that. So what your study does is to highlight that aspect very well, that children with type 1 diabetes have an increased metabolic risk as well. Interestingly, there was, of course, some association between parental metabolic risk and children's metabolic risk, but then there were many patients with type 1 diabetes who had metabolic risk despite their parents not having metabolic syndrome. So this is also interesting.
Yes, certainly.
So to what extent the family history contributes to metabolic risk, and to what extent type 1 diabetes per se itself contributes to metabolic risk in these patients is something which we need to probably answer in a larger step.
Yes,
I would like to know, did any of the parents have type 2 diabetes? They have metabolic syndrome, but
No. Of these 30, no. But like I said, we have a fairly large group, and there are a fair number of children whose parents do have type 2 diabetes. They are there. But they were not in these 30 children whom we studied in this particular project.
Okay, so
Dr. Kadilkar, I think you are a very distinguished researcher, have published a lot on children and various markers and bone density, and using all kinds of measurements of anthropometry and so on. So we respect your contribution to anthropometric research in India. I myself have contributed, our team have contributed a bit to it in adults as far as adults are concerned. I hope you will continue to contribute to our journal with your
Absolutely, sir. Absolutely, we will. Thank you so much, sir. Thank you for the kind words, and thank you, Dr. Ritesh. Thank you.
Thank you, ma'am. Thank you. Yeah. So we go on to the next presentation, and which is from Indonesia. So we have Dr. Nani Natalia Subedio, who's going to talk about a very important topic as to how is antibody response following the SARS-CoV-2 vaccination in patients with type 2 diabetes. So over to Dr. Subedio.
Thank you, Dr. Ritis and Prof. Anup. This is a very honor for me. I want to share. Have you seen my slide?
Yes.
Yeah, we can see the slide. Yeah.
Thank you. This is only a systematic review. We are in the team to see what is the antibody response following SARS-CoV-2 vaccination among patients with type 2 diabetes mellitus. And this is my team. This is myself. Maria is nephrologist. This is Shirley. He is very good in statistics, and Hikmat Permana is the supervisor from endocrinology division. And yes, introduction. Yeah, as we know that global data, it is a lot of number of cases, and we hope that it will decrease right now. And we really hope that there is no COVID again right now. And then the invention of COVID-19 vaccine is very, very help in battle on ongoing pandemic. But as you can see, especially the vaccine COVID-19 is protect vulnerable population such a patient with type 2 diabetes mellitus, and also not only type 2 but type 1 and other type of diabetes mellitus. So the problem in patient with type 2 right now is with the COVID, as we can see that they have increased risk of morbidity and mortality due to innate and adaptive immune response alteration, and they are not achieve seroconversion of SARS-CoV-2 antibody even after 2 weeks of diagnosis. It is also seen a lot in the reality with patient diabetes with COVID-19. So the antibody response after the COVID-19 vaccine among these patients is still unknown until right now. So that's why what is there is will be increasing risk of severe disease in the diabetes mellitus population. So the aim of the study is explore the SARS-CoV-2 antibody response or seropositivity among diabetes mellitus patients following the COVID-19 vaccine. So we try to see the systematic review. Actually, from the beginning, we want to do the meta-analysis, but as we can see from the Prisma graph, the literature search is from PubMed and also MBS, and the keyword is COVID-19 vaccine or COVID-19 vaccination or SARS-CoV-2 vaccine or SARS-CoV-2 vaccination and antibody or neutralizing antibody or anti-RBD or anti-SRBD or IgG or seropositivity and diabetes mellitus or DM or diabetes or diabetic or type 2 DM. So we input all of these keywords, and then from PubMed we found only 18 and MBase 49, and we see that duplicate we remove it, and this is we only find 51, and then records which is I will show you this one. The inclusion criteria is we include the patient age more than 18 who received 2 doses of the COVID-19 vaccine irrespectively of the vaccine type, and the exclude one is the pregnancy, autoimmune, chronic kidney disease, or underwent hemodialysis, and also non-English article, case report, and something else. And then if we come back again to the flow chart after we do the records of the exclusion and inclusion criteria, this is we only find 8 articles which can be which we can be reviewed. And if you see the result, characteristic of the study included in here, we see only 8 and only 1, I think, which is have the number of the antibody seroconversion. The other ones is only positive or negative and only qualitative measurement. So if you can see in here, all of the type of the vaccine we included in here. It is the inactivated vaccine or mRNA vaccine, and also one of from your country, I think it is doing the Covaxin team, visit COVAX study. As you can see in here, oh why? Now this one vaccination type and antibody 5 study using the Pfizer, which is a mRNA. 1 study using the CoronaVac, this is Sinovac. 1 study use the both. And one study, this one I think is from your country, using the Covishield and Covaxin vaccine. 5 study report antibody titer qualitatively. Only 2 study report the COVID-19 IgG and IgM, but only 1 study reported the quantitative antibody. It is from the Nomura et al. This one, and it is in a lower antibody response in diabetes versus non-diabetes patient in here, if you can see in here. So, as the discussion, as you can see, previous study regarding vaccine in diabetes mellitus patient were shown to promote an appropriate B-cell immune response after the influenza vaccine, also the PPV-23 vaccination, and also in the hepatitis B vaccination. That's why it's very different in diabetes mellitus patient compared to healthy population. Diabetes mellitus patient population is susceptible to infection. That's why the vaccine preventable disease is right now is given routinely. I think in all the guidelines right now, they give the schedule for the patient with diabetes mellitus to get the vaccine, although the COVID vaccine is still not included in the guideline, but I think influenza and hepatitis, I think has already included in here. But the seroconversion rate after SARS-CoV-2 vaccination is like the other vaccine is lower among the healthy control compared to type 2 diabetes mellitus. And from the Karamazov study, there is a significant difference in antibody response among 49 diabetes patients, which is more 65 years old after 2 doses compared to the healthy one. This is very interesting also. And the COVAX and diabetes COVAX DM study, they find that A1C level were not as the factor which is make the antibody, but the H and EGFR is the predictor for antibody level after COVID-19 vaccination among type 2 diabetes mellitus. This is very interesting because I also do some research about the giving the stimulation of antigen, also find the same. The A1C were not in the contributing factor to get the immunity, but the other factor. And the purpose of the hypothesis is maybe there is the altered adaptive immunity response among diabetes mellitus patients. Maybe it's because of the different circulating T helper cell, the CD4, CD8, and something else which is contributing to adaptive immune response. That's why in diabetes mellitus, we cannot say the immune deficiency, but we call it the dysfunction of immunity in the patient with type 2 diabetes and also type 1 diabetes. So that's why hyperglycemia weaken the immune system against SARS-CoV-2 vaccine due to antibody and adaptive immune response to the dysfunction. But the caveat study find, this is very interesting also, the A1C level more than 7% is lower the cytokine and antibody titer compared to A1C level less than 7. So okay, then the A1C is not the big factor, but still the controlling glycemic is the important one to make the level higher compared to the non-control one. That's why hyperglycemia at the time of vaccination might worsen the immunological response. This is the caveat study from Marvella et al. They find that it is very different between non-diabetic and also diabetic with A1C less than 7 and also A1C more than 7%. This is all of the adaptive immunity in here. So the MRA 1273 vaccine phase 3 trial, they're still right now still on the trial. Wait, it is have the protecting also in the type 2 diabetes or no, but there is no specific antibody test right now that can determine an individual risk of subsequent infection. The antibody response was still robust and persists. Therefore, patients with diabetes population should be priority to be vaccinated. But the study limitation, the total number of study included was limited. Only several studies reported the antibody response after the SARS-CoV-2 among the diabetes mellitus population. Only one study reported the quantitative serology response, Nomura study. We could not analyze the mean total of antibody titers among diabetes mellitus patients after vaccination, and we cannot analyze the confounding related to the study, including comorbid and or age related to this study result like the COVAX study. So the conclusion, the seroconversion rate after SARS-CoV-2 vaccination in diabetes mellitus patients were lower than the healthy control. However, the antibody response was still robust. Therefore, all diabetes mellitus patients are priority to get the SARS-CoV-2 vaccination on the schedule, and it is a high risk of deterioration and poor prognosis among COVID-19 with diabetes mellitus patients. Thank you. It is from our team, and we would like to congratulate you for the Thomas Cup winner. Thank you.
Thank you, Dr. Sutil. Yeah, as your review has very nicely pointed out, that the seroconversion rates are lower in diabetes, the patients with diabetes, and which is quite expected, which is in line with what the rates are in most other diseases. But the reassuring thing is that the antibody response is still robust. It is not that the diabetics are doing very badly. They have less seroconversion rate, but still the antibody response is there. Yes. And of course, we could not answer the question about HbA1c very categorically, but yes, there was some suggestion that those who had, in one study at least, that those who had a higher HbA1c had poorer seroconversion and CD4 responses. So I think it's a well conducted review. It again highlights the importance of giving timely vaccination to patients with diabetes. So any comments or questions from anyone, please?
Dr. Nani, I think that's a wonderful review that you have published. And I'm sure you have much more data than this. I'm sure you will have follow-up data of these patients, some other data, and we'll be happy to receive your articles in the future. Yes. And meanwhile, congratulations once again.
Okay, so you will accept my publication for the next because yes.
we always do the peer review, but I going by your standard, whichever publication that you are going to send is going to be good.
Yeah,
I think so. So,
yeah,
so if it is good, it is going to be published, sure.
Yeah. Because right now we're doing the data because of the system. This result, we're doing the real data to collect all the antibody in type 2 diabetes, which is received to vaccinated or not vaccinated or get the COVID and maybe have the booster. And we want to compare all of it. And then, if it is the data is good, and I will try to submit to your journal.
Such data are very much needed. And unfortunately, in India, we still don't have enough data in this direction as far as diabetes is concerned. And we have been telling this to many of the researchers that please go ahead and have a cohort like this. But I'm sure your data will be useful even to our population. So thank you once again. Thank you once again.
Thank you. And it is a very honor for me. Thank you so much.
Thank you, Dr. Naik. So we now come to the last presentation of this session. And this is by Dr. Sri Manjunath from Jodhpur, who's going to talk about association between branch-chain amino acids and the triglycerides and glycosylated hemoglobin in patients with type 2 diabetes. So over to Dr. Sri Ramanujan.
Very good evening. Please allow me to share my slides.
Yes, we can see your slides.
So, a very good evening. At the outset, I would like to thank the editor-in-chief and associate editors of Diabetic Metabolic Syndromes and Clinical Research and Review and the organizing committee, giving us an opportunity to present our work titled Positive Association of Branch-Chain Amino Acids with the Triglycerides and Glycated Hemoglobin in Indian patients with type 2 diabetes mellitus. So there is no conflict of interest associated with the present work. Abstract, which was published in Diabetes Metabolic Syndrome Clinical Research and Review. So diabetes mellitus, it is a chronic disease which affects the 1 out of every 11 adults, and it constitutes of 75% burden found in the developing nations. So global burden of a diabetes study, according to the global burden of a disease study, diabetes is the 9th foremost cause of reduced life expectancy. The type 2 diabetes mellitus, it is account for about 90% of total diabetes cases, and it is a heterogeneous disorders resulting from modifiable and non-modifiable risk factors. The resulting metabolic disturbances are due to the insulin resistance or insulin sufficiency or both in diabetes. With the advancement in metabolic approaches, it is found that the circulating amino acids are an important modulator of glucose metabolism, insulin secretions, or insulin sensitivity, which suggested to serve as a novel biomarkers for predicting the risk of type 2 diabetes mellitus. The plasma branch chain amino acids, mainly the leucine, isoleucine, and valine, all were connected to several metabolic diseases, but their relevance for the prediction of type 2 diabetes mellitus development is unclear yet. These branch chain amino acids, they undergo extensive metabolism in adipose tissues and as well as in the skeletal muscles. They catabolize mainly by two important enzymes. One is branch chain amino acid transferase, and there is a branch chain keto acid dehydrogenase complex. This BCK-DH complex, it is a rate limiting enzyme, which is regulated by two important enzymes. One is known as a branch chain keto acid dehydrogenase kinase, and another is the protein phosphatase 1. And these branch chain amino acids also play a significant role in signaling the PI3K, AKT, mTOR pathways. So in which they regulate the expression of various genes which involved in glucose and lipid metabolism. In the recent some prospective and positive studies, they have revealed the increased total branch chain amino acids levels associated with the higher triglycerides and lower HDLC, which leads to metabolic dyslipidemia. However, there is no consensus with regards to the association of branched chain amino acids and metabolic dyslipidemia in type 2 diabetes mellitus. At the same time, the evidence in the Asian community, especially in the Indian population, it is very sparse, with most of the studies on the association of plasma branched chain amino acids and type 2 diabetes mellitus have been done on the Western populations. Further research is warranted to illustrate the interlink between branched chain amino acids and dyslipidemia in type 2 diabetes mellitus in Indian population. So, therefore, the study was designed with an aim to determine the association between plasma and urinary total branched chain amino acid levels and insulin resistance. Second, to determine the association between plasma and urinary total branched chain amino acid levels and serum lipid profiles. Third, determine the association between plasma and urinary total branched chain amino acid levels and HbA1c between type 2 diabetes mellitus patients and the healthy controls. So this is an analytical cross-sectional study. We recruited 80 subjects. The sample size for the present study has been calculated based on the observed mean difference in a BCA stated in the recent study. So the study was done in Department of Biochemistry and Endocrinology and Metabolisms, and we have taken the Institute Ethics Committee approval before recruiting all the study participants. And also we have taken the written informed consent from the participants. So the selection of the study participant within the age range of 30 to 70 years, both normal and the patients was random. All the healthy control subjects were considered for the study only after following the routine clinical screening procedures and taking their consent before enrollment in the study. Similarly, the diagnosed type 2 diabetic patients with fasting blood sugar of more than or equal to 126 milligram per deciliter or the HbA1c value of more than 6.5% were taken up in the study. The patients who are suffering from type 1 diabetes or the type 2 diabetic patients suffering from any acute or chronic infections, suffering from a liver or a kidney disorders or a diabetic patients on the lipid-lowering drugs all were excluded. So we have collected the fasting blood samples for the estimation of glucose, the insulin, the lipid profile, and total branched chain amino acids. And we also collected the midstream urine samples for the total branched chain amino acid estimations. All the samples will stored at -80 degrees Celsius in a deep freezer before their analysis. Come to the biochemical parameter measurement. So all these samples for the biochemical parameters were analyzed using the fully automated clinical chemistry analyzer, the Beckman EU680. So fasting plasma glucose was estimated based on the hexokinase method. The HbA1c was measured based on the immunoinhibition method, and lipid profile were measured based on the enzymatic method. The serum insulin was estimated by using the fully automated immunoassay analyzer, that is a diazonium lyazine, which based on the chemiluminescent enzyme assay. Total plasma and urinary branched chain amino acids were estimated by using the commercially available branched chain amino acid assay kit with leucine as the standard. The absorbance of the colorimetric product is proportional to the branched chain amino acids, so whose concentration was measured at 450 nanometers by using the ion microplate spectrophotometer. So all the findings were statistically computed and the results were obtained. The statistical analysis were performed using the SPS version 23. So all the relevant appropriate statistical tests were applied. So coming to the result, so coming to the general characteristics, the biochemical parameters and the insulin resistance indices of a patient with type 2 diabetes mellitus and the healthy control subjects. So we found that the fasting plasma glucose was significantly higher in the type 2 diabetic individuals compared to the control subjects. And when we calculated the HOMA-IR, which shows the statistically significant increase in type 2 diabetic cases compared to the two groups had no significant difference in terms of age, gender, and the fasting insulin levels. Next, we want to compare the plasma and urinary branched chain amino acids in type 2 diabetic patients and the healthy controls. We found there is a significant increase in total branched chain amino acids in the plasma of a type 2 diabetic cases compared to the healthy controls, whereas we didn't find any significant change in the levels of urinary branched chain amino acids among the type 2 diabetic cases and the control study. Then we have determined the association of plasma and urinary branched chain amino acids with the insulin resistance in patients with type 2 diabetes. So both the plasma branched chain amino acids and the urinary branched chain amino acids did not show any significant association with the calculated HOMA-IR, but they show a weak positive association having the rho factor of 0.265. then we find the association of plasma and urinary branch chain amino acids to the lipid profile in both diabetic cases and in the control subjects. So among all the lipid parameters, only the triglyceride has shown the significant positive association. The rest does not show any kind of association with the plasma branch chain amino acids, whereas the urinary branch chain amino acid does not show any significant association with the lipid profile. Lastly, we have did the association of branch chain amino acid to the glycated hemoglobin in both type 2 diabetic cases and the control subjects. So the plasma branch chain amino acids have shown the positive significant association with plasma branch chain amino acids to the HbA1c, whereas the urinary branch chain amino acid does not show any significant association. So going to the discussion. The result of the study, that is the significantly elevated plasma branch chain amino acids levels, were consistent with the findings of the other studies. So it could be because of excess protein ingestion or increased protein turnover, or there could be an influence of the gut microbiota or disturbance in the catabolism of branch chain amino acids might cause the increase in the plasma level of branch chain amino acids in type 2 diabetic individuals. Again, we know that the branch chain amino acids, they have shown to be a modulator of glucose and insulin secretions, and their elevated plasma levels will exert adverse effects on a glucose homeostasis, because the oxidation of branch chain amino acids will space the glucose utilization in the skeletal muscles. So there is an association between insulin resistance and elevated branch chain amino acids levels across the different populations, but in our present study, we did not find the association. And this is similar to the Attai et al. Study findings. So according to Attai et al., they observed there is no correlation of branch chain amino acids with the HOMA-IR among the Asian Indian in comparison to the Chinese population. The findings also demonstrate that there is a significant association between the plasma branch chain amino acids and triglyceride, which is similar to the predictive ability of a branch chain amino acids to dyslipidemia after 4 years in a Japanese study. So findings also showed there is a positive association between the plasma branch chain amino acids and HbA1c in a study subjects with type 2 diabetes, but with no precise correlating mechanism. So as we know that the adipose tissues, they plays a vital role in branch chain amino acid homeostasis. So among the branch chain amino acids, the leucine is an activator of mTOR, that is a mammalian target of rapamycin signaling pathway, which promotes the lipid synthesis by activating the SREBP1, that is a steroid regulatory element binding transcription factor 1, which involved in synthesis of fatty acids. Again, the byproducts of leucine and isoleucines, that's mainly the C3 and C5 acyl carnitine, they also serve as an important substrate for the cholesterol biosynthesis. So there is increased fatty acids and cholesterol biosynthesis in adipose tissues, and the branch chain amino acids mediate activation of a mTOR SREBP1 pathway could be a reason for metabolic dyslipidemia in diabetic subjects with elevated plasma branch chain amino acids. So again, in our study, the data from the present studies reveal that there is a non-significant higher urinary BCA level, and there is a non-significant association of urinary branch chain amino acids with HOMA-IR, lipid profile, and HbA1c in individuals with type 2 diabetes mellitus. With the results of the present study and the observation from the other studies, we hypothesize that the branch chain amino acids play an important role in lipid metabolisms, and they contribute to the metabolic dyslipidemia in type 2 diabetes mellitus. The increased branch chain amino acids because of the dietary factors or the influence of the gut microbiota, or because of the type 2 diabetes per se, they can increase the plasma branch chain amino acids. So the elevated plasma branch chain amino acids, they increase the several diabetogenic risk factors causing the hyperglycemia, which in turn will increase the lipogenesis or the enzymes which are involved in the lipid metabolisms, leading to the increased triglycerides. Secondly, the BCA byproducts like C3, C5 acyl carnitine, propranolol-CoA or succinyl-CoA all will increase the cholesterol and fatty acid synthesis, leading to increased triglycerides. And the activation of mTOR SRB pathway through the leucine, which can increase the fatty synthesis, leading to the increased triglycerides, and all will lead to the metabolic dyslipidemia in type 2 diabetes. So coming to the conclusion, so this is our first study on plasma and urinary branch chain amino acid concentrations and its association with insulin resistance, lipid profile, and HbA1c in type 2 diabetic individuals in the Indian populations. So the findings demonstrate the elevated level of plasma branch chain amino acids in patients with diabetes, and higher plasma BCAAs was positively associated with triglyceride and HbA1c. The results will provide a new insight for plasma BCA as marker of metabolic dyslipidemia in type 2 diabetes patients. However, further large-scale studies are warranted to confirm the interlink between the BCAAs and metabolic dyslipidemia in patients with type 2 diabetes mellitus. These are the references. This work was supported by the Institute Intramodal Grant, AIM Jodhpur. Thank you. Thank you for patience listening.
Yeah, thank you, Dr. Manjunath. See, one thing was intriguing, that we often say that we Indians have a very low protein intake. We are largely protein deficient. We are muscle deficient, protein deficient. And then we are finding high levels of branch chain amino acids in diabetics. So how do you see any other reason apart from the dietary access? Because most of us don't take enough protein, and I'm sure Jodhpur definitely a large part of population is vegetarian. So how do we reconcile to that?
Yes, sir. What you say is true, sir, because normally the branch chain amino acids, these are the essential amino acids. So these must be supplied to the diet. But the other factors like the recent investigations show the importance of a gut microbiota. So we have a bacteria which can synthesize the branch chain amino acids. So if we look into the specifically about the gut microbiota, probably we can throw some light on why there is an increase in branch chain amino acids. And these branch chain amino acids, especially they found mainly in the non-vegetarian diet. Normally the red meat, it has a rich source of branch chain amino acids. And again, the cereals, the beans, the vegetables, they also have a more of branch chain amino acids. So here is also, in our study, the one limitation is we have not taken the dietary history. Probably that is the affect our results. So again, we are undertaking this some other studies where we are taking a 24-hour recall dietary history for 3 days. Probably that will give some ideas.
Yeah, that will be very...
Ritesh, just a moment.
Interesting. Also, yes, sir.
Dr. Arvind is waiting to join. Dr. Arvind, are you there, sir? Dr. Amit Gupta is here and Dr. Banshi Shabu is here. So if any of you want to ask any questions to me or to any of the participants, please do so. We have many other questions waiting, so please don't go away. Yes. Dr. Arvind, Dr. Banshi Shabu, Dr. Amit, Jimit, whenever any of them join, please announce so that we can include them in our question answer sessions and have their advice also, have their views also.
Dr. RX event, can you let Dr. Arvind sir in? Sir is waiting in this meeting. RX person.
I think he was. I saw him briefly in between.
So we can continue discussion till then.
Yeah. Okay. Ritesh, please go ahead with the next question.
Yeah. So we have some questions.
Yeah. Just a moment. Arvind has joined. Arvind, thank you for joining this discussion, and I hope you were listening to some of the discussion that we had earlier. And this is what is going on is the last discussion on the last paper on branch chain amino acid in patient with diabetes. And Ritesh here is continuing with some of the questions. And you're welcome to have, we would like to listen to you regarding any of the presentation or anything related to presentation after Ritesh's question is over.
Anup, I'm so sorry that I had to join in late because there are some issues with the electricity, and then I'm sitting in the room and then trying to connect from there. There were issues with internet and electricity, and I was also not getting an access. So I just called up Jimit and said I'm not getting an access. I moved out of the room. They'll just come. So I was not able to listen to the sessions, but I'm so very sorry. But from now on, I'll keenly listen to what you have to say.
The head of Diabetes India not getting access? That is unacceptable.
I mean, that was the problem. That was the problem with the hotel here. Unfortunately, our block did not have power, and suddenly the internet got disrupted.
Okay. Great to have you with us. And Ritesh, please go ahead with the questions that you were asking.
Yeah, so we were discussing about branch chain amino acids as was presented. So there is a trend, as I have seen in many youngsters who are going to the gym and bodybuilding and all, as to take BCAA. So many of them take these supplements with very large fancy bottles having BCAA capsules and powder. So what do you say, Dr. Srimanjunath? Should these be taken? Should we advise against taking BCAA supplements in light of your findings?
Sir, it is like two kind of way, because some of the studies will show that the BCAA has some of the protective role in liver disorders.
Yes.
Same way, if you look into the research in the diabetes, so most of the Western literature showing the link of increased plasma branch chain amino acids with the insulin resistance. So if we think of the in terms of diabetes, we should be cautious about the how much amount they are going to take the branch chain amino acids.
Yes, I think that's what we need to come up with. Yeah, sir.
Yeah, Amit was there. Amit, are you there still?
Yes, sir. I am very much.
Would you like to comment? Here we are talking about branch chain amino acid and in general, and specifically in relation to diabetes. So, and Ritesh asked a very, very pertinent question. You know, the branch chain amino acid or any amino acid are dime a dozen in any gym, and people are taking. People are actually following less of their doctors, but more of their gym trainers these days, and they will take anything there. So what do you think about in general this problem of very high protein supplements which are available on the counter and in the gym and being prescribed, and here we have a research paper that it may be a problematic thing. So what do you think about it?
Sir, I would just like to mention that increasingly there is a trend that most of the young patients, as you recently one of your papers you told that the diabetes in young is increasing, and the young people are very much interested in going to gym and all. And whenever they come for the consultation and we advise them some kind of physical activity, the first thing they talk about is that shall they join a gym? And the next question that comes is that whether they should be taking the supplements which they are likely to be getting at the gym, and most likely these supplements are the protein shakes or the very fancy shakes which are usually given to them, and I think they are almost part of every gym. But to be very true, sir, we don't have a clear-cut answer, and we don't know what kind of benefit they are doing to them. Rather, there is always, as a medical specialist, I would always look into this with some suspicion, because we don't know about what kind of impact they are going to have. What kind of impact they are going to have on metabolism, as the paper by Dr. Sri Manjunath suggested that they can be having some deleterious effect. So I think we should be very cautious when we guide these patients and regarding the protein shake or protein or the branch chain amino acids, or just like you mentioned in your questions. So I think it is very, very important.
There are a couple of papers, and I would like Dr. Sankara to have opinion on what I'm about to say. There are a couple of papers where if you take protein supplement just before the exercise, resistance exercise, say weights, heavy weights, and you take protein supplements before that, then actually it leads to increase in the skeletal muscle efficiency and insulin metabolism in the muscle. Now, we all know that the muscle insulin resistance is one of the earliest effects of defects in the whole cascade of diabetes. So, what do you say about that? And I would like Arvind's opinion after this. Yes.
I'll just make a small
Yeah.
comment here. I mean, very rightly taken what you said. It improves the skeletal muscle performance. But there is also another theory, Dr. Anu, but I think you can help me out and others can help me out. Whether I'm right or wrong, I don't know. See, when you take these supplements and when you start exercising, yes, there is a tendency to put on some amount of weight. Well, it may be good weight, but then nobody reduces the fat content to the desired levels. Okay, and most of these trainers are interested in seeing that, you know, your chest muscles improve, your biceps improve, your triceps improve, your thighs improve, and that's great to look at in these youngsters. But then nobody is really measuring the fat content accurately. Now the theory is, especially in a country like India, when there is a genetic susceptibility and when the BMI moves and shifts to the right, and as the weight increases, the hepatic fat content is known to increase. The islet fat content is known to increase because of the high triglyceride value. And that itself can cause insulin resistance and diabetes. I mean, this is thinking too forward, but then I really don't know whether increasing weight without reducing the fat content, is it a right thing by giving additional proteins? I mean, I just leave this thought to all of you to answer.
No, that is very important question and thought-provoking too. Arvind, there are two parts of it. One is the general fat that we can measure, and the other is the muscle triglyceride. Now, intramyocellular triglyceride (IMCL) is something which is more in people who are insulin resistant. But if you're doing enough exercise and you're taking protein to build up your muscle, somehow the intramyocellular triglyceride decreases. Now, once it decreases, there is a greater efficiency of the insulin glucose metabolism in muscle. That barrier of triglyceride is removed. That is one thinking. Is not the end of it. This is just one thinking. So some people think that though muscle is increasing and fat is not decreasing, but muscle fat is decreasing, then it is improving insulin resistance. That is one way of looking at it. But I absolutely agree with you. Unless we change the balance, and that's where I always say in one of my slides, I said that myostatin, which if it decreases, the muscle mass increases and the fat mass decreases, then actually balances the whole system.
Yeah.
That is a myostatin, but the exercise and along with the calorie restriction, we can do the same thing. Calorie alone will deplete muscle, deplete fat. Muscle exercise alone may build up muscle, will not decrease fat. Both together, we can decrease the fat and increase the muscle, as well as the intramyocellular triglyceride will decrease, thus overall increasing the insulin sensitivity. So this should be the proper cascade of things whenever we are doing. And those people who are doing, say, many people are doing intermittent fasting and many people are doing other types of diet, and they're not moving a muscle. They're not exercising at all. Now, that is something which is going to be detrimental ultimately. And there are a couple of studies which show that the lean muscle mass will decrease, the skeletal muscle mass will decrease with intermittent fasting and ketogenic diet if you are not doing exercise at the moment, at the same time. So, Ritesh, your opinion on this?
Yeah, I think very rightly put, sir. So, reducing calories without exercise and without a combination of aerobic and resistance exercise is actually going to lead to muscle loss. So along with caloric restriction, as it is there in intermittent fasting or any kind of diet, exercise is going to be very important. And regarding Dr. Manjunath's paper, I think the whole question of branch chain amino acids, we know we give leucine, we prescribe leucine to patients. At the same time, probably too much of it could be harmful. So we need to find the the right value, we need more data to see how much of protein our patients should be taking and how much is not, how much is detrimental to them, a certain limit which we need to determine. Traditionally, we go by 1 milligram per kg in a person with normal creatinine clearance, but we need to see if we can go above that or should we restrict to lower than that in certain patients. So I think this is what was the purpose of this paper. So thank you, Dr. Sri Manjunath. We can take some of the
Ritesh, there are a couple of more questions here. And I would like to, have opinions of Amit and also Arvind on this regarding the liver. Now there are some papers which say that if you increase protein, actually liver improves, the liver function improves. And I remember, once I was talking to Dr. Sareen, who's heading the Institute of Liver and Biliary Sciences. He says that in a lecture that you increase branch in amino acid in patients with the liver problem. And he says that, the akhrout has plenty of branch in fatty acids. So this is kind of a little ambiguous here. We're looking at improvement of liver function with the branch in amino acid, and we are looking at some deterioration in lipid profile. So Arvind, what is your opinion? If a patient who has a fatty liver of grade 3 proportions and who has raised transaminases, what kind of diet do you think will be working best for him?
Well, I'm only reminded of the old study called the Masala study over here, which was done at the Bay when they took the Indian origin people, and then basically they were the second generation Indians who were there, and then tried to change their diet pattern to the westernized diet pattern and increase their protein. And then the other group continued to eat the Indian food. And what they found was when you made a change in the diet, increase the protein, and this group actually went on to develop diabetes faster than the group which was actually taking the Indian diet. Now the big question is, well, what may work for one particular group of patients? I don't know whether it can be applicable to all our Indians. Ethically, are we going to be very different from others? Because even if you take the average protein content of most of the Indian families, even who eat non-vegetarian food every day, and when we do the calculation, it's not coming to more than 20 grams. And this is in a Muslim population who have non-vegetarian 3-4 times a week. And it's very difficult to increase the protein content of a vegetarian family in India, because the average is only about 10 to 15. Now, how do I take it to 40? Because whatever you try to increase will only end up with indigestion. So you have to give them protein powders. And, I think we are walking on a very tight rope here. What is right, what is wrong, what is practical is something that, we all have to sit together and try it out. Because yes, increasing protein, gastroenterologists are saying, may actually help reduce the liver fat, but will it actually cause diabetes like what we have seen in some of the studies earlier? Well, we don't have an answer at this point of time, but I will take your views any day for that, and would love to sit and listen to what you have to say on that, Anu.
That's very interesting what you just said. And I admire your common sense approach so well. We designed a study which was you can say something like Atkins diet. Now we wanted it to be vegetarian. So it was a vegetarian sort of a counterpart of Atkins diet. And we wanted protein to be increased to 29% of the total energy, 29 to 30%. Atkins diet, it goes more than that, 30, 35, maybe more. And we had so much of trouble doing so. Ultimately, when we designed the whole diet, then ultimately we had to use the protein supplement. And then only we could reach 29%. Remember, the usual protein intake of Indian population is around 12%, which is less. 15% is usually the guidelines say that you should take. And the Western population takes around 17 to 18%. And we designed for 29% and without meat. So that was so difficult. So you're absolutely right. Vegetarian diet, increasing protein to a certain degree, a high degree, is virtually impossible unless you take external supplements. And we used a supplement from a company. Ultimately, the findings came out very well, and liver enzymes improved, although we did not measure liver fat in that particular study. That was done around 6 years back. So we had a good sort of experience with a high protein diet, two diets. One was a meal replacement with protein, and the second was general increase in the protein. Two research studies, both published. So I feel that in Indian population, 12% protein is too less. If we increase the protein not to 29%, but to 17, 18% somehow, then we are going to do good in these people. But yes, as Arvind said, that in a particular population of people, if we go too much overboard, then where will it lead to? We don't know about that. Amit, you have any comments on this?
Sir, I don't have a comment, but it brings me to another question, because I think you are the right person to answer that. So most of the time when we are dealing with diabetes patients, our approach is to reduce the carbohydrate. We don't want to increase the fat content. So the only option that remains is to increase the protein content, because you have to replace the carbohydrate or the fat with the protein only. So how do we take it, and what is the clinical message in this context which you are setting here, sir?
Say you want to reduce carbohydrate from 55 to 45 or 40. If you reduce further, a patient is on a SGLT2 inhibitor, there may be some chances of ketosis. So I would say you go ahead and do moderate the carbohydrate reduction, not a major one or extreme one. Please don't go for that. And so you have 15%. From 55, 40%. So 15% to compensate. Now 15% you can compensate in two ways. That if a person is taking 15% protein, you increase it by 3 or 4%, which is easy to do, to 18 to 19 or 20%. So 5% is compensated here. And 10% you can compensate by increasing fat, but monounsaturated fat. So patient is taking 25% or 26% of fat, which is the usual thing. Then you increase to 30, 34, 45%. Increase quantity of nuts itself, and that itself will actually increase monounsaturated fat. And so you can do that. Fat quality, change the quality, increase the fat, increase protein, decrease carbohydrate. I think that would be the best combination, because intake of monounsaturated fat in our population is less, and it is going to be extremely beneficial in terms of as far as liver is concerned, as far as anything is concerned, insulin sensitivity is concerned. So a good dietitian should be able to manage this particular thing. This is not difficult to manage. And this is what we do in our clinical practice. Ritesh, any comments here?
Yeah, I think you have very rightly pointed out. That's what we do in our practice, that we increase MUFA and we reduce carbohydrate, but not majorly. I think that's how we can. And of course, when you reduce carbohydrates, we also need to understand we're also reducing calories. So your total calories will also come down. The patient might be taking 2,000 calories, you bring it down to 1,600 or 1,500. So to some extent, your problem of increase of not being able to increase protein or something that can be taken care of, because protein content, so proportionately the carbs will come down anyway and protein will go up because the calories are also going down.
Amit, another thing about reduction of carbohydrate, we have a problem of postprandial hyperglycemia. So if you reduce carbohydrate by 10% or so, some amount is taken care of, but still some amount remains. So what we have done is, in a recently designed study, which we have sent for publication, we use CGMS and a pre-meal load of almonds. Pre-meal load, three meals and 3 pre-meal load, 15 minutes before the meal, we gave a load of almonds, maybe a ek muthi bhar ke kareeb, that kind of. Now this, though calories slightly increase, if you take pre-meal and meal is concerned, the post-meal blood sugar dropped, clearly dropped on CGMS, significantly dropped. And the over period of time, appetite decreased. And so overall calories also decreased. So ultimately, over 3 months, which is the second paper. So there is a acute study paper which we have sent for publication, and there is a chronic study paper which are yet to be published. We have seen tremendous improvement in everything. Now, only thing is, patient often forget कि meal से पहले लेना है, भाई 15 मिनट पहले लेना है, जैसे दवा को भी forget करते हैं. But this is a good strategy, and we are going to recommend this strategy as to decrease the post meal blood glucose levels. It is 70% as effective as acarbose. We have checked everything, and we have compared and made a table of postprandial regulator versus the pre-meal load of almonds as a postprandial regulator. So this is going to be very interesting. We are working on it, and we will soon send it for publication. Once it's published, I'll share with you. So Arvind, if there's not any more comments, we are nearing the time.
I think we can, we 5 minutes ahead of time. I think Dr. Otis has already joined in, and we have a Diabetes India ADA symposia which is starting, and I would request all of you to actually stay back, and then I think Amit and Jimit can now take over, and then you can start the next symposia. Thank you so very much, Anup, for all the wise work.
Thanks everybody. Thanks everybody, and thank you for joining. Thank you, thanks Amit.
And always a learning curve.
Yes, sir.
Thank you.
Thank you.
Yeah, Amit, you can take over the next session and then start off.
Yes, Dr. Jimit, would you like to initiate the next session? Yes.
Yes, definitely. Let me thank you, the chairpersons, for the last session. Thank you, Anup Mishra sir, and thank you, Dr. Ritesh Gupta sir, for the wonderful handling of this editor's choice session for our journal Diabetic and Metabolic Syndrome. Thank you. And I thank all the speakers, 5 speakers who have joined here and presented their winning papers. Thank you, everyone. So we are on time, and we'll be moving forward toward our next session. So next session is going to be Diabetes India and American Diabetes Association Symposium. To chair this session, I would like to invite none other than, we all know him, Dr. S.R. Arvind sir, President for Diabetes India. He is the Director and Chief Diabetologist at Diakon Hospital, Bangalore. And we also like to invite Dr. Amit Gupta from Delhi. Over to you. Both of you don't require any introduction, and I would like to invite you to proceed for this ADA symposium.
Yes. Thank you, Dr. Jimit, and welcome, Dr. Otis. It is really a proud moment for Diabetes India, as we have this very special session that is Diabetes India and ADA Symposium. I have the dual responsibility that as a Joint Secretary of Diabetes India and as a member of the Membership Advisory Group of ADA and member of the Public Health and Epidemiology Interest Group of the ADA. So I am on both the sides, the ADA as well as the Diabetes India. So it is really a very proud moment for me. And I would like to introduce Dr. Otis here, who is currently the President of the Healthcare and Education for the American Diabetes Association. And he is retired professor of pharmacy with over 25 of experience, vast academic experience. And he has spent almost 35 years in various practice settings, including hospital, community, as well as ambulatory pharmacy practices. And currently he is serving as the Director of the Pharmacy Services for the Neighborhood Medical Services, a federally qualified health center. He is a board certified advanced diabetes management as well as a certified diabetes care and education specialist. And he is also a member of Kappa Alpha Psi fraternity, Sigma Phi Phi fraternity, and serves as the director of the Prince Hall Shrines National Community Health Initiative. So Dr. Otis, along with the President of Diabetes India, Dr. S.R. Arvind, we welcome you for this very prestigious Diabetes India ADA Symposium.
I think just a word, like as Amit was saying, Dr. Otis, this is Dr. Arvind. Even I have the dual responsibility because the ADA 2 years back also had the Diabetes India Symposia, and this is the first time that the ADA welcomed Diabetes India, and we've always been associated, and I personally do ADA primer meetings in India for the last 8 years. And what's interesting is this first topic has always fascinated me because 96% of people with diabetes in India pay out of their pocket. Insurance covers only 4% of the people in India. I'm eagerly going to listen to you. And I'm very happy to know what you're going to say. And we can always come back on the question and answer session. And after that, two of my good friends are also going to speak. I'm sure we are going to have a great time. I think the virtual platform is all yours, Dr. Otis.
Thank you so much. This is truly an honor to participate in such a grand event. It's definitely one of the high points in my professional career. Allow me to share my screen here, and we will start it here. So just to give you some background here, if I can get this out of the way. Okay, so just to give you some background, I am a pharmacist, and I actually been working at this particular center for over 20 years as a faculty member, and now hired as a full-time person in pharmacy management. So first of all, I disclosures, I am speaking for Novo Nordisk, just to get that out of the way. But today, what I want to do is share with you some of the challenges that we face as a very qualified community health center. Talk a little bit about our current patient population that we serve, the unique patient population. Also describe the organizational framework by which we attempt to provide a very needed diabetes education and management service, and also list some common barriers and challenges that a center such as ours face. So if we look at the overall landscape of diabetes in the state of Florida, we see that about 13% of the population, has diabetes. This is actually higher than the national rate of about 11.1%. So, and if you would go and look at the diabetes map, the state of Florida, you will see that the highest concentration of diabetes is located in the Central Panhandle area of Florida, which is actually around this area. And you'll find that Tallahassee is located in the Big Bend. This is the Big Bend right here. And so we're surrounded by very rural counties. And so you'll see later on my presentation, one of our sites is actually located in that site. What's amazing is that 5.8 million Floridians live with prediabetes. And so we know what that is going to be like a tsunami, coming at us in a few years if we cannot, implement the necessary lifestyle interventions that have been proven to kind of slow down the progression of the development of the disease. And it is estimated that every year, over 100,000 people in Florida are diagnosed with diabetes. So let's talk a little bit about Neighborhood Medical Center, where it's a very qualified community health center. And these centers were created many years ago by the federal government. And they're actually administered by HRSA, which actually governs these centers. And they're actually designed to provide care for uninsured people living in counties throughout the United States. Our center is truly what we refer to as a safety net. We include services such as primary care, both chronic disease management, mental health, dental care. 3 of our facilities actually have dental seats there. We have specialty care, OBGYN, we have orthopedics, pediatrics, psychiatry. And those services are offered on a limited basis, but they are consultant providers that work for us during those hours. And I always say, like, the glue that holds everything together is the case management services, which is critical for the types of patients that we manage. We have 5 locations throughout Leon and Gaston. As mentioned earlier, Gaston County is a rural county located about 10, 15 miles from Tallahassee. And we have a lot of patients who go back and forth from Tallahassee to Gaston County. So we put a site there to accommodate those patients. So when we look at our patient population, most of our patients are between 18 and 64. Most are African American. However, we have a growing Hispanic population as well as non-Hispanic white population. So, the services, everybody needs help. Poverty, uninsured does not escape, race or ethnicity. When we look at the income, over 98% of our patients fall below the 200% of the federal poverty level. So these patients are, really, really poor. Most of them are uninsured, and those who are, they mainly are Medicaid. Now, if you may not know, Florida is one of the few states in the United States that did not expand Medicaid, which would provide a critical service to patients, working poor who need primary care. So our Medicaid patients are either very old, they're disabled, or they're women of childbearing age. We have a small percentage of Medicare patients and an even smaller percentage of patients who are on other commercial insurances. A significant number, 73% of our patients live in public housing, and 17%, which is huge, of our patients are homeless. I had a patient yesterday who was family of 5, and they were just put out. They're looking for housing, and she's trying to manage her diabetes. So it is really critical. These patients still actually experience a lot of challenges. So about 18% of our patient population have diagnosed with diabetes. Now, these numbers come from the information that is reported annually to HRSA. So this is like the 2019-2020 report, and we all know what was going on in 2019 2020. And you can see that the 18% is much higher than the national rate of 11%, but the rate of hypertension is lower. And I think this is primarily because patients with diabetes, they had to come to the clinic. I mean, we could see them, a lot of them, sought assistance, even if it was via telehealth, as opposed to, hypertension. And so I'm sure, these numbers will, as things normalize, we'll be able to get a better indication of what our true diabetes population, as well as hypertensive population. All of these numbers could be actually changed in a couple of years. So when we talk about the barriers that we face, the social determinants of health remain a constant challenge. And so when we think about the patients, I described the economic status of our patients. If you think about economic stability, being able to afford, healthy food, being able to pay for your medications, being able to take care of other necessities of life, those are challenges. Actually, to find a full-time, find a job. And even though there's a lot of work out there, a lot of our patients still remain unemployed. When we look at the built environment, our centers, actually 3 of our centers are located in what we refer to as food deserts. So, the access to healthy foods and vegetables is limited. But on the other hand, they lie right in the middle of what we refer to as food swamps. So there are stores on the corner that sell high caloric dense products, malt liquors and things of that nature. And so, which contribute to the diabetes epidemic that we see. Healthcare and healthcare. So, that goes directly with the economic piece there, because even we have patients who have insurance, but their copays are so high that they really don't benefit from having, the insurance and so forth. So again, we like most patients that look like our patients are consistent with their demographics. These social determinants of health, which really fuel the health disparities that we see in this country, are real, and we deal with them every day. So, our model or our approach really is consistent with that of the chronic care model, in which we have a collaborative practice approach. It's multidisciplinary. And unlike a lot of programs, it's pharmacy-led. I'm actually the person that kind of coordinates this whole effort. And, before COVID came in place, we actually found it kind of difficult to collaborate a lot of times. But since now we're telehealth is here to stay, oftentimes we can collaborate, right through the telehealth, using telehealth technologies. But all of these essential components are critical in terms of the patients that we deal with. Mental health counselors, we did a small survey using the Zung survey for self-described symptoms of depression. And we found that almost 30% of our patients demonstrated mild to moderate symptoms of depression. So we know how, chronic disease management, self-care management is impacted by, mental health. And so it's important to have these counselors available. So if we encounter patients such as that, we can get them into to see those counselors. Our case management coordinators are very important, because oftentimes these patients, they are intimidated about the system. They have to have someone who's going to advocate for them and negotiate them through the healthcare maze. Very important. I'm a certified diabetes care and education specialist, so I kind of serve two roles. And our providers are, we have 3 physicians and the rest of about 8 nurse practitioners who staff who provide service to our patients. One of the things we did a few years ago, because we wanted to bring our nurse practitioners up to speed in terms of, it's kind of standardizing the approach when they get a patient with diabetes, we began to do team visits with patients. And so I was able to work with them. And now, we're seeing more and more patients that come to me, they're already on an SGLT2 blocker, or they're already been started on a GLP-1 receptor agonist, which shows that those team visits and collaborative visits actually pay it off. So when we look at our program, we try to provide a basic diabetes education experience for all our patients with diabetes. However, if the A1Cs are greater than 9, then we bring them into the disease management piece. And so the disease management piece is through a collaborative practice arrangement I have with providers there. I actually see these patients between their primary care visits so that we can make sure that we don't get lost in inertia, and that we are routinely, regularly monitoring their progress and making changes to therapy, sooner than later. Our initial visit is about a 60-minute visit that does the traditional things like looking at medical history, laboratory results. We do several assessments, a diabetes self-management questionnaire, which kind of gives us an idea of where they are with self-management skills, but also a diabetes distress scale, which actually gives an idea of, how, what impact the disease have on these patients. It's already a burden, being poor, and concerned about, going from day to day. But to add diabetes on top of it, you would expect patients to have some level of distress there. We assess educational needs, and we identify management priorities. And I mentioned earlier, sometimes patients come in and for the initial visit, and they're not in a state in terms of mental health. Well, we can really help them with disease management. And so we refer them to mental health right away, and then they come back. We go through educational sessions as as needed. If they need specialty care, and that could be anywhere from needing to go to podiatry or dietitians, if possible, if they have insurance, we send them to a dietitian. And then we document those encounters through electronic medical record system. And I'll talk about that a little later because we have electronic medical records, but it's very difficult to pull data that you want to look at outcome data, and so that's one of the limitations of our system. Our management plan, we at one point we used to do team visits or group visits. Now we do all individual encounters. The goals are individualized, the cookie cutter thrown out. We look at individual therapeutic interventions. There are patients who don't tolerate certain medications. We have to make sure, or they fear the needle. So, we make sure that the patients feel as if they are the captains in the ship and we're just the navigators. And we try to shape a therapeutic intervention that's based on what their comorbidities are, as well as their needs and their desires. We talk about individual lifestyle interventions. As I mentioned earlier, our patients, this is a working poor. Many times these patients are working 2 part-time jobs and make a full-time job. So when you think about, exercising and things like that, you really have to come up with creative, interventions on how they can get that in. Or if you think about other interventions, such as buying healthy food. It's easy to say, buy healthy food, but their reality is, beginning of the month, they may start off eating healthy, but by the end of the month, they're eating more rice and beans or more high carb based, foods. And then self-monitoring blood glucose, which is the one that nobody wants to do. And I understand that because glucose monitoring, it's uncomfortable to stick your finger. And there is a serious disparity between who gets to use continuous glucose monitors and who don't. Even our patients on insurance, Medicaid and Medicare, even though they say they cover continuous glucose monitoring, it is very, very difficult to get it. And so that creates a barrier. So when we look at how we approach our, the pharmacological therapy is really a significant part of the management plan. And so therefore, we have to come up with creative ways to get access to the kind of medications that the newer medications. And so through the federal 340B program, we're able to get certain insulin product analogs for literally pennies. I mean, pennies, less than $1 per month supply. And so which is huge. The state of Florida also has an insulin distribution program, but the formulary is outdated. They are still, using regular insulin and, human insulin. And we know that the pharmacokinetic profiles of those insulins are inferior to the analogs. And so we're actually working with the state trying to advocate for that formulary to be updated. And then a huge piece is our patient assistance program. And this is when we can actually send out to the drug manufacturers, and they will provide our patients with a 3-month supply of medications per year. And we just renew that every year. But this could not be done without the help of our case management crew. They actually complete the applications, they follow up with the patients and so forth. And they're able to do this through a service called MedData, which actually catalogs all of the companies that provide patient assistance. So we can go in and rapidly identify whether or not the drug is covered. And once it is, we get the necessary paperwork submitted and patients get access to the medications. So when we have some selected outcome data, and believe me, I had to generate this the old-fashioned way. We have went through we have about 150 charts that we're a patient that we're dealing with. And so I took a random of 54 of those charts. And just to get some basic outcome information. So when patients enter our program, their average A1C is 9.61, but 52% of them come in with A1Cs greater than 9%. And so oftentimes, it's not uncommon for us to get patients who we can't even measure the A1C. So they haven't been on medication for many years, just have not been managed. But what we did find is that within a 3 to 6 month period, we saw a mean change in terms of A1C, in terms of a positive change, in terms of about 1 almost 2%, which, at least gives us an idea that, what we're doing does work, considering the challenges that we deal with on a regular basis. So when we think about those challenges, I mentioned earlier about the socioeconomic challenges, the language barriers. We have a limited number of Spanish-speaking providers there. We have even fewer staff members, so it's very difficult in terms of Spanish-speaking. But we also have people from West Africa. We have people from other, languages or cultures. So it's not necessarily the language, maybe it's cultural, not understanding, what the foods that they eat and so forth. So that's a challenge. And so it really you have to get up and educate and try to help create a lifestyle intervention related to nutrition that's culturally sound and something that they can deal with. When we look at programmatic space, we're actually in the process of opening up, renovating a new building just purchased. That's going to add valuable space. It's never enough time to do what you need to do. And we can always use more money in terms of funding. But a big piece there is that, we have no registered dietitian on staff. And so, I'm a disease manager. I'm not a dietitian. And even though I do, I do what I can, but it's not like the patients having access to a registered dietitian. And so we're really working to make that happen. The other piece was COVID. So I've been working from doing telehealth for the last 2 years. And so, as a result, I'm not in the clinic. And so you don't get a chance to see the patient face to face. We had a lot of patients that fell off the grid, particularly our older patients. Even they had struggles trying to deal with the telehealth technology. Oftentimes we resulted in using telephone. The other piece is that you don't get a chance to do the assessments, the A1Cs and so forth. So hopefully now we have a lot of this COVID behind us, and we'll begin to bring patients in and get the kind of assessments that we need. So, despite the challenges our patients face, despite, all the that's dealing with the disease, dealing with life and so forth, the services we brought, they generally are very satisfied. And, it's very important that we know how our patients feel, because, we try to treat each one of them as if they're part of the family. I don't think you can get it right if you don't approach it from that angle. And then my final slide is something that I always share when I give presentations is people, or in this case, our patients, they don't care about how much we know until they know how much you care. And so that was a quote by Theodore Roosevelt. And at that end, I will end the presentation. Thank you.
Thank you, Dr. Otis. Dr. Arvind, sir, your...
No, I think that was a fascinating lectures, and I was just listening exactly to what he was trying to say, especially about the DSME. Dr. Otis, I have only one question. Basically, we have been trying to do the same thing, but at individual levels, not at the level of the government. The biggest problem is we know knowledge helps through education, and education is hand-holding, and it has to be for life, it has to be permanent, and it changes from time to time. Now, one of the biggest barriers that I see as a practicing physician is knowledge and the final effect. There is a bridge. What is it? Is it the attitude of that patient? How do you actually see the success of your DSME? Yes, you showed me the graph, it said satisfied, okay, etc. But in terms of parameters, what do you measure and how do you make it sustainable?
Well, one of the things is, first of all, let me just say this. A lot of our patients are transient. We see them and we don't. They come in, we see them for like 8 months straight, and then they like drop off the grid. But one of the things that I think that has made us successful is the fact that you do have to hold their hand. You have to be a preacher. You have to be a coach. You have to be a motivator. You have to be a comforter, and really, and not only that, but the frequent visits. Because I can see patients at a more frequent, at a higher frequency than the primary care providers, I'm able to identify issues. For instance, a patient who is insured, and we write a prescription for Trulicity, right? Normally, the provider would not see that patient for 3 months, okay? Well, I'm gonna see that patient maybe in a month, maybe 3 weeks. The patient didn't pick the prescription up because the copay was $100, right? So the issue here is that you try to identify those issues before. And so I think that's one of the things that has helped us in terms of is the frequency of the visits. And, I do case management. I mean, it's not unusual for me to get on the phone and call the insurance company. I had a patient who was type 1, needed the CGM and had Medicaid, but could not get the CGM. And so it took me almost 2 hours one afternoon to finally complete a prior authorization to get this patient approved for CGM. Now we have a better idea of what the glucose is running throughout the day, and we're better able to manage that patient. So it's not a cookie cutter. It's not something that objectively I guess I can lay out for you, but I do know it takes a team to do it, and it takes a team to do it. And I think the important thing is that we listen to the patients. And the days I always tell my patients that, look, you are flying this plane. I am just a navigator telling you, hey, look, there's a mountain here. You need to go to the left, okay? I can't turn the plane. So when you go home, you have to make decisions, right? And so you got to think about what is going to be the shared value you're going to experience by making these good decisions, and so forth. And that's kind of how my approach, if that answers your question.
I think that's a wonderful answer. You can tell the patient, I can show you the path, I can show you how to walk, but I can't walk for you.
Exactly.
Yeah, I
exactly.
Think, very well said. And one last question, before we allow you to go. What I've always seen or found is the attitude of the patient, because eating gives them happiness, shopping gives them happiness, playing sports gives them happiness, laziness gives a lot of happiness. Getting back health is something that people don't feel. And most say that, okay, getting back health is something not felt by me, so it doesn't give me happiness. Now, how do you address a question like that if it comes to you?
You have to identify what's important to them in their lives. Okay, and so I like to get to know my patients. Who's in their life? So I always ask them, I say, you have kids, you got grandkids. How many grandkids do you have? Now, I know you want to be there to that wedding when you walk it down. You have to find, because it's just like diabetes, man. It does not hurt, right? So it don't hurt. So there's no motivation to do the right thing, to go in and seek care. And the same thing is that we have to help show them a vision of what the healthy choices are going to be. We have to help identify what those benefits are. And they may not be able to appreciate them at the time. Because you have to understand the patients that we're dealing with, they have a lot of other things that they're dealing with. Like I had a patient yesterday who she has an adult daughter who had a CVA and is disabled. She has 3 kids. The mother is trying to take care of the adult daughter and the 3 kids, and they were just, the people who bought their trailer just went up on the rent and everybody's moving out. They're homeless. So, you know, oftentimes it's, you know, it's hard to overcome all of that, right? You know, and try to paint a rosy picture. You just take it one day at a time. That's, you know, one visit at a time.
I think you're more of a counselor than a pharmacist. You're a great speaker. And thank you so very much, Dr. Otis. And with that, I request Amit to start the next lecture. I see Dr. Des Shorts has not joined in. I did send him a message from Goa. He hasn't joined in because that's a live lecture. We have Dr. Guillermo's lecture, which is recorded. I think we can start the second lecture and then try to see if Dr. Des joins later. Thank you so very much, Dr. Otis. And that was a great lecture that I have heard for a long time.
Thank you.
Thank you, Dr. Otis.
Thank you.
Yes, I will request RX team to show the introductory slide of the Dr. Guillermo. So let me just introduce Dr. Guillermo, and it is really a matter of honor and pride for Diabetes India to have him as a esteemed speaker here. Dr. Guillermo is Professor of Medicine at Emory University, and he is the Editor-in-Chief of the BMJ Diabetes Research and Care and the ADA reference book. He is a clinician par excellence scientist with extensive experience in conducting various clinical and population research in diabetes. He has a special interest include mechanism for beta cell dysfunction in African American with diabetes and prevention of diabetes complications and the management of the inpatient hyperglycemia and diabetic ketoacidosis. He has served as a director of the Grady Hospital Research Unit for the past 7 years in this position, and he supervises the clinical operation and supports researchers in conducting clinical research. He is also the chairman of the Endocrine Society Guideline Committee on Diabetes. So it is a proud moment for all of us, and we welcome Dr. Guillermo Emperes, and we request him to deliver his talk.
Guillermo Pierres. I'm a professor of medicine at Emory University School of Medicine in Atlanta, Georgia. And I'm the president for medicine and science for the American Diabetes Association. And it's a true honor to talk to you about glycemic management in patients with chronic kidney disease. So the agenda for today is to discuss epidemiology of kidney disease and diabetes. How should we monitor people with diabetes for the development of chronic kidney disease? Talk a little bit about the pathophysiology, but more importantly, we're going to concentrate how we should manage patients with diabetic kidney disease. It's such an important and hot topic these days in diabetes world. So in the United States, there are about 37 million people, or 15% of the US adult population, are estimated to have chronic kidney disease. 48% of those with severely reduced kidney function, unfortunately, are not aware of having diabetic kidney disease. 1 out of 3 adults with diabetes, so about 30 to 40% of adults, will develop chronic kidney disease. And to the right of this slide is what are the causes of CKD. Diabetes account for 44%, hypertension about 29%, and we know that about 70 to 75% of patients with type 2 diabetes will develop hypertension during their lifetime. So these two accounts, with about 20% are glomerulonephritis, other causes like obstructions, and 7% are unknown. So again, 40% of patients with type 2 diabetes will develop chronic kidney disease. When we talk about chronic kidney disease, we need to talk about how we diagnose them. And they can be diagnosed in 2 ways. In one way, you get the glomerular filtration rate, the formula calculated by creatinine in serum, and we call chronic kidney disease when the GFR is less than 60 ml per minute. The other way that we think is much more important or equally important is the presence of albuminuria. The urinary albumin creatinine ratio is a formula that takes in consideration the urinary albumin and urinary creatinine. Less than 30 is normal. From 30 to 299 is already microalbuminuria, and macroalbuminuria is the urinary albumin creatinine ratio more than 300. So if somebody has proteinuria, have elevated UACR, how do you know if this really due to diabetes or maybe other causes of hypertension? Well, first, take a good history. If the patient have type 1 diabetes, for example, more than 10 years, it's very, very likely this is CKD, diabetic kidney disease. If the patient has already retinopathy or other microvascular complications, so it's likely that proteinuria is due to chronic to diabetes, so diabetic kidney disease. The most important thing, and hope this is a message to take home, we want to do both albuminuria and also calculate glomerular filtration rate. And this is something that was published by the group of kidney disease and diabetes, the KidDIGO. And what we have here is that we divide them in levels of albuminuria. Level 1 or stage 1 is normal with the UACR less than 30, moderate increase from 30 to 300, and severely increase more than 300. The most important thing is that both A2 and A3 are predictors of progressive diabetic kidney disease and are associated with increased cardiovascular mortality. Here to the left are the levels of GFR. A normal GFR or glomerular filtration rate is more than 90, mild decrease 60 to 90, moderate 45 to 59, moderate to severe. So these are 3A and 3B. 3B is 30 to 45, and severe decrease is less than 30. When we have a GFR less than 15, this is a patient that usually goes on dialysis. The most important thing is that the increase in cardiovascular complications goes with both of them. The presence of albuminuria and glomerular filtration rate. I love this slide, although it has already a few years, but what it does is put together the natural history of how the diabetic kidney disease progresses. So you shouldn't have albumin in the urine, that's right. So more than 30, here you go. And when you start going up in the albumin in the urine, you're going to see that glomerular filtration rate start decreasing. Remember that about 50% of patients with type 1 and many patients with type 2 at the beginning are hyperfiltration. They're more than 90. But when the albuminuria past 300 is when you see this completely decline, and when the GFR start coming down, in 2 or 5 years, the patient have a creatinine of 2, go to 5, the patient is on dialysis. So why do we care? We want to diagnose this early. And to diagnose this early cannot be with GFR. Look at here the years duration of diabetes. We want to look at the albuminuria because both are associated with poor prognosis. This is a data from the United Kingdom prospective diabetes studies. And it's the progression with albuminuria and the rate of death in patients with diabetes. If you have no nephropathy, so you have UACR less than 30 and normal GFR more than 60, mortality is higher compared to non-diabetic patients. But look what happened with the patient developed microalbuminuria. The annual death rate is double. If you have albuminuria, so more than 300, is more than threefold increase from those, the annual death rate compared to those with no nephropathy. And it happened to be you're on dialysis, the death rate is 10 times to 15 times higher. So we want to diagnose early because now we have medications that would change the way of progression of diabetic kidney disease. I already mentioned this, but this is a graphic point. So if you have here, you have no nephropathy, in blue is mortality, in orange is all-cause mortality. And both diabetes and chronic kidney disease are independent risk factors for mortality. If you don't have mortality, this is just diabetes here to the left. The cardiovascular mortality is the #1 cause in patients with diabetes, And of course, all-cause mortality goes up. Look what happens if somebody has chronic kidney disease. So GFR less than 60 and presence of albuminuria, mortality is even higher than in patients with diabetes. And if you have diabetes and chronic kidney disease, mortality goes sky high. Almost 20% of patients will die of cardiovascular mortality, and this is over a period of 10 years. And chronic kidney disease, about 30%. So patients with type 2 diabetes and CKD have 2 or 3 times increased risk of acute myocardial infarction, and believe it or not, 3 to 5 times the risk of hospitalization for heart failure. And of course, heart failure has a poor prognosis long-term. So proteinuria predicts strokes and coronary heart disease events. I just wanted to highlight here that you don't have to have massive proteinuria. This is just less than 150, more than 300. Increased risk of cardiovascular mortality, increased risk of strokes, and coronary heart disease events. More data from epidemiological study from the United States, what is called NHANES, or the National Health and Nutrition Examination Surveys, and this goes from 1988 to 2016. And what you're looking at is different stages of CKD. Stage 1, more than 60, 45 to 60, 30 to 60, less than 30, and you see the mortality. Patients who have CKD or macroalbuminuria to the right are going to have an increased rate of cardiovascular mortality. And I love this slide because putting representation that people with CKD or diabetic kidney disease are 6 times more likely to die of cardiovascular disease than to advance end-stage renal disease and dialysis. We can maintain people on dialysis for many years, that's right. But unfortunately, mortality in patients with diabetes who are on dialysis is quite high. More than 50% of patients will die within 5 years, 75% after 10 years of dialysis. And the main reason why people with end-stage kidney disease and dialysis die is not because of renal disease. We can dialyze. Of course, it's cardiovascular mortality. And this is an interesting epidemiological study published a few years ago now, that is the majority of mortality in patients with diabetes. You have diabetes, already have cardiovascular, have chronic kidney disease. So no kidney disease and mortality in diabetes. If you have an albuminuria, it's 4-fold increase. If you have impaired GFR, it's 5-fold, 6-fold increase. And look what happened if somebody has albuminuria, so more than 300 urinary albumin creatinine ratio, and a GFR, low GFR less than 60. The mortality is extremely high in these patients. So this is why the American Diabetes Association on the standard of medical care in 2022 recommends, and the same thing the Kidney International, that you have to measure at least once a year urinary albumin with spot urinary albumin creatinine ratio. So not just albumin, but UACR, urinary albumin creatinine ratio, and also measure a blood test at least once a year to measure the glomerular filtration rate. In patients with type 1, newly diagnosed, you can wait for 3 to 5 years if you're young. Then in patients with type 2, we want to do it shortly after the diagnosis. Why? Because we don't know when type 2 patients start having diabetes. It can be several years. So once you have type 2 patient, you immediately do UACR, you do a GFR, and then you repeat this test every year. Patients with diabetes who have a urinary albumin creatinine ratio more than 300, so macroalbuminuria, or a GFR less than 60, should be monitored twice a year, because we want to see the progression. We want to intervene early on to decrease the risk of dialysis and cardiovascular mortality. So this is new data that I think has been highlighted by the ADA and the Kidney International KDIGO. And what you have in here that most people do not know they have CKD. They have diabetes. This is data on 5,000 patients. Looking at electronic medical records, 99% of those are stage 1, 95% stage 2, 82% of even stage 3. So this is GFR less than 45. Do not know they have the disease because it's asymptomatic. Even half of the patients with GFR less than 50, less than 30, don't know they have the disease. So we need to screen patients. And we need to screen patients, as I mentioned, in 2 ways. We want to measure urinary albumin creatinine ratio. So a single spot urine in the morning, and you're going to get a GFR. Most people right now are measuring, are diagnosed with GFR. We want to increase this number because 90% of these patients never do urinary albumin creatinine ratio. So message to take home, measure both urinary albumin creatinine ratio and measure GFR to diagnose early on, because like we will see in the next few minutes, we have several interventions that have shown to be very effective in preventing progression of diabetic kidney disease. So, CKD progression, how can we alter that? Well, there are several ways. I'm a diabetes person, so I always think about glycemic control. Now we have blood pressure control is equally or more important than glycemic control at short term. We have medication that help us, and this way you have renin-angiotensin blockers, and you have the ACE inhibitors and the angiotensin receptor blockers. You have the SGLT2s and the GLP-1 that we're going to discuss them. And of course, if these patients are going to die of cardiovascular disease, we need to treat dyslipidemia, and of course, trying to decrease the LDL to the levels according to the risk factors. So let's talk about medications. So glycemic control. This is data that come from the diabetes control complication trial. As you may remember, these are a study on type 1 diabetes that followed this patient for 6.5 years. And you see that tight glycemic control or intensive glycemic control with hemoglobin A1C less than 7 compares to a little over 8, 8.5 to 9 for primary prevention. So patients who do not have proteinuria to develop proteinuria was reduced by 60%. And it also not only primary prevention, those patients who already have established nephropathy or diabetic kidney disease, you slow down the progression. So in type 1 diabetes, improvement of glycemic control, getting the hemoglobin A1C less than 7 was effective in primary and secondary prevention. That study was 6.5 years. And now we have been followed these patients with long-term up to 30 years, and we have what we call a legacy effect. Improving glycemic control during the first years decreased nephropathy, but progression after the study was closed, you still have a beneficial effect. There is a legacy effect that intensive glycemic control during the first few years of study like DCCT have a long-term effect in preventing progression of diabetic kidney disease. That was type 1. What about type 2 diabetes? And we have to go back to the United Kingdom Prospective Diabetes Studies, or UKPDS. And this study shows that improvement of glycemic control with a hemoglobin A1C less than 7 reduced microvascular complication in about 30%. And look at albuminuria. You can prevent up to 33%. And this is a study with just 6 years. And the same thing have a legacy effect when this patient has been followed for a long periods of time. So if we want to summarize the importance of glycemic control in the progression of diabetic kidney disease, we can summarize in the following way. There is substantial and enduring reduction in microvascular complications. You can prevent by 50 to 75% nephropathy if you decrease hemoglobin A1C less than 7 versus 9% in patients with type 1 diabetes. And in patients with type 2 diabetes, you see a 25% reduction if you achieve control. And these effects are long duration. There is the legacy effects at long term. So those studies were done in the 80s and the 90s. What about recent data? And we have the ADVANCE trial that was done mainly in Australia and New Zealand, Canada, some places in the United States, and they took over 10,000 patients, mostly treated with sulfonylurea agents. And they were randomized to 6.5 to 7.3. And they saw a reduction of UACR by 9 to 10% and progression from micro to macroalbuminuria reduced by 30%. Impressive evidence. The ACCORD trial, over 10,000 patients in the United States, they were randomized to less than 6.5% or less than, and they got 6.3 versus 7.6. And similarly, but the advanced trial, you have a significant reduction in urinary albumin creatinine ratio, and more importantly, progression from micro to macro albuminuria. And in the third trial that is called the VADT, the Veteran Administration Diabetes Trial in type 2 diabetes, a good glycemic control less than 7 versus 8.4, reduced by 30% urinary albumin creatinine ratio and 37% progression of the disease. So glycemic control is quite important. All trials, type 1, type 2, new trials, all have shown the same beneficial effects. I mentioned to you that treatment of hypertension is as important or even more important in the progression of vascular complications. And here you have in the UK PDS a lower blood pressure, less than 140 is associated with a 40% reduction of doubling of serum creatinine, development of dialysis, the need for dialysis, or cardiovascular death. Blood pressure is quite effective in preventing progression of kidney disease. So the American Diabetes Association will say, for people who have very little cardiovascular risk factors, just keep the blood pressure less than 140 over 90. But if you have proteinuria, albuminuria, if you have cardiovascular risk factors, the blood pressure should be less than 130 over 80 millimeters of mercury. And there are several studies now that have shown that with ACE inhibitors like ramipril versus amlodipine and calcium channel blocker, you decrease the risk of proteinuria, kidney failure significantly. So ACE inhibitors or angiotensin receptor blockers shown to have a beneficial effect compared to other type of therapy. And that is why we recommend that everybody with type 2 or type 1 diabetes who already have albuminuria should be placed on an ACE inhibitor or an angiotensin receptor blocker. And that's the classic studies now published in the New England Journal of Medicine 20 years ago, that if you compare an angiotensin receptor blocker, losartan, compared to placebo in the Retinal trial, you decrease the progression to doubling of serum creatinine, development of end-stage kidney disease, the need for dialysis or death by 16%. And the IDNT trial that compare irbesartan, again, an angiotensin receptor versus amlodipine, you have this very nice reduction in death, on death, by 20%. So impressive data. But when you look at this data, you're going to see that there is substantial residual risk. Yeah, you decrease by 20%, but there is a significant residual risk. So now we have medications that together with ACE inhibitor therapy can prevent kidney damage. Let's review these medications. So you know that there are 12 different groups of anti-diabetic therapies with different mechanism of action. The question is, how do they behave on the management of patients with diabetic kidney disease? So let's review each one of these medication groups. Starting with metformin, the #1 anti-diabetic agents used all over the world. It can be used until the glomerular filtration rate is less than 30, you have to stop. It's contraindicated if the GFR is less than 30. But if the GFR is between 30 to 45, so stage 3B, you shouldn't do full dose of 2 grams a day. You should limit the dose to 1 gram of 500 milligrams twice a day. In patients with heart failure, also, there is a need for stop the metformin in these patients because both heart failure and impaired kidney function with GFR less than 30 may increase the risk of lactic acidosis, although it's a rare complication. But what about metformin in the long-term prevention of cardiovascular or renal disease? And we don't have that evidence. So we know that improvement of glycemic control long-term prevent diabetic kidney disease, but in short-term, established metformin doesn't really prevent cardiovascular or renal protection because we don't have randomized control trials, and I don't think they're coming in the near future. So what about insulin secretagogues? And here you have the Carolina trial. This is glimepiride versus linagliptin. And what happened is that you see a significant increased risk of hypoglycemia. And that's the reason why the sulfonylurea used around the world has decreased significantly. They are very effective in bringing the blood glucose down. They're cheap, they work fast. Unfortunately, sulfonylurea does not prevent cardiovascular complications, and sulfonylurea does not prevent kidney progression. So not metformin, not sulfonylureas. What about DPP-4? And here you have, they're effective in patients with diabetic kidney disease, decreased hemoglobin A1C about 0.6, 0.8%, all of them. But unfortunately, you have here a urinary albumin creatinine ratio, not significant difference. So DPP-4 has been tested, all of them, but none of them has shown to prevent the progression of diabetic kidney disease. Unfortunately, we don't have that evidence. And we should keep in mind that you have to adjust doses according to kidney function. That's right. You have mild, moderate, and severe renal insufficiency. And the only one of the DPP-4 that you can use even in dialysis is linagliptin. For vildagliptin that is used all over the world except in the United States, you, instead of giving twice a day, you just give once a day, and you have to adjust the dose. I mean, I like DPP-4 in patients with impaired kidney function, but you have to keep in mind they're not very potent. They don't have much side effects, but they don't bring the blood glucose down too much. But you can give in these patients even on dialysis, and many patients respond fairly well. So what about the life change with the GLP-1, or life of the diabetologist changed with the GLP-1 and SGLT2, that's right? So GLP-1 and renal outcome trials. And here you have the Elixir leaders, several of these trials, all of them shows that you can decrease microalbuminuria, worsening of kidney function in favor of GLP-1. And you can improve by about 20 to 30% the progression of microalbuminuria. This is the result of the liraglutide trial, that's right. And this was a composite of renal outcome, double of serum creatinine, dialysis, and regression to microalbuminuria. You have a 20 to 30% reduction with liraglutide. And new onset persistent microalbuminuria, so going from micro to macroalbuminuria from less than 30 to more than 300 was prevented in 25% of the patients. Liraglutide in this trial was quite effective. But it's not only liraglutide. We have data with the once-a-week agents. In this case, it's dulaglutide. Here to the right is the progression to macroalbuminuria with doses, low dose, high doses of dulaglutide of 0.75 to 1.5%. Compares to glargine, much more effective. So insulin has been used now for 100 years. It's very effective in reducing blood glucose, but unfortunately it does not have a good effects on kidney prevention. By improving glycemic control, you may prevent complications, but a short term, like in this study of 52 weeks, you see that the GFR continues to decrease, compares to dulaglutide at low high dose, that with the slope of the decrease is much less. And insulin doesn't change albuminuria. Of course, dulaglutide has a beneficial effect. That was dula. What about semaglutide? A once-a-week medication is very effective in improving and decreasing cardiovascular complications. The same thing has been shown with nephropathy. And here you have that compares to placebo, semaglutide decreased the risk of nephropathy by about 30%. So no question that GLP-1 has a beneficial effect. So what about SGLT2s? A medication that, if you know, blocks absorption of glucose, so produce glycosuria, and sodium, so produce natriuresis. And because you produce glycosuria, you improve glycemic control, you lose weight, and because natriuresis, which you have decreased blood pressure, and other beneficial effects. So there have been several trials that have looked at both cardiovascular and renal kidney disease progression. And we have data now with all of them, with EMPA, with canagliflozin and dapagliflozin. There is ER2 gliflozin, but the data is not that beneficial with ER2. That we have impressive data with EMPA-REG in the empagliflozin, in the canvas with canagliflozin, and DAPA, the renal disease, DAPA kidney trials. In the EMPA-REG, the use of empagliflozin reduced the risk of worsening nephropathy, reduced the need, the new onset microalbuminuria for close to 40%. So, and this was on top of ACE inhibitors. This was on top of ACE inhibitors. So you add these agents on top of ACE inhibitors and you decrease the double serum creatinine or the first initiation of renal replacement or dialysis by 40 to 50%. This is with EMPA. What about CANVAS, canagliflozin? And you have the same, going from normal microalbuminuria and there's significant reduction in the amount of urinary albumin creatinine ratio. This is studies that were conducted up to 5 years. And if you look at the doubling of serum creatinine, the need for dialysis and cardiovascular renal death was decreased by 30%. So data on EMPA, data on CANA is very, very impressive. And if you look at the others, it's the same. That's right. All of them except Vertis with ER2 gliflozin have shown that you decrease double serum creatinine death for cardiovascular and renal costs by about 40 to 50%. Let me move now to more recent trials. And the reason why I bring this to your consideration, the Credence trial, is because they not only took patients who know nephropathy, but they included patients more than 30 years old with type 2 diabetes who already have nephropathy, already have diabetic kidney disease with a GFR between 30 to 90, so significantly reduced, and they already have proteinuria from 300 to 5 grams. And they were randomized to canagliflozin 100 milligrams or placebo. But this trial was stopped early because in the interim analysis shows a relative risk reduction of the primary outcome that we mentioned before by 30%. So impressive data, not only in those who do not have, but those with established cardiovascular and renal disease. And the second trial is the dapagliflozin. The study included 4,000 patients who already have nephropathy with a GFR of 25 to 75, who already have albuminuria, urinary albumin creatinine ratio between 200 and 5 grams, so nephrotic range proteinuria. And you'll see here in the primary outcome is the decline in GFR more than 50%, end-stage kidney disease or need for dialysis, and more impressive, reduction in death from renal or cardiovascular cause. So the data on SGLT2s is impressive, as well as the GLP-1, even more impressive. So these are the recommendations of the American Diabetes Standard of Care published in January of 2022. Anybody who has cardiovascular risk factor, anybody who has a GFR less than 60, you should consider using a GLP-1 receptor agonist, or you should consider using an SGLT2. Either one. If the patient has albuminuria, so with or without reduction on GFR, the patient is already an ACE inhibitor of ARB, you should consider adding an SGLT2s, because SGLT2s on top of ACE and ARBs reduce of proteinuria, reduce cardiovascular and renal death and need for dialysis. So let's go back to the standard of medical care. So first-line therapy for treatment of comorbidities, you have to talk to the patient about access. Metformin is the #1 agent for most people with diabetes who do not have advanced cardiovascular disease or risk factors, who do not have nephropathy. The ADA, for the first time ever, now is telling us that if you have a patient with cardiovascular disease, with established diabetic kidney disease, you are not obligated to start on metformin. We know that metformin is a great agent that has not proven cardiovascular or renal prevention therapy. A long-term, yes, but a short-term, no. So if I see a patient with heart failure, I start an SGLT2. If I'm seeing a patient with proteinuria, already first diagnosis, I treat the blood pressure, I put them on an SGLT2s. If the GFR is decreased, I will consider a GLP-1 and SGLT2 because these agents have been shown to improve and can be used with metformin together. They can be used with any drugs together. They can be used with insulin therapy. And this is the KD words, right? Diabetic kidney disease. And the recommendation of the nephrologist is the first line therapy. If the GFR is less than 45, less than 30 or dialysis, first you have to decrease the dose of metformin, as we mentioned before. If less than 45, you reduce the dose no more than 1 gram. If more than 30, you decrease, you discontinue. Dialysis, of course, discontinue. But you're going to add an SGLT2. If it's less than 30, you don't initiate. Now you can use up to 25 for DAPA and not on dialysis. And so if you have a patient with nephropathy, consider using an SGLT2 or a GLP-1 receptor agonist. If the problem is albuminuria, always an SGLT2. And our recommendation from the United States mirror the recommendations around the world. The European Association, the Kidney, the American Heart, they always suggest that in the presence of nephropathy, you have to consider an SGLT2s, you have to consider a GLP-1. So some important recommendations regarding dosing in patients with, according to the GFR. Canagliflozin, used in 3B, so this is GFR less than 45, 30 to 45. You should use no more than 100 milligrams. Stage 4, so 15 to 29, do not start Cana. And you may continue 100 milligrams. They don't have much effects on glucose, but they still have the cardio and renal protection effects. With dapagliflozin, we start on 10 milligrams. You can use up to 25. Empagliflozin, you don't need to adjust the dose, and you can use until the GFR is less than is 30 or above. So these agents now, at the beginning, we didn't use them 45. Now we can use them with a GFR of 30, and one of them even with 25. So this is a paper that we published just to guide primary care physicians. How do you adjust the dose of anti-diabetic therapy in patients who have, you start an SGLT2? So if you have a patient with hemoglobin A1C less than 8.5, if the patient is an SU, sulfonylurea, you should reduce the dose of sulfonylurea to prevent hypoglycemia. The same thing with the insulin dose. So you add an SGLT2 for cardio-renal protection, you reduce the dose. If you're more than 8.5, just continue this agent, that's right. And if you use metformin, go ahead. You have to be aware that GLP-1 and metformin both have a gastrointestinal adverse events, so you have to monitor these patients in that way. So let me finish up with this mineralocorticoid receptor antagonist, the new kid in the block on protection of kidney disease. And there are 2 papers that have been recently published in the New England Journal of Medicine, which is called Fidelio and Figaro. And they use mineralocorticoid receptor antagonist compared to placebo. These patients already have proteinuria, already have decreased GFR. They have diabetes, diabetic kidney disease, significant with proteinuria between 300 and 5 grams. And these studies show that the primary endpoint, that the need for dialysis or sustained reduction of GFR more than 40 was reduced by 20%. Here you have albuminuria, significant reduction in albuminuria. these are patients with diabetes and kidney disease. Now we're doing studies on patients non-diabetic with diabetic kidney disease if we can reproduce this data. Do have a 31% reduction of urinary albumin creatinine ratio after 4 months that is sustained after 3 years of the study period. And when you look at cardiovascular death, non-fatal myocardial infarction and stroke, you have a reduction as good as the SGLT2s, as good as the GLP-1 receptor antagonists. But the beauty of these receptor antagonist, mineralocorticoid receptor antagonist, that is independent of changes in blood pressure and independent of hemoglobin A1C therapy. So now we have medication that help us. And similar to the other mineralocorticoid receptor antagonists, like Dacton or Plerinone, the risk is hyperkalemia. So you have to check for hyperkalemia in this patient, which is present. However, severe hypokalemia is not very common. So let me review what are the most important points or take-home messages of this presentation. First, screen early. Most patients are asymptomatic, and you should screen with urinary albumin creatinine ratio or the blood test to calculate the GFR. A reduction less than 60 of GFR, the presence of
I think there is a problem with the recorded lecture towards the end. I think it was kind of overshot and something happened. I think we can come back and play the last part of that video a little later. I think
it was concluded, Dr. Arvind, but you know, the last 30 seconds somehow is not been recorded properly.
Yeah.
So it was concluded, but then we could not get the last 30-second part of it.
Okay.
So now you can start introducing.
We can recheck later and we can worry about it. And I welcome Dr. Des Shorts now, and then he's looking absolutely handsome. And then I have to give him a message that RCB did really well yesterday and they have won the match. So with a bit of luck, I think they can still qualify for the last 4. And next time around when you're in India, you're definitely going to see IPL. And Dr. Banshi Sabu can definitely promise you to take you to the IPL finals, which is happening at Ahmedabad. I think without wasting too much of time, can we have the introduction slide of Dr. Das, please? Amit, you can do the honors.
Thank you, sir, and welcome, Dr. Desmond. Dr. Desmond is Professor of Pediatrics, and he is a Medical Director of Diabetes Center, the GCRC at the University of Florida, and he is a past President of American Diabetes Association 2016, and he is the Interim Chair for the US College of Medicine Department of Pediatrics. So welcome, Dr. Desmond, and this is a very, very prestigious session where Diabetes India as well as the ADA are coming together and consecutively for the 3rd year for this very, very important session. So we welcome you all. We welcome you, and on behalf of our Dr. Banshi Sabu is also here for this session. So you can proceed with your presentation, sir.
I think I'll just add one. I think Dr. Des Shorts is probably the foremost, expert in type 1 diabetes, and he has spent all his life with the kids with type 1 diabetes, and is a very, very passionate speaker and researcher. And then I want all of India and those who are listening to him now to take a lot of learning lessons from him. Over to Des. Wonderful seeing you, sir.
Thank you. I'm going to share my screen right away. And let me see that this works. Can you see my screen?
Not yet, sir.
Not yet.
You have a share screen green button below.
Let me just look. I do want to get this right. Just get out of there. Can you see it? Let me try again. Yes. Can you see it now?
Now we can see.
Fantastic. Okay.
No, make it on full screen.
You can go to slideshow.
I have slideshow from beginning. Let me try one thing else.
Bottom right, you can go to the full screen mode.
Yeah, I've got a slideshow from beginning. Still not there. No.
I think you can bring it down.
It's the wrong. Just remind me how to change the screen. I think that's really what it is. It's got the wrong screen here.
Okay. Now you can come down where you have the slide sorter. Then you can go to the right extreme, and then you have a slideshow there.
Yeah, I've got that, and I do that, and that's what I get. Unfortunately,
no issue. What we can do is you unshare and again share it. That is the best way.
Let me try that again. Stop share. Share screen. Yes, no. Still not.
It's not in full screen, but we can still see the slides.
Let me try one more time. Stop share. Let me try one more thing here. Share screen. Let's try screen one. Is that good or no? Still not?
No, it's not there.
Right. What last time, and otherwise we'll get this thing going.
You share the screen. We are not able to see. Yes. Show the PowerPoint. Yes.
Yes.
Now it is done. Good.
Fantastic. Well, sorry for the delay, and thank you very much, Dr. Gupta. Thank you very much, Dr. Aravind. Hello to all my friends. And I'm sort of thinking here as I looked at the program, and classically, I think, Dr. Sabu, Banshee, you put me at the end of the program. Now, what does that mean to me? It means that either I'm waiting for all of you to go to dinner, or frankly, for all of you to get out of there so that you can go to bed. So I'm not exactly sure which one it is, but I'm reminded that as a cricket fan, it feels like I'm giving this talk with 9 wickets down, right? And what you're waiting for is the excitement of the 10th wicket so that we can wrap up a very successful day, for the conference. So again, it is a great pleasure for me to be here. And for those of you who know me, know that I like to be controversial. Controversial in the sense of challenging authority, challenging prevailing opinion, and really trying to understand why we haven't cured diabetes, type 1 diabetes yet. So what I'm going to talk to you about is lessons from the National Pancreatic Organ Donor Program. It's a program that we run here at the University of Florida. And I'm going to say to you, should we be rewriting the textbooks on how type 1 diabetes actually develops down the road? Because what I'm going to show you is some novel insights into the pathogenesis of type 1. And again, it is my whole intention to be a little controversial, and I do want you to perhaps think about some of the things. I will also say to you, for those of you who know me, this is a live discussion, and if anybody really feels they want to interrupt me at any time, please feel free to do that. Okay, so the first question is type 1 diabetes just another regular autoimmune disease? And I would say to you that it's not just a classical autoimmune disease like lupus or multiple sclerosis or Crohn's disease for that matter, but it's a disease that we have to think about as involving the beta cell, the whole pancreas, not just the beta cell, and also the immune system. And it's about the right time that we started thinking of it in that kind of way. And why is that? Because I think we've had limited success in preventing and reversing type 1 diabetes. And so the question for you is why? Because really, despite what you'll hear from some of my friends, we know so little about mechanism. We have about 500 ways that we can prevent or reverse diabetes in an NOD mouse, in an animal model. We've had limited success of immune interventions, and I ask the question, and I'll show you a couple of slides, is it the wrong approach, the wrong time, or the wrong combination? I've also given other talks at other times about the changing face of type 1 diabetes, and I will also say to you that type 1 diabetes is a heterogeneous disease, just as is type 2. And again, that's the subject of another talk. And children are not the same as adults, and it's not the same disease. But really, it's not through lack of trying. Look at some of the intervention studies that have been shown in the last 10 years. These are the, if you will, non-antigen specific studies. And it goes to the notion that type 1 diabetes is due to a breakdown of tolerance and immune-regulated disease. And we have everything, if you will, from antigen presentation to the MHC, to the activation of the immune system, to regulation, all the way through killing. And we've used really 80 non-antigen specific therapies, and really we've had no success at completely reversing. We do have some success at certainly preserving C-peptide for a couple of years. And again, that's the subject of another talk. And these are perhaps some of the antigen-specific trials that have been conducted, and they started off with Diapep, and they've gone through various forms of insulin, which has been given orally, nasally, subcutaneously, and then with glutamic acid decarboxylase and other potential autoantigens, and to this point in time, we're unable to prevent or reverse the disease with antigens. So it's not like we've been doing nothing, we certainly have tried. So the question is, do we have it wrong? You know, the prevailing sentiment is type 1 diabetes results from a classical autoimmune TCL-mediated destruction of insulin-producing pancreatic beta cells. And this goes back to really insulitis, which was really described in 1902. There were, in the early 70s, there were MHC associations, and then all islet autoantibodies were really discovered by Franco Batazzo and others in 75, and antibodies have really been instrumental in our both definition and prediction of type 1 diabetes. And this is what we have thought, is that type 1 develops when almost all beta cells are gone. And there's a genetic predisposition, beta cell mass falls over time, and when you lose all your beta cells, we think that's when you get diabetes. I'll tell you right up front that that's wrong. A lot of people still have beta cells at diagnosis and even several years afterwards. So the question is, why? And so what we have done is, because the good Lord put the pancreas in such a strange position that it's so inaccessible to really getting to it easily. And, you know, there are some organs, such as the skin, that may want to be touched. The pancreas and certainly islets do not want to be touched, and you touch them and you can get a pseudocyst, or you can get really acute pancreatitis. So it's very difficult in vivo to look at the pancreas. So we created, really under the direction of Mark Atkinson, my friend and colleague, created the NPOD, the National Pancreatic Organ Donor Program, which collects transplant-grade tissues from people who have died of diabetes and other diseases. And as of last year, 2021, there were over 500 organ donors within the pancreas, and which included 180 people with type 1 diabetes, and another just 50 or so that were autoantibody positive, that we think were at risk, although you could never tell because obviously they died or destined to develop type 1 diabetes, which allowed us to gain some insight into what may be going on within the pancreas. So I'm going to try and walk you through some hypotheses and things that we think we know, or some things that we don't know. So lesson number 1. Type 1 diabetes is characterized by immune infiltration of the pancreatic islets. So is that true? And the answer to that is true, that insulitis is in fact documented, and we can document it now scientifically. And if there are greater than 15 CD45 positive, those are CD5 positive cells within the islet at the time of diagnosis, then in fact using at least 3 islets, which could be in the head, body, or tail of the pancreas, that confirms that there's insulitis. But again, I want to tell you, is insulitis the cause, or is this an effect of what's happening within the pancreas? Let me leave you with that interesting notion, because I will tell you that there are many different kinds of islets in type 1 diabetes. And if you just look at my marker, you've got insulin positive islets, but they don't have insulitis. There are also insulin positive islets with insulitis. And then there are what's called pseudoatrophic islets that stain for insulin, but look very different. And there's some fibrosis that's occurring. But, they're stain positive for dividing cells, which is Ki67. So again, you see different islets, certainly within a pancreas. And not only within the pancreas of those that are different, but you see different kinds of insulitis. And why are some islets with insulitis different from others? Here's a 12-year-old donor at onset. And the only point that I want to make from this slide is that if you look at B cells, which is CD20, you look at T cells, which is CD3, and you look at glucagon, which is sort of stained in the yellow, you see differences. These are all one person, but some islets have a lot of T cells, some have B cells, and some have no insulitis and a lot of glucagon. So again, this should tell us something, that there's different things that are happening. And again, is this primary or is this secondary? This is just an example from P. Elite and others that was published, and just simply shows you that there is a difference between younger patients and older patients. And on the left-hand side is what's happening within the islets themselves, and on the right-hand side is what's happening in the periphery. And if you look at kids under the age of 12, really you see a predominance of CD20 cells. And that's both within the islets as well as in the periphery. So it seems that B cell predominance occurs early. And then when you look at older patients, there is really no difference. You sort of look at the B cells in older patients and they really aren't increased. So that may tell us that there may be something different about the diagnosis in younger patients, which I will tell you as a pediatrician, there certainly is a difference. So it gets back to a beautiful picture, which says to you as clinicians, you've got one face, but is type 1 diabetes just one disease? And what is the role of autoimmunity? Let me give you lesson number 2. I didn't solve that for you, but I'm hopefully making you think. It's a disease of islets and beta cells too. And I will tell you that beta cells are not passive participants in this evolution of type 1 diabetes. Now, let me sort of summarize the difference, that there is endoplasmic reticulum stress, mitochondrial dysfunction. There are, if we understand the synthesis of insulin, which I'm sure has been talked about in other talks, we know that insulin is synthesized as a pre-proinsulin, then gets to proinsulin, then is converted into insulin C-peptide, and some of these extra vesicles which release insulin have autoantigens and microRNAs that have been linked to immune activation. There's acquisition of a senescence-associated secretory phenotype. There are new antigens, and we know that people with type 1 have increased MHC class 1 upregulation. So type 1 diabetes does not occur only when 80 to 90% of beta cells are gone. And here's some data from Diamond et al., and they looked at single-cell analyses from NPOD for islet hormones and looked at non-diabetic, recent onset, and long duration patients, and looked in red at insulin, orange at glucagon, blue in somatostatin, and look at onset. There are lots of people who have insulin that are present at diagnosis. I will also tell you, as part of another talk, that many people who've had diabetes, who particularly diagnosed at an older time, have many really insulin-positive cells. And diabetes can occur with as little as 50% loss of functional beta cells. So there are multiple factors that trigger stress within beta cells. And again, this just tells you about, what I think is many causes of diabetes, because we know that ER stress, which is definitely found in type 1 diabetes, can be triggered by long-chain fatty acids. And we actually have some very interesting data that suggests that maybe long-chain fatty acid, free radical oxygen may actually be found well before the presence of autoantibodies. But viral infections, cytokines can all contribute to ER stress, which leads to unfolded protein responses, and that can lead to cell death itself. So you may not need the autoimmunity. And here are just a couple of examples of endoplasmic reticulum stress markers in islets of patients with type 1 diabetes that indicate increased islet stress. And what you see in this particular slide, you see is antibodies against ER stress markers, the homologous protein CHOP, the immunoglobulin heavily chain BIP, and XBOX binding protein XBP1 in the islets themselves. And what you can see is that islets from individuals with type 1 diabetes have increased levels here shown of CHOP, and at least for insulitis, positive and beta cell containing islet cells, BIP, as well. If we look at the next slide, what you see is defects in the expression of unfolded protein response. That's what's called UPR. And these are the mediators, ATF6, activating transcription factor 6, and XBP1, which is the XBOX binding protein in beta cells. So you clearly see a dysregulated expression in these patients. Now, is beta cell replication themselves and number important in type 1 diabetes? Well, it should be. Here are some data from Peter Butler, and sort of looks at adult beta cell mass and looks across the years. And if you think that we all have the same beta cell mass, well, you'll be very wrong in that thought. Look at beta cell mass in grams in some people, very, very high, and in others, this is very, very low. Well, does it matter where you start off with to develop type 1 diabetes? And I certainly do believe that it does, which goes back to some very interesting data from Chris Rhodes, and really looks at beta cell formation and looked at islets and beta cells from early in life to later in life. And what you can clearly see is that the percentage of insulin-positive cells early on in life is very, very low, and there's a dramatic increase in the first 2 years of life, which is very interesting because we do know that there are insults to the islets from Teddy that are occurring in the first 2 years of life, and this may be at its most vulnerable when in fact these cells are indeed developing, and then they decrease over time till adolescence, and then you don't really increase your beta cell mass thereafterwards. And sometimes these beta cells can escape destruction. And these are just some cells in people who've had diabetes for several years, in this case for 18 years, and you still see insulin positive cells within the islets themselves. And beta cells can persist in long-standing type 1 diabetes. And here's some data from both Keenan as well as Susan Bonaware, in which 44 out of 47 of the medalists that have had diabetes for over 50 years actually have identifiable beta cells. They may not be within the islet. And that's a very interesting scenario in itself. And these are data from Clive Wasserfall and others who show that there are insulin positive cells outside of the islet, but are still indeed positive. And this is really Clive's data that was published in Cell Metabolism and looked at the persistence of pancreatic insulin mRNA expression and the proinsulin protein in type 1 diabetes pancreata. And what, again, you can see is that there is, when you sort of look at insulin, and you sort of look at this across the board in both controls, antibody positives, and type 1, yes, they're less. But again, pancreatic islets, even in patients with flagrant and long-standing type 1 diabetes, retain the ability to produce proinsulin, which again brings in a question: is there a defect in that conversion of proinsulin to the active form of insulin? Lesson 4. Type 1 diabetes is a disease of the whole pancreas, not just the beta cells. This was an initial observation from Martha Campbell Thompson, really early on in 2012, where she took just a few patients and made the observation that when they looked at the pancreas weight of organ donors, was that patients with type 1 diabetes, which is shown here, were smaller, had a smaller weight than those patients who had no diabetes and were controls. Now that you think about it, that islet cells per se comprise 1 to 3% of all the pancreas. So why, if it's just the islet cells, should the pancreas be smaller in weight? But it is. And here is some data that was published by our group and looked at the pancreas weight in a bigger group of type 1 patients and compared them to controls. And I do want to tell you there's a difference, by the way, in the islets, that there are ironically more islets in the tail of the pancreas, by the way, than the body and the head of the pancreas. But when you look at patients with type 1 diabetes, there's a significant decrease in the weight of the tail of the pancreas, as well as the body and the head, but mostly in the tail. But look at type 2 diabetes compared to controls. The head is higher, the body also higher, and then the tail about the same. So there's a difference. And when we look at this with age, you can clearly see that if this is the control here in the black line, and this is the patients here in the gray line, you can clearly see that there's a big difference at all ages in the weight of the pancreas. That's from NPOD, but we've taken it to another level. This is really with Mike Heller and Martha Campbell Thompson, where we've really looked at patients with recent onset diabetes, which is shown here in the blue, as well as in controls over there. And this is what we did. We did MRI of patients who were at risk for diabetes. And these are relatives. And we looked at antibody negative relatives, which are here in purple. We looked at antibody positive patients, single antibody positives, which is here in the light blue. And then in the turquoise or very light blue, multiple antibody positives. And what you can actually see is that there was a decrease in the pancreatic volume in living subjects in recent onset patients. A provocative hypothesis is that even in relatives, they may have a smaller patient or a smaller mass, pancreatic mass to begin with, which obviously then puts them at risk, because we know that in relatives, the risk of developing diabetes is about 1 in 20 compared to the general population of 1 in 300. But we know that it's not only endocrine function, certainly in beta cells. There certainly is evidence that there may be some alpha cell dysfunction too, and I know that's subject of other talks. But we also do know that there is also a slight decrease in the enzyme trypsinogen when measured in patients with type 1 diabetes. These are controls, and these are new onset and established diabetes. And you can see that the trypsinogen levels are slightly decreased. When I say slightly decreased, it's very interesting because if you, let's say, you take a level, it's certainly enough to get along with people who don't have exocrine insufficiency. But clearly in patients with type 1 diabetes, they're decreased, which then suggests that the exocrine pancreas must have some bearing on beta cell signaling and beta cell functioning. If we look at lipase and amylase, which are other parts of the exocrine secretion, and we look at amylase, which is shown here, and we look at lipase, which is shown here, and then you measure it against age. And if we look at the controls, this is really what I want you to do, because it's like growth in children. You've got to look at establishing, let's say, a median and then 1 and 2 standard deviations. Look at what you see for controls for lipase, and that's shown here in the blue. And let's look at the same thing in patients with type 1 diabetes. They may be within normal per se, but if you look at the levels, they certainly are below for both lipase especially, and also for serum amylase as well. So again, that calls into question the role of the exocrine pancreas. Several years ago, with one of our students, Patrick Rao, we looked at complement activation in human type 1 diabetes. And what we found, again, was that the pancreas itself is abnormal in the sense that complement is laid down within the pancreas, again, not just on islet cells, but within the particularly the interconnecting acinar tissue. So in summary, as I sort of wound down this talk, and we will say that is type 1 a classical autoimmune disease with immune infiltration of the pancreatic islets? I would say we clearly do see immune infiltration of the pancreatic islets. I will say to you that it is a disease of beta cells, that they're inherently abnormal, that we need to understand what is per se going on within the beta cells themselves, that beta cell mass and number are very important in the development of type 1 diabetes, that in type 1 diabetes, the disease affects the whole pancreas. And that is so crucial, because where does that take us? It takes us to understanding or to revisiting an older concept of Gianfranco Battazzo, really from the late 80s, and to really ask the question, is this a homicide or a suicide of the beta cells? Because if it's a murder, that's clearly an autoimmune attack. Maybe an immune-mediated attack too. But what is it per se if the islets themselves, if the islets per se are contributing to their demise? And that's why we're seeing that immune suppressive agents will not in any way affect the disease for a prolonged period of time. So with that, I really want to thank the rest of my group, Mark Atkinson, Clive Wassel, Mike Heller, and so many others, all the NPOD scientists, the staff, our funding agencies, the JDRF, all the organ donors, and their families, because it really takes a village to try and understand type 1 diabetes. It's crucial that we take the next step. We haven't cured type 1 diabetes yet, but we're asking some very difficult questions, which I think will need to be resolved over the next few years. And this is an exciting time, really, for all of you to ask questions. It's an exciting time for all of you to get involved in type 1 diabetes, because once we do find out where it is, you will change the lives of so many people. So with that, I think I'm certainly within the time slot that you allocated me. And I want to thank you for inviting me again to this really exciting conference, of Diabetes India, and the opportunity to present to you today. So thank you very much.
Thank you, Des. I think, you remind me of some of our teachers from college and school who would give a brilliant lecture, who would teach us all, and then finally write down several questions and say, go back home and try to answer these questions. Okay, so you have made us think, you have left behind several questions. How does it now affect the treatment of type 1 diabetes? Now, how does this now change the treatment?
So right now, it's a great question, as always. And usually when Aravind asks me a question, I can't answer it because it doesn't right now. I think this is, insulin is not a cure. Insulin will never be a cure for type 1 diabetes. Despite what other people will tell you. Yes, and you've heard about hybrid closed loop systems, and hybrid closed loop systems and have really changed the way we manage type 1 diabetes, and improves their lives dramatically. And these are data that have emerged really within the past couple of years. But again, I want to say that insulin is not a cure, and this doesn't make it that much easier for patients, certainly with us trying to find that cure. But I would say to you that we need to, again, continue to understand the mechanism, continue to find out what we can do in really getting pro-insulin, which I'll tell you is present. And it's a great collaboration I have with Yuval Dor, where he finds pro-insulin in patients who have islet cells with diabetes for several years, but we can't get that translated into functional insulin. So once we can find out what that abnormality is and get this insulin working and activated again and stop the immune process, then I think we will have a therapy. I don't think there's anything now in terms of immunomodulation that we can do other than prolong a honeymoon. So we do see patients at the University of Florida. There are other institutions around the world that are giving, for example, in a comfortable and a safe setting, anti-thymocyte globulin to new onset patients who have classical type 1 with the goal, depending on the circumstances, of prolonging the honeymoon period. And I will tell you that it works. I can't tell you what its long-term effects. I mean, here you had Guillermo Perez talking about the DCCT and EDIC and memory and what it may mean to complications 25 years down the road. I can't tell you what that is going to be in terms of long-term effects on down the road. But I will tell you, if it does make it easier for families and the risk and the benefits are taken into consideration and can be done in an institution that can do it, that an immune intervention such as anti-thymocyte globulin does prolong the honeymoon for at least a couple of years. And it's really good to see my friends standing behind you. I wish we were present together.
He was in another hall and he finished, and then he came running here.
That's fantastic. I miss that so much. Yes.
Yeah, miss meeting you physically shortly.
Okay. Are there any other questions, Amit? Any other questions that has come
right
online
now,
to you?
We don't have any other question, but Dr. Desmond, your talk was really very stimulating. It has all of us has it has really given us a lot of things to actually ponder upon and think upon. And this year, the theme of the conference is 100 years of insulin. And maybe now it is time to look beyond the insulin also, as you have pointed out, that insulin is not the treatment for type 1 diabetes. And your research definitely adds to what is currently known and what we can expect in the future. Obviously, the immunotherapy is something which we are looking for as a treatment for the people with type 1 diabetes. So just a comment, sir, nothing else. And your talk was really excellent. Thank you.
Well, Amit, Dr. Gupta, thank you so much. And it's really good to see really all of you here tonight. And, hopefully, as I said, that 9th wicket, was successful either way. And that, Royal Challengers Bangalore move on.
Thank you so very much. Have a great day, Des. And then
thank you.
We all know we have a couple of more sessions. It's not the 9th wicket. This was only the 3rd wicket. And we'll have some more sessions going on till about 10 o'clock. And have a great day, Des. And hello to the family.
To you too. Thank you very much. Bye, guys.
Thank you. Thank you. Now, Jimit, we hand it.
Thank you so much, Dr. Amit and Dr. Arvind, for the wonderful ADA symposium. And I would like to thank all the speakers of this hall from morning to night. We have seen a wonderful academic feast, and I'm sure all the delegates who have joined here and in the other platforms also, they have enjoyed today's scientific agenda very well. And I thank the RX Events team for wonderfully handling the technical part. And I thank again all the chairpersons, all the faculty who have joined tonight and to make this virtual session very, very successful today. And I would like to also invite all of you to join tomorrow. Physically, we are meeting tomorrow morning. And after many years, we are meeting physically. So I'm very excited to invite all of you for tomorrow's physical session at Grand Hyatt, Goa. Thank you, everyone. Thank you. Good night.
Thank you. Thank you. Bye-bye. Thank you.